Today we're going to start our CME on upper extremity. Our faculty members include Dr. Dwayne Anderson. I hope most of you know him. He has been serving in Ethiopia for 18 years and he had a huge impact on orthopedic practice in Ethiopia. And he is a great mentor, educator, and an excellent clinician. He always pushes us to be an excellent surgeon. And among the few phrases he knows in Amharic is "Makakalenya alfalak." And our another faculty is Dr. Vic Papandrea. He was an upper extremity surgeon for the last 25 years. So please welcome him and he'll be with us. Our third faculty is the medical director at CURE and Orthopedics program director. And we know everybody knows him, he's pediatric orthopedic surgeon at CURE. So I'll give the mic to Dr. Galatao to open our CME.
Good morning, everyone. Thank you, Sami. Just I'm here to say some words. Otherwise, it's very hard to speak a lot in front of your mentor. You know, really proud mentor. Like I'm proud of him. Like all the time in my OR time, like I'm speaking about him. So this is upper extremity course. It's organized by the CURE, so Dr. Christian Hospital and ESOT together. So this is a big topic and it's very precious. And I want to say thank you very much for the organization and to give this talk for our fellow surgeons and final residents. So in most of our hospitals, we don't have upper extremity specialists. So this is it's a high-class lecture. If it was prepared in other parts of the world, I know how people are just rushed to register and to pay for the course. But in our setup, it's very difficult because like most of the time we don't know what it is, what it means. Like maybe like if I show a cake for a farmer, he may not be interested like that. But if people from around Gole or somewhere, they may rush to hit that one. So thank you very much for that. Like you know, Ethiopian orthopedics, it is a young one. That's why we see a lot of young orthopedic surgeons. I want to say some few words on that. Like while I was a resident, like more than 80% of patients were treated non-operative, almost 80%. And that was a dark age. It was very tough time for Ethiopian injury people. So surgical wise, like there was a lot of mentors coming from abroad, but they were not like happy by the practice. And no one is interested to reject. Not from that. It's from dermatology, from psychiatry. Like for, imagine how disgusting, how shameful to be an orthopedic surgeon. So history is changing. We join and we start to have detachment program. I noticed how the life was changed while I was in attachment to CURE and surgery. So what I learned from that is like while I was in Sordo, Dr. Anderson, like he's different guy. He's not a surgeon sometimes. Like surgeon is selfish. Personally, I say I'm selfish. You know, I'm not happy to give the blade for someone. He gives you the blade, the knife, and he allows you to cut. Immediately when you are not in a way, he took the knife and he showed you, do this way. This way is the black line way. And he gives it to you back. We didn't do that one for our residents, unfortunately. So he did like that. And I came back from Sordo, everything was like different for me. The learning, the attitude, everything. And I asked my mentors in Blackline to present some lectures. By the way, I'll share you that lecture in Blackline, what I presented in Blackline, just immediately after I came back. So I want to present the lecture, what is experience in Sordo. And I posted the PowerPoints, and my mentors in Blackline, they were like shouting on me. What? Is he doing like this? This is crazy. He has to stop this, everything, in every slide. They were shouting. Their eye is changed like through the time. Because that is new for them. How people are fixing that way, the other way. How open fracture is fixed like this way. That was the breaking moment for some of my resident colleagues. So they were shouting, and to the extent, we have to accuse him. Like, we'll take him to the court, some of them. That was the moment. That was the moment, because it is new idea. But that is a practice, and that should be followed. That will have to be followed. And it was. Then next time, after attachment, I came back and I present what is a stabulum, what are the lines. Before that, until I reached to third year resident, we don't know what it is as a stabular fracture. Just I went to Sordo and I operated in 4 cases. The fifth one, it was posterior wall stabular fracture. He allowed me to operate by myself. It was a big courage for me, how the fifth one is given to the 4th year resident. Then I came back and I presented, this is a line, this is what is the diagnosis, this is post-colonal, this is a, what, is this something like this? Yeah, it is. So everything is changing. So Duane he's the father of orthopedics in Ethiopia, without anything. So he changed it. So now every patient is happy because of his hand. And the second is like the cure. We don't know how people are treated, especially the kids. Still, I'm not happy the kids how are handled in everywhere. Still, we need to do more. So the first attachment with Teddy at that time, so he gives me to do foot amputation, finger amputation, I think. So just I was rushing to cut it. He told him, oh, there is a nerve here. How I'm worried about a single nerve in the digits, in the foot, later. So that was the mentorship. So cure and Christian Sordo Hospital is like, it has a big impact to change Ethiopian orthopedics. Thank you very much for your contribution. So by saying this, ESOT will work with different institutes and with different surgeons. So we are glad to have this type of course in our country. Hopefully this 2 days course will be impactful in our practice. Please follow our mentors. Thank you very much.
Salam, good morning. Thank you, That was a great introduction. Samson put this together, and I'll have a little introduction in a second. So thank you for having me and spending time with us today to talk about upper extremity issues. So as Samson mentioned, I've been in practice for about 25 years. My practice is in Wisconsin, in the middle part of the U.S., and I practiced on a large group of orthopedic surgeons. I did a residency in Cleveland, Ohio, with 2 very busy upper extremity surgeons who are mentors to me, and as we just heard, mentorship is so important. We learn from those who've gone before us. They instruct us to become great surgeons and great physicians, and I had 2 really, really good mentors in Ohio. I did a fellowship at Harvard in hand and upper extremity, and then a shoulder and elbow fellowship in Mayo. And then that was my connection to Ethiopia. Dr. Sean, who many of you have met, brought me here in 2020, and maybe some of you, we may have met. I'm sorry if I don't remember everybody, but I was here in 2020 on my first trip to Ethiopia to come to Addis, and we spent a couple days here and did a course, and then down to Soto and to work with Duane and some of the residents that are here now. We met back then, and I've been back. Smartphones in the hospital here, we come to Africa, and certainly there are things that maybe haven't gotten to the level of other places in the world, but the advantage for you in Ethiopia is you can jump over some of the things that we've done in other places. And so when I grew up, I had a landline telephone. We had to walk to the wall and pull it off the wall and dial a number, and we didn't have call waiting, and we didn't have anything. And that's, if you wanted to use the phone and someone else was using the phone, you had to wait. And if you weren't home, nobody could get a hold of you. You've skipped all over that. You've skipped over, and now you have smartphones, and you have all the things that everybody else has in the rest of the world. And I think orthopedics is doing that too. So you're going to leapfrog and learn the things that we've learned, and through this, through the educational process and people visiting, and you going out on the internet and finding good sources and talking to people and working with people, you're going to, Dr. Tim and Dr. Dwayne and others will take orthopedics and take it from that level, which we just heard, and it was the same in the U.S. in the 40s and 50s. Orthopedics was not a specialty people wanted to go into. It's where the not so smart doctors went. The joke was they were as strong as an ox and half as smart. That's what an orthopedic surgeon was in the 40s and 50s. Total Joints changed that, and all these people who were passionate about making people better, getting people walking or moving or using their limbs and being out of pain, that passion grew, and then the technology, of course, brought it up. But it was the intellect that everybody here has, and that passion everybody here has. So hopefully today we can go through some things in upper extremity. Obviously that's what I do, it's what I'm passionate about. I like to call it the superior extremity, as inferior and superior. But no, seriously, I mean, find what you're passionate about and try to dig into it. I think it's good for orthopedic surgeons to have, even those who go out and maybe have just a general practice, find something you're passionate about to try to really dig in and be a local resource, a local expert, something you can really own. And for me, that was the elbow. I wanted to really understand complex pathologies and instability, and then everything else flows kind of from that for me. But I like hand surgery and shoulder surgery too. So Samson gave me a lot of things to do. I was up a little bit last night trying to put some talks together, finish some things, so hopefully I can instruct some of you today. I thought, Samson, if it's okay, we'll give talks, and if there's time to do questions and answers as we go. And I don't mind if a hand goes up and asks me to explain something, or maybe you have a question, there's a thought you just want to complete right then and there. I don't mind that. So please interrupt if you want to. So I've got 2 talks in a row. I've got instability, and then I have rotator cuff pathology, and I have about an hour to do it. So I'm going to just go and again, stop me if you'd like. The first talk Samson gave me was instability. And so we think about, when we hear that, we think about usually shoulder glenohumeral dislocations. And I'll talk a little bit about separation. I hid the slides on separation. So I'm not really going to talk about separation much. AC separations, if somebody wants to go in that, we can dig out those slides and unhide them. But I want to talk more about glenohumeral dislocations. And of course here, we see a lot of chronic dislocations. I'm going to talk a little, Dwayne's got a talk on chronic shoulder dislocations. And that's my first operation here in Ethiopia. Dwayne said, how many chronic shoulder dislocations have you taken care of? Now you have to remember, I'm 20 years in practice, and 0, right? And so Dwayne taught me that operation, so we'll hear from him later this morning on that. An acronym, an abbreviation almost, that I was taught in residency, which I think has some applications still, is this TUBS versus Ambry, and kind of dividing shoulder instability into 2 very broad general classes. But it's a way to at least think about kind of when the patient comes in and starts to talk to you about a shoulder that's come out of socket, a way to categorize it. And like everything in medicine, there's a spectrum. It's not necessary that something fits exactly into these categories, but it's helpful to think about them. So we'll use these, or at least mention them. TUBS is a traumatic injury. So that's a history. The patient will tell us something happened. They fell, they slipped, the shoulder popped out. It's unidirectional, usually. It's usually anterior, sometimes posterior. Pathologically, there's a Bankart lesion, and then a lot of times surgery is offered for that, especially when it's a younger patient where there's a higher incidence of recurrence. Ambry is different. It's atraumatic. It's the patient may just say, well, I was dancing and my shoulder popped out, or I reached for something and then my shoulder popped out, or it pops out all the time. I never had an injury. It's multi-directional. The shoulder is loose in all directions. And because of the base pathology of that often is a ligamentous laxity. And because of that, it's usually both shoulders. So the patient might come in for the right, you talk about their left, and they say, oh, it's bad. It's just not as bad as the one I'm here for today. These problems can typically be rehabilitated. That's the first line treatment. And then if rehabilitation fails and it's significant, there's not a soft tissue lesion of a Bankart lesion. It's a stretched out capsule, so it needs to be tightened or shifted if surgery is going to be the plan. So why is the shoulder so unstable? Well, it's because it moves so well. It's a very, very shallow socket. And I know golf's not a big game here. I'm not a golfer myself, but I like that golf picture there of the golf ball and the tee. And while the ball and socket aren't quite that much of a mismatch, in a shoulder, we can think about that golf tee. If there's a chip or there's some bone or plastic removed from that golf tee, the ball's not going to sit on that. And so our shoulder blade moves a lot, and a lot of times when we're doing things, our shoulder blade is balancing that socket under the ball, under our humeral head. But if we're missing some bone, it can really make a big, big difference. Instability, then again, the dislocation itself, if it comes out all the way, if the ball rolls off the socket, that can typically be anterior, but it can be posterior, and even rarely with something called luxatio erecta, where it's inferior. The patient will come into the emergency room with their arm over their head and the ball straight down. Have you seen that, Dwayne?
Never.
I haven't either. Yeah, it's very rare. So our muscles do give a dynamic support to hold the shoulder in the socket. The rotator cuff muscles are the most important, but they can only do so much. They fatigue, and they don't have the ability to hold a very unstable ball in the socket. The ligaments are more important for stability. They're static control, yet they're loose enough to allow for a full range of motion that we have in a normal shoulder. The ligaments are the thickening of the capsule, and if we do a dissection, it was always hard for me as a resident to try to understand where the ligaments were. And they're part of surgically, even in a patient, we can't always separate the two, especially as we're lateral. A little technical tip, if you're trying to separate it, go a little bit more medial. Usually you can find some separation between the capsule and the rotator cuff. But the rotator cuff and the capsule are really, really tightly bonded together. The Bankart lesion is a hallmark feature, and again, anterior inferior is typical. When we see a shoulder dislocation, it's not always as obvious as the x-ray you see here on the right. This is a typical dislocation x-ray, most likely anterior inferior. Sometimes it's more subtle, so if we're not sure if things don't look right, we need to get a good axillary view. There's something called a Valpo. That's where we put a plate on the table and we have the patient lean back, and then they can shoot down from above and get a reasonable axillary view to look for that anterior or posterior. And if you have access to a CT scan, and again, things don't look real right on an x-ray, and this is usually a posterior dislocation, it can look, initial look at the x-ray, it looks okay. It's not like this x-ray we see here, but it doesn't look quite right. The lines aren't all symmetric. There's a little bit of overlap with the glenoid and the humeral head. Get a CT, and that's how we can see a posterior dislocation for sure. The Bankart lesion, that is the hallmark of this Tubbs pathology. It's a tear of the capsule, and that pulls off the labrum like we see here on the upper right. That MRI most likely is an arthrogram. Dye's been put in. Sometimes there's enough effusion in the joint to allow us to see this clearly. This is not always seen even on a good MRI, even on a high quality 1.5 Tesla MRI. We don't always see pathology this clearly. This is a posterior lesion, so on the MRI, the subscaps in the front, we can see that the bicipital groove, and the labrum in the back is torn. There's a fluid around there, so it's a posterior or a reverse Bankart lesion on that glenoid there. The Bankart lesions, they're intra-articular lesions like an ACL. They don't heal. Things are moving. There's joint fluid around, and that's why the Bankart typically doesn't heal in an anatomic position. For a while there was some talk about positioning patients in a certain direction to get the tissue to kind of stick in place and have it heal. The studies that have been done show that doesn't really make a difference. So when we have a tear, when we have a dislocation, the tissue doesn't heal back down, and that leads to recurrences, which we'll see about in a second. This anterior dislocation is usually the abduction, extension, and external rotation. And then once it happens, it's usually recurrent. The age at first dislocation is very important for recurrence. Posterior dislocation is a little different. It's that posterior direction that push the shoulder out. It's a fall on an outstretched arm if it's a traumatic issue. In American football, the big linemen who push real hard have tears in the back. They usually don't dislocate, but they'll tear and become unstable. It's also common in seizure disorders. So if somebody has a seizure, or even with electrocution, as the muscles contract, most likely because of the size of the subscapularis, it will push the shoulder out the back, and we can have instability or even dislocations. Those are the patients we have to watch for a locked posterior dislocation. If you see somebody in the emergency department or even in clinic and they have had a seizure and they have a lot of shoulder pain, the x-ray doesn't look quite normal, get a CAT scan if you can, or MRI. Usually CAT scan's better to look at the bone and see if they have a locked posterior dislocation. In some of the studies, and these aren't that old of studies, the time to diagnose a locked posterior shoulder dislocation, and this is in Ethiopia, this is the rest of the world, it's over a year. So these are missed injuries. It's a little bit older literature, but there's some easy to miss because it's not as obvious as that anterior inferior. So if we see somebody, take the history. Again, a fall is one thing, but a seizure, electrocution, think about posterior shoulder instability and really scrutinize those x-rays. The initial and surgical treatment principles are really the same if it's posterior or anterior. There's probably a little bit more tolerance for a dislocation that's out the back, that's reduced, than the patient rehabs. If they're not a lineman in American football, if they're not doing a lot of pushing, often they won't come back out in the back. If it's seizure related, if their seizures are controlled, they usually stay stable. So the initial treatment for a shoulder dislocation is, of course, to put it back in, to reduce it, and then to immobilize it, as I already mentioned. The position probably doesn't matter. There's pretty good studies that show that how long we immobilize and what position we immobilize doesn't seem to matter, especially for anterior inferior. So I allow patients to start to move progressively, start to use their arm for light activities to avoid any abduction, external rotation for at least about 6 weeks. And then they start to strengthen when they feel better. And they can go back to doing kind of everyday things when their strength is back and their motion is back. In some sports, especially contact sports, we'll consider using a brace that we call a Sully brace, which is kind of a flexible sleeve that's put on with straps, but it limits the motion. Really all it does is prevents the patient from getting in that position where they might have some instability. Reduction maneuvers, there's different maneuvers. A Coker is seen here on the left. Stimson is when we hang a weight off the bed and the patient's prone, lying there, awake. The Stimson actually works pretty well if you're busy in the emergency department or you can't get to somebody and there's somebody who can help you, maybe a more junior resident. Having a patient lie prone, get some weight, they can't be holding it, they're not going to relax, and just let their arm fatigue with about 10, well, probably about 5 kilos, I'd say 10 pounds, and just let them relax. That will often reduce the shoulder pretty atraumatically. So if you're busy and you can't get to somebody, it's something you can kind of tell them to relax, and usually by the time you get to them, 20, 30 minutes later, they'll be reduced. There's the traction, counter traction method, seen down here on the left, which works well, but to people, if you're not careful, it can be a bit traumatic. The patients will fight you if they're awake and not sedated. So I typically will do, if it's acute and if I'm on the field and I see an athlete, I'll do a Coker maneuver and gently tell them to relax and bring them out, and usually put my hand up in their axilla and push back on the head and feel it if they're thin enough, and bring them down in an internal rotation with their arm on their belly. Otherwise, if they walk into my office and they're dislocated, we'll do a Stimson maneuver, and that works pretty well. So I mentioned before the recurrence rate is age-related, and when we look at the literature, it's pretty impressive how frequent it happens again when somebody's young. So again, typical anterior shoulder dislocation when someone's less than 20, depending on the age and the literature we're looking at, it's a 70 to 100% redislocation rate. So when we see a 15-year-old kid who's dislocated, maybe they're playing real football, as Samson says, and they slip and fall and dislocate, they're going to probably have problems again. And so it's not an unreasonable thing to talk to them about that at that point in time. And there is now a little bit of a growing movement to fix people that are really young pretty early and fix that Banker lesion to hopefully prevent them from redislocating. As we get older, the dislocation rate drops, and older yet, past 40, the rotator cuff tear incidence increases. So we'll talk about rotator cuff tears next. But when we see someone over 40, there's up to an 86% chance of a rotator cuff tear. So when I see a first-time dislocator in their 30s, usually I'll talk to them about the fact that if they rehab it, they'll do okay. If they examine well, when I see them back at 6 weeks, they're strong, I'll just follow them along clinically. But if somebody hits 40, I'll start to think about imaging their rotator cuff with a first-time dislocation and look for a rotator cuff injury. It's certainly 50. And then unfortunately, as we get even older yet, in the 70s, people often have an asymptomatic cuff tear, or maybe it's symptomatic, but then they'll fall and dislocate and they tear some more. Those people can be really unstable just from that rotator cuff pathology. The redislocation rate in the greater than 50 is pretty low, less than 25%, relative to, it's still high, but relative to a younger person. So age matters on dislocations. So once the shoulder comes out, if we treat it with rehabilitation, and it keeps coming out, then we're usually looking at some sort of surgical stabilization. The problem about it coming out repetitively is we start to lose bone. We'll look at some pictures in a minute. We talk about the Hill-Sachs lesion as the head comes out and dents the back of the ball. That Hill-Sachs lesion makes the ball smaller, which we'll talk about too. And off the front, if it's an anterior dislocation, the glenoid can start to wear off, either from a fracture from the initial one or just be worn down from the repetitive dislocations. It makes the overall stability much lower. So once we're in that recurrent shoulder dislocation, I'd rather get it fixed than not. And we can do arthroscopic or open, and I know arthroscopy is something that's growing here, just like smartphones, and there's not as much availability, especially with implants, so we'll talk about that. But it can be done arthroscopic or open, and there may be times where open actually has some advantages. So we want to repair the ligaments and cartilage back to the socket. Dr. Duane and myself were taught by two surgeons who were taught by the same surgeon. We have a lineage going back the same. And there's a thought that when we dislocate the shoulder that first time, not only do we tear the tissue, but we probably stretch the capsule out. So do we need to tighten that capsule? That might be a reason why we fail when we don't fix, when we fix the shoulder and try to get somebody stable and it still comes out. It might be because the capsule is too stretched out. So there's some school of thought that stretched capsule needs to be tightened as well when we repair the shoulder. That can probably be done, or I believe is done better open anyway. So sometimes we'll do an open procedure because we want to tighten that capsule in a more secure way than we can do arthroscopically. So again, the primary part of fixing a shoulder dislocation is to get the ligaments back, but there's other things we can do too. We can do what's called a remplissage. That's French. We were talking about French, Ebenezer. Do you know that word? It means to fill. So we fill in the defect of that Hill-Sachs lesion with what's called a remplissage. And then there's bone block procedures, which we'll talk about. So before we kind of go into surgery a little bit, I wanted to at least mention this. This for me is a little bit like maybe I'm an Apple phone person. This might be more like an Android thing for me. I don't use a lot of this, but it's a good concept. I think it's one you need to at least know about and think about. I'm not quite sure yet what to do with this, and as I read the literature about it, I think the literature isn't defined on it yet. But there's a concept of on track and off track in shoulder instability, and the idea is, this is Itoi from Japan. The idea is to look at both sides and kind of see if the socket's gotten smaller, and then if the Hill-Sachs has gotten bigger, and then how they compare to each other. It's confusing to me, and when I was putting this talk together, I had to look at it a couple times so that I can make sure I speak to it accurately. When the shoulder moves, when they looked in the lab and they moved the shoulder around, they saw that the ball only was sitting on part of the socket at any one time. It didn't sit on the whole socket. So in their calculations, 83% of the socket was holding the ball. So that's where the 0.83 comes from. And then they kind of tracked out on maps, if you see on the right, kind of where the socket was on the ball. And we can imagine when we come into that abduction external rotation, we're getting into that region of where the Hill-Sachs lesion is. So if the socket's smaller, that little d in the middle there, we lose some, the overall diameter goes down, and we only have 83% of that we're using at any one time. So that Itoi measures the diameter, what it should be, using a circle, and then measure it by 0.83, and it subtracts a little bit. So again, the math starts to get, I guess for some, maybe half as smart as the ox here, but the math for me gets a little bit confusing in what it all means. But basically, as the socket shrinks, there's less golf tee to hold that golf ball. These pictures make the most sense to me. So in the mid-range, so we have a Hill-Sachs. This is the front is towards me, the back of the humerus is over there. This is an axillary view. So the capsule's in the front here. We see the Hill-Sachs lesion in the back. And so in the mid-range, the ball is smaller, but is still in the socket, and it's not dislocating. And so something becomes on track, or I should say remains on track, when we get to that end range. They get all the way out, and there's still some ball on the socket. So it's on track, it's not falling off the track. And that's kind of the basis of this. So it's on track that way. So off track's when it gets to the end range of motion, and there's nothing holding it, and it slips off. So as the Hill-Sachs gets bigger, or the socket gets smaller, then it's more likely to be off track. So people have tried to use this concept to calculate, to go back and calculate how big the glenoid is, how big the Hill-Sachs is, and make these measurements. But I haven't seen a paper yet that really has a formula that fits exactly. I think there's still a fair amount of experience and philosophy that goes into what you do, when you do it, based on these measurements. But it's important to look at both of them and realize that they definitely play a role together. This is a bipolar problem, and when somebody's got repetitive instability, if they've got a big Hill-Sachs and they've lost bone, if you just think you're going to do a soft tissue procedure, it's not going to work. You need to take care of the bone defect because they're going to fall off track too readily otherwise. So for me, I don't have a surgical algorithm as I put this slide together last night, I tried to put something down that was real straightforward. If this, then that. Always do this, never do that. But as we know, first of all, that rarely works in orthopedics. And I think for instability, at least for me, I'm not quite there yet. I look at the age of the patient. The younger, the more kind of aggressive I am as far as doing more things. I look at their activity in sport. Here, of course, soccer, football is big. But sometimes it's just what their needs are as far as range of motion. Of course, a goalie's going to need full range of motion and be a lot more aggressive with the range of motion. You might find somebody that does something a little more extreme sport. I've taken care of some downhill skiers who fall a lot, and so they need to have a lot of stability. They don't mind losing their motion either. So some people want to really have they might swim. It's very important to be overhead, and so maybe their motion can't be limited as much. We need to look at the pathology parameters. If somebody's had surgery and they're still coming out, a lot of times across the world, people are going to a Latarjet, bone block procedure, right as a second operation. And then if there's bone loss, somehow we have to treat that, or at least think about treating it. On the glenoid side, that can be the Latarjet or others, which we'll talk about. The Hill-Sachs lesion, do we fill that in somehow? And then if it's bipolar, do we do a combination of both? So an arthroscopic Bankart repair is kind of, in the States, is probably the most common way to treat anterior shoulder instability. It is very material intensive, and it's probably something here I would put down low on the list. If somebody's got all the toys and all the arthroscopic equipment, I think an arthroscopic Bankart is fine. The problem is, I know how it is here. I've been here enough times and worked in a few hospitals now. The anchors here you need them for other things. I would save them for things that you kind of can't replace. So I would use them, but use them judiciously. I wouldn't spend a lot of time unless you have everything else figured out going right into arthroscopic Bankart. I think an open Bankart is probably a better way to start. You can use a higher variety of anchors and even do bone tunnels if you need to. But if we have the good, really excellent fluid management, we can see clearly. We have multiple cannulas and anchors that are low profile with good suture material. We can grab that torn Bankart tissue and put it back. When we do this arthroscopically, the typical teaching is to try to pull things up to tighten the capsule. But there's not a real good way to tighten that capsule when we do this. And that might be a way or a reason why people fail this operation. Again, like Dwayne and I were taught, you want to kind of tighten the capsule, which I don't always do, and I can't really do here real well. So open arthroscopic Bankart is a good operation, but certainly not where things started, and probably where you shouldn't start if you're getting into shoulder surgery. An open blanket repair is the gold standard for a person without a lot of bone loss. And that's done through the front, so we have to get through the subscapularis some way. Dwayne, were you taught to split the subscapularis, or you peeled it, didn't you? Yeah. So again, Dwayne and I have this common legacy, so we were both taught to peel the subscap back. A split can be done, which is done for a Latarjet, which is difficult. It's hard to see in the shoulder, even with good retractors, especially as somebody gets more muscular. So I don't like a split for this. I do a peel. I peel the subscap off, again starting a little more medial to find the interval between the subscap and the capsule and peel it back. That's something that's really nice to be shown how to do or watch some good videos. That interval between the subscapularis and the capsule is, as we get more lateral, it has to really be almost made surgically. Very hard to define that. It doesn't just open up or fall open. As the subscapularis is peeled off, and the capsule can be cut vertically, it can be cut in an L or a T, and the T is the way I was cut. We shift it on the way out or tighten the capsule. And then the labrum has to be attached to the glenoid. It can be done with bone tunnels. With a good awl, we can make bone tunnels. And the access is, I haven't done much of this actually, we just did it last week. And it's good access, it's not difficult to do if you have good exposure. So we can use anchors or holes, bone tunnels to sew the tissue down, and then we'll shift it on the way out. What are the bone block operations? Well, the one that most people talk about is a Latarjet, and that's where the coracoid's cut. The subscapularis is split, as you see on the lower left there, and then the bone block is tipped and screwed, or some of the fancier equipment now. I have not used this. They're using some suture buttons in some techniques where the bone block is held down by suture buttons. But by putting the coracobrachialis, or the coracoid, which has the coracobrachialis and short head attached to it, over the lower subscapularis, there's a sling effect that is felt to be significant, although data from the laboratory is variable. But as somebody comes out in that abduction external rotation position, first, the glenoid's bigger because there's that bone block, and second, there's that soft tissue strap that holds things in, and then if we repair the capsule, we have additional support as well. And so that's supposed to be, those three things all add up to giving us more stability with this Latarjet procedure. I think an important thing for here, especially if we talk about, Tedesse and I were talking last night or the night before, or 2 nights ago, I think, about this procedure, and he was talking about the chronic shoulder, which Dwayne's going to talk about. I would not recommend doing a Latarjet if you take the subscap off, then put it back on. If you do that, I think that the force, when we split that subscap and we had to put that Latarjet down, there's a lot of force on that lower subscap that we're over. And if we did that, if we took the subscap off, put it on, and then put the Latarjet over it, I can't imagine anything but that getting torn off. So I would not combine the two operations. I think the inferior half of the subscap has to have its native attachment to do a Latarjet. I would not do it any other way. You can, and I have released the upper subscap for access and put that back. That's reasonable. And if doing the Latarjet, that may be not a bad way to start. This is an operation I was not taught in residency. I had to figure this out on my own. It was a popular operation. Well, actually, in the U.S. it's more the Bristow, which is just the tip of the coracoid. But it was a popular operation in the 80s. I trained in the 90s. It had fallen out of favor. Nobody did it. And so I had to kind of learn how to do it on my own. This is one of the hardest operations I do, I think. An open Latarjet is not an easy operation. Again, especially if someone's real muscular or large. So if this is an operation you're going to do, if you can have someone show you how to do it the first time or two, great. Otherwise, watch a lot of videos, be patient, make sure you have good retractors. If you can get what's called a Fukuda retractor, that's my preferred one for getting the humeral head out of the way. So good operation, just requires persistence to make sure that bone block's put low and not overhanging the joint. And those screws have to obviously be positioned to get good hold and not cause an articular problem. So I already mentioned something called a Bristow. Really isn't done much anymore. That's the tip of the coracoid. There's a movement in places like the States to use distal tibia allograft. It fits real well. The articular surface of the tibia has good morphology for fitting the humeral head. It has cartilage on it. If we have a real big bony defect, that Latarjet it has no cartilage, of course, so we're rubbing our humeral head on non-articulate bone, which isn't great. So one of the thoughts about using an allograft is we have cartilage. There's one paper, I think, right now that says it's equal to Latarjet, but it's very expensive, and I don't think there's allografts here anyway, but it's something to know about. I've only done it once or twice, and one of them has already started to resorb, so it's not the end-all, be-all. There's other options, and the distal clavicle, I think, is an option. I've used once, and it worked fine, and that's obviously available here. Autograft, distal clavicle, not a great shape, but it's got some cartilage on it, so that's something to think about. Might be also a way to bail out if you're doing a Latarjet and it's not a big enough piece of bone, you need more bone. It's locally right there. Keep your CC ligaments intact, do a distal clavicle excision, and bring it down as a free graft with cartilage on it. Iliac crust, we use that here. I think on my second trip. That works well, but there's morbidity from taking the graft. It's non-articular, and it doesn't have that strap effect. But if you've got a younger person with a real bad instability, a lot of bone loss in the glenoid iliac crust is reasonable. I don't have a picture, but there's a paper called J graft out of Germany where they cut the graft into a J shape. Have you seen? Did I send that to you before?
I have a paper.
Yeah, you take an osteotome then and create a trough in the glenoid. You can just wedge that in. They actually do it without fixation, so it's very amenable to doing here a J graft. Again, a reasonable option if someone's got a lot of bone loss in the glenoid. That's what we did on recurrent, or it was a failed chronic. There was too much bone loss, so we went back and we didn't use a J graft. We used screws, which is iliac crust, to build up the glenoid. The patient, they said they've got some pain because their glenoid is a third no cartilage, right? It's just like ilium. So I mentioned already remplissage. It means to fill. I'm told in French. I don't speak any French. Ebenezer speaks more French than I do. But that's where so if we're looking at this picture here, on the back is the Hill-Sachs lesion. So this is anterior instability. The ball goes that way. In the back, we have a Hill-Sachs, and a remplissage is to fill it in. What we do is we just bring the rotator cuff, we clean up the tissue, and we bring the rotator cuff down into it. It doesn't shorten it, but it just creates kind of a shorter length. And then hopefully the ball can't fall into that defect anymore. So it might be a way to convert that on track, off track into a more stable situation. I don't know how to do this operation open. I haven't figured that out, but what we did last week is we arthroscopically placed the two anchors, and then when we were done with our open shift and labor repair, we just tied it open. So arthroscopic assisted is a good way to do it. It'd be very hard to do. I suppose one could do transosseous. That would be hard to do and get access. I think about that. Probably could be done arthroscopic assisted transosseous, and then tie the knots in the front on the way out. It's hard to know when this is needed. I don't have, again, an algorithm that's going to tell me exactly when to do this. I don't think we ever do a remplissage alone. This is something we do in addition to a Bankart or in addition to a bone block procedure. So if we have somebody who has a Bankart that we're going to fix and they have a huge Hill-Sachs they're engaging, we can close up that gap and give them more stability. We'll lose a little bit of motion, but it seems to be pretty insignificant. So circling back, we get the tubs and the ambry. I wanted to shift now to the atraumatic, multidirectional patient. At least from what I can tell and what I've seen here, less common in Ethiopia. It's not caused by an injury. The shoulder is unstable in all directions. The people are loose. We can check other joints. There's something called the Bateman criteria, where you have to put the patient, have them bend over, put their hands on the floor, see how lax they are, bend their thumbs back, bend their elbows back. The idea is that the more loose you are, the more likely you're going to have this multi-directional instability, or what's called MDI, or abbreviated as MDI. We want to strengthen the rotator cuff muscles, do therapy, lots of it, get people rehabilitated. Rarely surgery is indicated for this. When we do surgery, we want to do a capsular shift. That can be done arthroscopic. I think it's probably not technically as sound of a procedure because we're not overlapping or building up the capsule. We can tighten the capsule based on the glenoid side, the middle, or the humeral head. I was taught humeral based or near. It's open rehabilitation. We lose a little bit of motion, and it takes a while to rehabilitate this, but we take the capsule, we peel the subscap back, and we take that bottom leaflet that we see on the left, and we lift it up, sew it down, and the top leaflet and sew it down. So we're shifting and doubling the the thickness in the middle of the capsule. It's a good operation. Again, this is an operation that's, I think, seeing it once or twice was really helpful. The tissue layers are a little difficult to define on your own. As far as post-op rehab, the principals want to let people move and let people function, but allow them to protect their repairs and progress as they go. When I was in training, I was taught some complex protocols for rehabilitation. I could never remember them. They might be useful, but they were hard for me to understand and follow, and patients had a hard time following them, and therefore they probably didn't help much because nobody knew what was kind of happening. I prefer real simple protocols and terms. I want to be able to communicate to my therapists, but also the patients and my residents or fellows or coworkers, PAs, what I'm doing. So when I do a shoulder surgery, I basically have 3 basic range of motion protocols that I try to fit everybody into. I either say they have full active motion, they can move where they want. They have limited arc, which we'll talk about, or they can't move actively at all. So for rehabilitation after an instability problem or surgery, I do a limited arc. So I say they can forward flex a 90, rotate to neutral external. They should go to their internal, rotate to their rear end only if they need to for ADLs. Keep that real minimal. And then I'll add weight restriction, which for a rehab, for instability is light, less than a kilo, preferably about a kilo. So that's instability, a little longer, so I'll have to go a little faster for the cuff. Any questions about shoulder instability? Acute instability? All right.
If you were to put the literature and say which one's better, organic heart repair and inferior capsular shift versus a ladder J, which one's easier and which one has the longer series of good results?
So Dr. Dwayne asked, what does the literature show, ladder J versus open shift with banker? I don't think there's a head-to-head comparison that I know of. The French literature on ladder J is really impressive. They do that as a primary operation for a lot of people. So their data is really good.
How long is their follow-up?
I think they have some long-term follow-up. The arthroscopy, just like in the rotator cuff in the States and in Europe, has pushed away open surgery maybe a little bit too quickly. And there's such a push for arthroscopic instability surgery that it's rare to ever hear anybody doing open. I mean, I have younger partners I've had to show how to do open shifts. They've never seen one. These are people who trained at big institutions by big sports people, and they've never seen one as a trainee. So yeah. I can't answer the question. I think you could get 2 people up here. You get well-known French shoulder surgeons that say ladder J is better for all these reasons. And you get somebody who's still doing kind of a Columbia-based, New York, Columbia near shift, and they'll give you good results and say they've had minimal failures. So
I'd be interested to know who's done a capsular shift and who's done a ladder J.
has anybody done a ladder J? Dr. Tim? Anybody done a capsular shift, open capsular shift of any sort, overlapping the capsule? Yeah, so now a lot of experience.
You have it?
All right, I'm falling behind Sammy. We're gonna get moving. I'm gonna go over a little bit, right? Because you got breaks in about 15 minutes.
Yeah, let's go take the cup and then break.
Yeah. So I'm gonna probably go over a little bit. Sorry. All right. This was my longer talk, I thought. All right. So, people. So this is gonna go over kind of the spectrum of rotator cuff pathology. So patients they'll ask me often, why did I tear my rotator cuff? Because I'm talking about smaller, full thickness tears, people past 50. They'll say, I didn't hurt myself. Well, same reason our hair thins out the back of our head and gets gray. Apoptosis, programmed cell death. Our tendons do wear down. This is a wear and tear aging issue. And so that's important to remember when we talk about fixing rotator cuff tears, especially as people get older. In general, if we're going to, and I'll go back and forth a little bit, but if we're going to fix a rotator cuff, we want to address the pathology of the rotator cuff problem. And now, so I'm jumping right into surgery here. So full thickness rotator cuff tears in younger patients, typically in the States, will fix them. Now there's some pathology, I couldn't find the article, there's a recent article out of Scandinavia showing people in their 50s with non-operative, and it was almost equal some of the outcomes. So there's a question with these degenerative tears whether they all should be fixed. But if we're going to fix a small full thickness tear, we want to address the pathology, decompress the subacromial arch. That's somewhat debatable now based on some literature. Mobilize the rotator cuff, repair without undue tension, recreate the footprint, and then do the appropriate rehabilitation. So, again, talking about arthroscopic versus open, when we do arthroscopy, we can see pathology, adjacent pathology, associated pathology, or even separate pathology, and treat that. Decompression, subacromial decompression. Is there a problem where the acromion is causing part of the problem, or is it contributing to part of the problem with the rotator cuff? Subacromial decompression, shaving the undersurface of the acromion down, in theory opens the arch up, gives the rotator cuff more room. There's literature, side-to-side comparisons, prospective studies even, with rotator cuff repair showing no difference. There's a couple papers recently now showing that if we look at people who've had a decompression, their long-term outcome might be better. So it's debatable, but there's been a movement away from decompressing everybody. In the US, most rotator cuff tears are getting fixed arthroscopically. I still do mine mini open. This is a place where I think you really can save anchors here in Ethiopia. Getting a reusable awl, recreating the footprint, and using an awl to use sutures and shuttle them can create what's really the gold standard rotator cuff repair. This is in the arthroscopic world. They're trying to mimic this with what they call a double rotator cuff repair, even more anchors. So they're using, for even small tears, partners will use 4 anchors for a small rotator cuff tear arthroscopically. So very, very equipment intensive that can be done with no anchors at all. By making a small incision, we can mobilize the rotator cuff, bring the sutures through the tunnel, apply multiple sutures, and recreate the footprint. So in the US, there's not a lot of surgeons like myself doing things open anymore. But if we think about it, it makes a lot of sense, especially here, because we don't have a lot of anchors, we don't have a lot of arthroscopic equipment. What are the outcomes like? Equipment plays into it, cost, efficiency, surgical training. There was some thought that maybe arthroscopic rotator cuff repair is an earlier recovery, maybe less stiffness. When we look at the literature, one paper in 03 talked about comparable outcomes, notch, with a higher rate of adhesive capsulitis in open surgery. But looking in 05, Yanati's paper showed comparable results and no difference. Healing rates were somewhat comparable in later studies. Early studies showed that there was a higher complication or failure rate of arthroscopic rotator cuff repairs. 2006, open repairs, 69% intact, only 53% of the arthroscopic. That's a prospective study with MRI follow-up. A lot of the data, if we look at it, they don't image the rotator cuff, so we really don't know. This is the best paper out of England, Carr, looking at a prospective randomized study comparing 273 patients. They imaged the shoulder at a year. This is arthroscopic versus open. Generally speaking, equal outcomes. The re-tear was not significant, but there was a tendency for better healing with open. So no evidence of difference. So it's great to be as technologically advanced as we can, but especially in a place like Ethiopia where we don't have a lot of anchors, open is as good. And again, that's still what I do in the States. I do arthroscopically look to make sure there's nothing else going on and do a mini open. The cost can be equivalent in the States, maybe. There's some papers that try to push and say there's an equivalency. I don't quite understand that. But the savings are definitely realized with bone tunnels. And definitely can't have implants that we need cannulas, anchors, passers, and then the added time. So arthroscopic, I'd say Ethiopia can wait for arthroscopic cuff repair. That's a thin patient like we have here. That's a 3 or 3.5 centimeter incision. Get efficient doing it this way with a mini open, and you'll be very happy with it. So in my practice, I arthroscopically fix everybody, and do a mini open I'm sorry, I look arthroscopically on everybody, and I do a mini open for nearly everybody else, for everybody. So I wanted to, so that intro there was more a small full thickness tear in an active patient who you decide to fix surgically. I'd say do a mini open repair. If you have arthroscopic equipment, clean things up if there's some labral pathology you want to treat, but do a mini open repair with bone tunnels. Get good suture awls, and that will make your life much easier. I wanted to shift into chronic tears and talk a little bit about that. Some of this is germane to Ethiopia, some of it, I'll just mention some things about reverse shoulder, which of course we don't have here yet. So I've already gone through the best data. Rotator cuff repair works in a small chronic tear that's fixable. Partial tears I'll mention, that's an interesting dilemma I think. What do we do with a patient with a partial tear of the rotator cuff? Severe tendinosis at apoptosis, there's a programmed cell death. The hair is getting thinner, well the rotator cuff's getting thinner. What do we do for that problem? And then, are there rotator cuff tears that are unfixable, and what do we do with those? There was an article by Galatz in 2004 that in JBJS, I think it was the lead article. People were really amazed by it because the authors were so honest. This is from St. Louis, Lisa Galatz, Ken Yamaguchi, two very well-known shoulder surgeons at the time. They went and looked and imaged their patients with big rotator cuff tears that they fixed. And this is 2004, so people were using multiple anchors and all these slide techniques, and all these videos were coming out, and certain people from the podium were saying, oh, I can fix any rotator cuff tear. I can do this and I can do that, and I can make up for all these deficiencies and fix them. So Galatz and Yamaguchi went back, and not a lot of patients, there was only 18 patients, but they imaged them, and 17 of 18 had retorn. So, interestingly enough, most people were pretty happy. So when we go in and clean somebody out, we're probably helping, but do we really need to repair these massive tears? And if they're, what are we doing to these rotator cuffs? Can we make these things that are huge, can we make them really heal? And so there's this quest for the Holy Grail, another English reference, but how do we heal these chronic tears, especially when they're massive or they're large? I'm not going to talk about some of the things that have been done in the literature. Freeze-dried allograft, distal deltoid release is an Italian procedure. Deltoid transfer was out there for a while. Arthroscopic biceps cannelli, where the biceps is tenodiced. I am going to mention some other things so you at least have heard about them. But before I do that, I want to go into chronic partial tears. This shoulder is mine. So this is a rotator cuff tear that's partially torn, and I want to at least talk a little bit about that at the very end because it's interesting. For partial tears, there's been a technique used called pasta, where people go through the rotator cuff with an anchor and then tie things down. I've had trouble believing this makes any sense. We're going to tighten the rotator cuff right at that anchor point and loosen it where it's still attached. We're going through bad tendon and asking it to heal to the bone. Biologically, it doesn't make a lot of sense to me. So for most of my partial tears, I just debride them. If they're less than 50% thickness, I think the literature shows that's about equivalent to doing much of anything else. But what do we do when someone has a massive rotator cuff tear and it truly isn't fixable? They have severe atrophy, the tendon end is retracted all the way to the level of the glenoid, the humeral head is superiorly migrated. And certainly, not every tear is fixable. This is another study kind of like that Galatz study, 2013, JBJS, 91% re-tear rate. So we can go in and these companies that sell equipment like to show us all these techniques to use all these disposable anchors, but when we go back and MRI these patients, the re-tear rate is quite high. So for massive cuffs in the 90s, I was taught to use a bipolar device, like a bipolar hip. The idea was the double ball would somehow recenter and allow us to use the shoulder more appropriately with just the deltoid. Many of these were overstuffed or put in very large. Did you do any of these, Dwayne? Never? I was taught this in Boston. And some of the results were really impressive. This lady on the left here was an early patient of mine. But they were unpredictable. The patient on the right was a patient of mine too. When he relaxed, his shoulder was in the socket. And when he forward flexed, it subluxed all the way up and out. So they can be problematic. The next kind of generation of implants was a CTA head or a cuff tear arthropathy head. This is actually probably something I could get here through it. I'm hoping through Exacta because nobody uses them anymore pretty much. But the idea is to cover the greater tuberosity with metal. It's a metallic interposition. allowing the head to stay high and letting it kind of ride in the arch. It's an okay operation. The head has to be contained. It's unpredictable. People tend to feel better after it than they did before. It's probably equivalent to a significant debridement and then a smoother surface. So it's not an unreasonable option, and maybe an option for Ethiopia if we can get a hemiarthroplasty here. But they can pop out. This lady came to me, and as she would lift up, that ball would just pop out. She wasn't contained. She didn't have an arch. So reverse, of course, is an option which we don't have here either. It's, you know, we're treating severe rotator cuff problems. It doesn't solve the problems. It helps a lot of patients. It's a good operation, but we create the potential for other prosthetic issues as well. So I'm sure, just like you know, the newer smartphones, this will get here eventually to Ethiopia. And when it does, the idea is to be properly trained on it and use it judiciously or carefully so we don't overutilize it. But there are things we can do here for chronic irreparable rotator cuff tears, and that's tendon transfers. So traditionally, for subscap loss in the literature, pec major was utilized, and then Warner talked about teres major having a better vector. This is a patient of mine with a subscap failure. I did a big dissection, took the teres minor off, transferred it, and there it is there, the bone block you can't see very well, was transferred. I was very happy with this, but we can see it's still subluxed anteriorly. So even this operation, teres major, isn't that good. And El Hassan has shown that both the subscap and the teres major don't have quite the vector that the latissimus dorsi has. So for irreparable subscapularis tears, the latissimus dorsi transfer is actually quite easy to do. It's down low, we just transfer it up. It's got a better vector, and he showed in 2020 improved subluxation on some patients, improved clinical parameters, and improved shoulder function. So tendon transfers for chronic irreparable rotator cuff tears for the front subscap latissimus dorsi. Historically, lat dorsi was used for posterior superior transfers, taking it and flipping and pulling it up the back. That's based on a pediatric Lepiscopo. Dr. Tim probably remembers that. Lepiscopo, do you do that? Lepiscopo at all? For brachial plexus palsy? So that's the historical reason Gerber did it in '88. Some okay follow-ups and studies. It's an operation I started to do. When I look back 10, 15 years ago, I had okay results, not great, and couldn't really change motion predictably. So latissimus dorsi has fallen out of favor as well, and Bassam El-Hassan from, now he's in Boston, again has revolutionized things by taking the lower trapezius. So this is a transfer I did with Mamo 2 years ago when I was here. We did one, and the patient did pretty well. So lower trapezius muscle, it's in phase, it's in line, and it's a readily doable operation. You need to extend the tendon with a graft. So here in Ethiopia, we can use hamstrings. So we extend that and we repair that autograft into the humeral head, and we can replace to some degree the lost tissue. Just to finish up, again, industry is pushing orthobiologics, using either things from our own body. There's some use of PRP here, isn't there? I think. Yeah. So PRP, which is there's some literature for that for arthritis and other reasons, but can we do things that are PRP, stem cells, some sort of engineered substance? Is there something we can have that can really change the way the biology is? And this is, I grabbed this out of I think it was the JAOS journal, but there's an article by Scott Rodeo, who's, I think, probably one of the leaders in this whole orthobiologic world. He's done a lot of research looking at PRP and rotator cuff repair and all sorts of things. Pretty good data. And I thought this statement was worth just copying. He says, current data suggests that orthobiologics are symptom modifying, but there's little evidence that they can lead to true tissue regeneration or structure modifying. So, and in the US, this is a big deal. A lot of people come in and they'll pay cash, and people charge a lot of money for stem cells. There's just no evidence anywhere that we can regenerate tissue. And what I say to my patients is, if this stuff worked, nobody would be bald. Because, in the back of my head, I'd love to have more hair there. If we could somehow inject something and new tissue would grow, the whole world would be doing it. No one would have wrinkles, nobody would have thin hair or even gray hair if they didn't want it. So we can't modify the tissue yet. Nobody can do it. So we can make people feel better, but we can't modify the tissue. Not that we haven't tried. In '99, someone came out with this is a porcine submucosal intestine patch to make and this is that holy grail. How do we make that rotator cuff healthy? How do we reverse that apoptosis? And this was out in '99. I actually used this for a while. They had pig models that really looked impressive, and then they came out. I don't think they have it. They did. There was I think the Australians showed it just didn't work. So companies don't stop. They keep selling things. They keep coming up with ideas. Who here has heard about the SCR, superior capsular reconstruction? We'll get to that in a second. Not really. It's probably better that you haven't. So acellular dermis. So we take some skin from a cadaver. We process it to pull all the cells out. We have that collagen matrix, and we put it down. This is probably the best study done that I could find showing something that makes rotator cuffs better. These are rotator cuffs. This is prospective. Rotator cuffs that were repaired. They're repairable. Only 42 patients. And they put an augment group on. They put this acellular dermis, and they showed intact, again, prospective randomized, intact and 85% with a patch, and 40% not intact, 85% with the augment, only 40% non-augmented. So doubling the healing rate with a patch. So maybe there's a role for a patch to get something to heal. Acellular dermis has been the best one. SCR is this idea which I think is going to fall out of favor. It's where we put a patch over the top and sew it to the glenoid. This is for people who don't have a rotator cuff. The idea is it kind of holds the ball in the socket. This is already, this graph here shows how some things are incorporated and the idea takes off, and at the top, a lot of people are doing it, and then they kind of realize the results aren't so good, and then it kind of trends back down, maybe even back to where it started. SCR is kind of going here. Superior capsular reconstruction has probably reached its peak at this point. The company that Arthritis that makes a lot of these products has said, well, maybe we can put a patch somewhere else and it'll act as a cushion. This is an inner position. I think these ideas really don't make a lot of sense. But speaking of cushions, there's now a device that's a pillow filled with saline. It's a dissolvable pillow that you put in here to help support supposedly the shoulder while the people rehab and recover. This is a device that costs a lot of money. Made its way from Israel to Australia. I'm told by my Australian friends it's already out of favor there. Hit the U.S. about a year and a half ago. There's a really nice article in Lancet in 2022, level 1, prospective randomized. They came back and said, we don't recommend this. It just doesn't work. So a lot of these things have been tried, and hopefully, again, for Ethiopia, you can just bypass. You can bypass that landline and go right to the cell phone. Let other people figure out what works and doesn't work. People are pushing biologics to help those partial thickness tears. Remember I showed that picture. Do you tack it down? Do you clean it up? The one article I showed you was for full thickness, putting a patch on. That seemed to help. Go back to my shoulder and I'll finish with that. I guess I'm catching up. That's good. I had a biceps tenodesis, so I said to my partner, why don't you put one of these patches on? Maybe it'll make my shoulder, my rotator cuff thicker. That's what happened. That's, remember when I didn't come last year. Yeah. So there's a reaction, not really a reaction as much as a breakdown of this product. I had to have that all washed out. So we can try to make our thin rotator cuff healthy. We probably can't do that. We don't really know how to do that. If we have a full thickness tear that's small and it's flexible, that's fixable and it heals in most people, especially if we're younger. Maybe putting a patch on it will help. If we have a massive tear, something that's not fixable, tendon transfers can help. And eventually here, prosthesis can help too. So that's rotator cuff. Questions? Has anybody seen a reverse shoulder replacement anywhere? I know they're not here. You seen one? Or was it? Kenya? Yeah. Was it done for a fracture or for a rotator cuff tear? Or? Massive. Did it turn out well?
I think you have to be very selective with the patients you put on the list for reverse shoulder.
For sure, yeah.
And the reach limitations even afterwards.
Yeah.
So a lot of them are already in the cell.
Yeah.
With no comfort.
Yeah. The reverse shoulder is a good operation, but you have to pick the right patient. You have to give good advice up front to tell the patient they're not going to be normal, they don't move normally, and they don't have normal strength out in front. And their motion typically improves, but not to normal. It can be a great operation, and it's used for a lot of things now, and we have to be careful we don't overuse it. Sure. Has anybody seen a tendon transfer of any type around the shoulder for any reason? Okay. All right. I think we might have one coming up tomorrow or on Monday. You've seen something? What tendon was it?
It was the you and Mom with
Oh, okay, the one we did, the lower trap, yeah. I think that patient did pretty well.
yeah.
Yeah. Good. All right, break, Samson?
Yes.
All right.
Tea break, 20 minutes. Which start?
Current concepts in complex elbow instability. So when I think of complex elbow instability, it's not simple. It's with a fracture. Elbow instability with a fracture. And we can treat these based on pattern recognition. And so this is something that, for me, started off a long time ago as very, very complicated, and has become a lot more driven by algorithms or a series of thoughts about what's going on with pathology. And when I was showing shoulder dislocations, I was saying that I don't really have an algorithm where I can say this much bone loss means that much motion, or this bone loss means lateral-J. I don't always, in my mind, have that. For the elbow, for me at least, I'm a lot more driven to a treatment based on an algorithm. This is a page out of a book that was a rush rod manual, which is, I know you rush rods and things, but back when there weren't a lot of implants and rush rods were modern, this is out of the elbow section, and down below it says, proceed cautiously. This is a territory of monuments to surgical accomplishments and misadventures. And me to this day, for sure, I'm humbled by the elbow time and time again. But if we look at it and we pay attention to the coronoid, we pay attention to the fracture patterns, there's a lot we know right now, and a lot we can be driven to do, and to take good care of patients that certainly 25 years ago we just couldn't take care of. We did not understand. Dr. Sean, who many of you mentioned, met, and I had mentioned earlier, my mentor was here with me in 2020, and he's really driven elbow surgery forward probably more than anybody else, or as much as anybody else in the last 20 years. So for me, this is about 27 years of learning. There were cases I had in residency and fellowship that I really didn't understand the pathology. This is a patient I treated within the first year or two of practice, who today I would treat completely differently. He had bilateral terrible triads, he had radial head excisions, and hinged external fixators put on. He's still around town. I work in the same area that I started 25 years ago. This is about 25 years old, this picture. His fixators were coming off, that's why he's smiling. And I saw a patient within the last year who knows him and says, do you remember this patient? And he's doing fine. But this is, my understanding has advanced so much, he would never have these external fixators on, and he probably would have done a lot better. So if there's one thing I want you to walk away from, it's this slide, and you'll see it again, and I'm going to go through this as we work through the talk. But this is the whole talk pretty much in one slide. It's about pattern recognition, and when we recognize a fracture dislocation and we look at the coronoid, is the fracture of the coronoid the tip? Is it the anterior medial coronoid, or is it the base? And if it's a tip, the mechanism of injury, the way the elbow dislocates, is a posterior lateral rotatory instability. If it's the anterior medial, it's a posterior medial rotatory instability. And then if it's a base fracture, it's a transulnar basal coronoid fracture dislocation. It's a variation of an olecranon fracture, but the base of the coronoid's off as well. And then we treat these according to that pattern recognition. So if it's a tip fracture, if it's a posterior lateral rotatory instability, we want to fix or replace the radial head. We need that. And we're going to talk a little bit about radial head replacements at some point today with what we just did last week, or this week, making them out of polymethyl methacrylate. So we'll talk about that. You can make them in Ethiopia. You don't need to buy them. And they work, we think, okay. It's been done elsewhere. We want to take care of the radial head. We want to fix the LCL, the lateral collateral ligament. And then we want to think about the MCL and see if that needs to be addressed as well. It was an anterior medial fracture. We want to restore the support for that. We want to fix the medial coronoid. We want to fix the LCL. And maybe even sometimes think about the posterior band of the MCL. We may not get to that today. If it's a base fracture of the coronoid with the olecranon fracture, we want to fix and replace fix or replace the radial head if that's fractured, which usually it is. We want to fix the olecranon, but we have to fix the coronoid, and that's usually before we fix the olecranon. And we have some cases that we're going to go over I think after lunch, and we'll see some of this in action. So again, we want to understand elbow instability. We want to go back to the coronoid. Dr. Mori, who is my mentor, and Dr. O'Driscoll's mentor, would say you use the term the primacy of the coronoid. As a coronoid goes, kind of so goes the elbow. When the coronoid's not supporting the distal humerus, the elbow is not going to function well. The injury pattern dictates the coronoid fracture type. The coronoid fracture type kind of dictates the injury pattern. They speak to each other. The lateral collateral or lateral ulnar collateral, LUCL, LCL, that's a very strong stabilizer of the elbow. Medial collateral is important, but because of how we use our arm, when we bring our arm out, there's a varus force on the arm, and that stresses the lateral side. It compresses the medial side. So we don't really need an MCL, or we don't need a great MCL. If everything else is normal, we're not stressing that too often unless we're weight bearing or we're an American baseball thrower. So the anterior band of the MCL, not so important when we're talking about fracture dislocations. Not irrelevant, but not critical. Posterior band actually has some play and is important when we talk about some injuries. We can ignore it sometimes, especially if the coronoid is normal or well supported, we can ignore it. But there are times fixing or reconstructing it may play into it. The radial head is really important, especially when there's not a normal coronoid. I showed a picture of the guy with his fixators. That's why I say I would do something different. I wouldn't have just excised his radial head. I would have probably put something in to support his elbow. We can do fine without a radial head if everything else is intact. But if we have a fracture dislocation and the coronoid is deficient, having a radial head is helpful for sure and often critical. Why is this all important? Again, an obligatory varus with ADLs. We look at an x-ray like this, we think of the elbow in a vertical, but in actuality, when we grab for that milk out of the refrigerator, there's a varus force, and we're stressing that tension. We're tensioning the lateral side, LCL. We're compressing the medial side, medial coronoid, and that's why those structures are so important. Now, of course, there's a rotational effect as well. Surgical exposure, and I think I'm giving a talk tomorrow on surgical exposure, so we'll go through that. In my opinion, don't go after coronoids from the front. We were talking about this over the week. And there is a paper on it, and some people do it. And if there's a group I'll put up later. There's a WhatsApp group that has formed that I'm kind of one of the early actors in. And we call it Cubitus Mundi, World Elbow. And there are people from all over the world. It's kind of a neat group, but we have to be careful when we just sometimes comment that we don't just really look into the depth of the case. Dwayne and I talked about this. But there were some discussions on Cubitus Mundi about anterior surgical exposures. And it can be done. And there was a case that I think one of the surgeons did it at Soto before I came, and I was talking to the resident. And they did a good job, actually. The end result was very good. But I said, how long did it take and was it hard? He said, yeah, it was hard. When you go in the anterior, the problem with the coronoid from the front is what? We want to extend to see it. And when we extend what gets tight, the brachialis, what covers the coronoid, the brachialis. So we're fighting two things. We're trying to see in there and relax the brachialis. At the same time, it's tough. Some tip fractures can be approached laterally through a radial head defect. And a deep medial approach, my advice to you, and you're going to see more of this tomorrow, if you're going to treat elbow pathology, get comfortable coming to the elbow from the medial side. And there's different ways to do it. We've got a couple of pictures, and we'll talk about it a lot more tomorrow. If we're going to treat that medial coronoid, you can, if in doubt, and when people ask me, well, how do I don't feel comfortable, or I haven't done it, or how can I see the medial coronoid, especially if you've done any ulnar nerve transpositions where you put it under the muscle, which I know is not that common, but it's called a Learmonth exposure, where you release the whole flexor pronator mass. If you do that, you got the whole coronoid staring right at you. So there's no problem taking the whole flexor pronator mass off, preserving the MCL, and then the surgeon has wide access to the coronoid. We can do it through splits, which you'll see a little bit here. But when we're starting, not a bad way to do it. So we're going to talk about the pathology here as we go. So don't worry if you don't understand this so much. And this is more about the exposure. This is a medial coronoid fracture. The piece of the coronoid actually was ejected in the cubital tunnel, and we see on the reformatted sagittal of the CT, the distal humerus is actually articulating up into nothing. This fracture left alone is going to do very poorly. The patient will have arthritis rapidly. So we fixed it. I did this through a posterior skin approach, elevated a flap and did muscle splits, put that piece back, had to release the MCL to get the bone piece in. But so the ulnar nerve is still in the back, behind my retractor. The K-wires are in the coronoid piece, and then a small plate was put on. So we can do it through small splits, but it's harder. When we talk about elbow fracture dislocations in general, regardless of the type, what are the treatment goals? Pretty much the treatment goal of any fracture dislocation of any joint. We want a concentric joint. We want that joint to be stable. And we want to prevent displacement. So in the elbow, we want to prevent varus displacement. We want to think about the lateral tension on the LCL and the ability of the medial coronoid to compress. We want to avoid valgus posterior lateral rotary instability, where if that's the injury, if it's a posterior lateral rotary injury, we're not letting the elbow roll off, hang down, and have gravity pull it apart. So coronoid fractures were originally first described by Reagan and Morey, and this is more of a, for me at least, historical purpose, but it also explains some of the confusion in the terminology. So back in, I think, in the 90s, Reagan and Morey published, they said type 1, type 2, type 3, based on tip, less than 50, more than 50. And they thought about the coronoid as a lateral x-ray just coming down the height of the coronoid, not as a 3D structure. And that's the problem with the elbow. It's a 3D, everything is, but it's a 3D structure that things roll off and they compress and they distract. So it was good to start thinking about the coronoid, but it really didn't help much. And it didn't really guide us as to what to do. So this is the Reagan-Morey classification. So then O'Driscoll, and this is the part of the confusion too, because Sean's at Mayo, Dr. Morey was at Mayo. So they're both there. There's one classification system, there's another classification system, and Sean published this, and it kind of got published in a weird place, and I think in an OKU or an instructional course lecture, and it didn't get published in a journal article that was readily referenced. And I love Sean, he's like an older brother to me, but he's so smart sometimes that when he talks to us, it's hard to follow him, and he shows this x-ray, and then he loses me the first time he showed me this x-ray. This is his classification system, and all those lines, and it's kind of, and arrows, and it's a bit overwhelming, at least for me it was. So I have to simplify things, and so that's what I do, and that's hopefully what I'll do for you too. But the important thing is Sean said, no, there's tip fractures, there's anterior medial fractures, and there's basal fractures. And then, so again, I got to go simple. So first of all, don't use 1, 2, or 3 or Roman numerals, because that's not the classification. It's tip, anterior medial, and base. Now, unfortunately, David Ring, who's super smart, said he wanted to kind of show that Sean's system worked, and then so they wrote an article, and what they do, they used his system, but then they numbered it. 1, 2, 3. So that's why there's all this confusion about, like people say, oh, I had a type 2 coronoid. Which system are you using, and who are you referencing? And if we go to O'Driscoll, there really isn't a 1, 2, 3. There's subtypes. Again, it gets confusing. So I will hopefully keep it simple. So the classification, when we use the O'Driscoll classification, equals the injury pattern. The tip is posterior lateral rotary instability. The anterior medial is the anterior medial coronoid is a posterior medial rotary instability, and the base is a transolecranon fracture dislocation. And we'll walk through these. Now, Sean has just recently published from Mayo a new classification of proximal transulnar fractures. So when the ulna is fractured, when the olecranon is fractured, or the proximal ulna is fractured, with or without the coronoid. And what he's done is he said, where is the coronoid attached, then that kind of dictates that. So it becomes, again, a little bit confusing. I just made this last night, I hope this kind of makes sense. So there's an overlap of pathology. So we have coronoid fractures, tip, anterior medial, and base. And then we have proximal, what you call proximal transulnar fractures. We have transolecranon, Montasia, and then the basal fracture. So a lot going on there. If we go back to this, if the coronoid is not attached to anything, then it's a transulnar basal coronoid. So For now, especially if you haven't seen this before, go back to this. Tip, anteromedial, and base. And then with the base fracture, we can work through the other stuff. So, posterior lateral rotatory instability, what is that? Well, in a simple elbow dislocation, when we fall, we our arms out and we fall. There's a rotation, there's a supination, there's a slight flexion, and there's a valgus stress. And the radial head rolls off the capitellum. And the black lines there with the two dots on the far left, that's to represent the lateral ulnar collateral ligament. As things roll off, that has to break. That line can't stay 2 points because the ulna is being pulled away from the humerus. So that in a simple elbow dislocation, the LUCL, the lateral collateral ligament, breaks, the ulna rolls off the distal humerus, and then the whole unit of the radius and the ulna start to spin behind the humerus. And then if we see number 2 there where it says perched, that's how we shear the coronoid off. So if the coronoid doesn't clear the distal humerus, it gets sheared off. And it can be a little tiny one or it can be a bigger one. And typically that shear fracture is straight across, right? Now Driscoll takes the tips and he says subtype 1, small, 2, greater than 2 millimeters. But it's all the same mechanism. And then of course it can dislocate all the way. So in a simple elbow dislocation, there's no fracture. It rolls out, it clears. In a fracture dislocation, what happens? The coronoid may get sheared off, and maybe the radial head gets destroyed as well on the way. If this doesn't drop down far enough, in posterior lateral rotatory instability, if things don't clear, the radial head will fracture, usually part of it, leading part, but maybe all of it, and the tip will fracture. So that's how we get a terrible triad. So terrible triad is basically a simple elbow dislocation that the bones didn't clear the humerus on the way down. So terrible triads are from posterior lateral rotatory instability. Most simple elbow dislocations are too. So it's that direction of the elbow going valgus and things swinging underneath. It's a 3D problem. It's not just that things drop down. It's not that somehow things just straightly go back. They roll around to clear that. And they can actually hinge on the MCL when we're perched. And certainly when we're at number 1, the MCL could be intact. We can be pivoting on that. If we're at number 3, the MCL is going to be gone. So that gives us the tip fractures. And again, Dr. Sean splits these into subtypes. Subtype 1, subtype 2. No number. It's a tip fracture. If you want to call it a subtype, you can. It's that transverse line. Okay? So we see that. So again, we see the fracture tells us the mechanism. The mechanism tells us the fracture. They kind of go back and forth. Tip, posterior lateral. Tip, posterior lateral, terrible triad. Or simple elbow dislocation if there's no fracture of the radial head. So subtype 1 can be little, subtype 2. That's the coronoid piece. This x-ray, there's a fractured radial head too. So the real small fractures in general, some people don't even need those fixed. Some surgeons never fix them. At the very, very tip, which is where my scissors are on this dissection, we see the brachialis going past the tip. There is capsule just attached just beyond it. They do add some stability, but very small tip fractures. We can't get to those or do any of those with the plate. What we do, if we feel like we want to add stability, like grabbing that capsule, we can suture fix these. This is the technique that O'Driscoll described. Drill holes coming up, and you can do that just by kind of looking and holding it. You can use an ACL guide. Typically 3 holes, trying to get kind of a triangular fixation. They don't always fix this well. They don't always come down perfectly. Then we had one last week that as we pulled on it, we could kind of see it was spinning a little bit. This isn't a big articular piece, so we want stability. We want it down. We don't need to spend an hour trying to get the piece to spin perfectly. We just want to get some added stability. These are small pieces. The sutures can work. So the algorithm for terrible triads has been published, and I think there's some reasonable agreement on this. Pew in 2004, fix or replace the radial head, fix the coronoid if possible is what they did, fix the LCL, that's really important. And then they did put on some X-fixes or fix the MCL when they felt like those other things didn't take care of it. Other studies have shown MCL repair is not necessary. That's For me, if it's a terrible triad, if things are really, really unstable, I might go and fix the medial side. In the study in Pew, really good results. So the terrible triad was this injury that people saw: fracture of the coronoid, fracture of the radial head, there was a dislocation, and back 25 years ago they should know what to do, and the results were bad. But when we get to these acutely, they should do really well. I'd rather deal with this than a medial coronoid fracture that needs surgery. It's a simpler surgery. So for me, so recommendations for posterior lateral rotatory instability, terrible triads. We can approach them either posteriorly or through lateral and or medial. I've gone, as I've spent more time in Ethiopia, I do less posterior incisions and more medial lateral. If one was going to do a posterior approach, the advantage is that it's forgiving. We can just lift the skin and make different deep intervals. The disadvantage is big flaps. We got to take a big flap to get lateral to do the deep work, and you can get necrosis if you're not careful, or just seromas that can lead to infection. So for a terrible triad in Ethiopia, we had one this week. We went lateral, and we didn't have to go medial. Less dissection, less sub-Q dissection. If it's a straightforward case and you can get to the coronoid and treat it through that lateral approach, just one incision. If you make changes to the plan, you might need to make additional incisions to go medially to fix the MCL, but that's not a big deal. Swelling might make things difficult. Usually the elbow, the epicondyles are pretty palpable. One of the things I've not wanted to do medial incisions for is because of the cutaneous nerves, but typically the incisions are such that they're distal, they can be retracted. I think intentional sharp transection of the medial antebrachial cutaneous nerve is probably not the end of the world. If you do it sharply, you should avoid neuromas. The patient may have some permanent numbness around the incision. That's something, if you need good dissection, I'd rather do that than, if I can't immobilize a branch of the cutaneous nerve and I need the exposure, I'd rather sharply transect it, have some permanent numbness, and avoid a neuroma, and stretch it and tear it. So do what you're comfortable with. I think dual incisions make the most sense in Ethiopia. I think for this terrible triad problem, you must repair the LCL, you must treat the radial head. If you have a really large coronoid, I like to fix them. You have to be concentric, you have to be stable on the table. You have to look stable, feel stable. So what do we do if we don't have a radial head without metal? We can use polymethyl methacrylate. This X-ray was shared with me. I apologize, I forgot who sent it to me. But that's obviously a 3/5 screw with some polymethyl methacrylate formed around it. And then there's a technique we tried this past week, utilizing syringes to preform polymethyl methacrylate radial heads. So this is a good idea. And I think if you're going to treat complex elbow trauma and you can't get radial head replacements, making them even ahead of time makes sense. We're going to try to figure out going forward how we can kind of have some algorithms that work with multiple sizes so they have things. So again, if the anterior band of the medial collateral ligament is really, if instability is a problem, you've fixed everything, things are kind of all set and it's just unstable, maybe if you're looking at the MCL you can fix it, or if you really need to go there, go there. You can think about this coronoid flex with capsule. Some people think it increases heterotropic ossification. I tend to fix things that I can see and get things moving. And then we're not going to talk about fixators. I think most of these should, especially if the surgeon is getting comfortable treating this trauma, we should be able to avoid fixators. If there's some sort of just horrible trauma, maybe there's soft tissue loss, no way to fix the LCL, but there's enough bone to maybe get things to heal. Here in Ethiopia, probably what makes the most sense as far as fixation would be a spanning plate. So I've not done that, I've seen that. We can span the plate from ulna to humerus, split the humerus below the radial nerve, temporarily span it, and come back in 2 or 3 months once the soft tissues have healed. So that's probably the best recommendation for bailout here if we can't get a good reconstruction and elbow fracture dislocation. This is a simple case, well not simple I guess, but this is a case, posterior lateral rotatory instability. This actually was open with a brachial artery injury. I had the vascular surgeon fix it. But the neat thing was, this was an anterior exposure of the coronoid and the radial head. That's unusual, so I came down with a screw and a funny little plate and did a tripod fixation of the head, and that worked well. Fixing radial head fractures with cross screws is good, and that would be my recommendation. If you have access to preferably smaller than 2.7, that's the problem here, is getting small enough screws. 2.7 can work, 3.5s are way too big. 2.0s are probably great, 2.4s are really good too. So if there's any way to get a small modular handset, the other problem with equipment for this is these screws need to be relatively long, 28, 27, sometimes even 30 to get the angle. But Graham King in his lab showed that cross screw fixation is very strong, actually stronger than a T-plate. So a non-locking T-plate is not as good as cross screws if you can get them in, and then you don't have to worry about impingement of the hardware. And you know, also, if you have access circumferentially, which you do sometimes, depending on the pathology, you can put that screw head anywhere you want as long as it's countersunk. You don't have to worry about the safe zone. So it's a pretty forgiving technique. So that's a little bit of everything, but I wanted to, and that's terrible triad. So now we're going to go on to posterior medial rotatory instability. So it's a fracture subluxation, it's coronoid, and the LCL fails in tension. It's a varus injury, it's a posterior medial injury, and there's some rotation as well. So these are subtle injuries, or they can be subtle injuries. These don't even project that well, but if one looks at these, there's something not quite right with the medial coronoid, and when if we examine under anesthesia and we put it on a straight varus, we see that kind of like a tibial plateau fracture, there's a depression into the coronoid medially, and there's a distraction of the radial head. CT scans can show these injuries with more detail, and some people, I've shown some of these studies to people, and they'll say, well, that doesn't look that bad. I probably would leave that. Usually, and I don't know if I have it on this one, if we get the right sagittal view, we'll see that there's actually a subluxation of the distal humerus into the defect. And if that's the case, these typically don't do that well. Now, Foria has published a study looking at non-operative treatment of these medial coronoids, and if there's enough concentricity and they're kept in flexion, they can do okay. My comment would be, you want to really prove that the joint's concentric. If it's not, they're not going to do well. So treating these in flexion is a possibility, but we have to be careful that we're not fooling ourselves. So get a CAT scan if you have access to a CAT scan. Otherwise, really good laterals. If I would treat one of these non-operatively without a CAT scan, I'd probably get an X-rays every week just to make sure that the joint's staying concentric. If I can do that. Upper right, we see that again subtle, but there's just a loss of congruity on that medial aspect of the ulna on the coronoid. And this is a loaded, imagine that's a tibia and someone's walking on that. It's going to rapidly go on to arthritis. Well, we're not walking on it, which is good, and the elbow can tolerate stresses, but when we're reaching for something, and that varus stress, the weight of the arm, the long lever arm, there's a lot of stress there, and these will rapidly go on to arthrosis if not treated. So they can be subtle, but significant. So the mechanism of injury is a fall, outstretched arm, often a bike. In the States, people are riding something and their arms slightly bent. There's a varus stress. The torque's different. They're pronated, not supinated. And then with the combination that drives the elbow forward, the humerus rides forward on the ulna and it rotates in. It distracts the lateral side, pulling on the lateral side, pushing on the medial side, driving the distal humerus into the coronoid, fracturing the anterior medial coronoid. And sometimes they're not subtle. So this, I don't know if this is important. But the medial trochlea rides up and it punches into that coronoid. And if it's big enough to do this, it's going to probably be big enough that it would be repetitively unstable, and it's going to wear. Now, I had mentioned the posterior band of the MCL connects the medial epicondyle to the back of the ulna, and that's torn here as well. And that's a secondary stabilizer that I think there's more understanding about in the last couple of years. So they can be subtle, but the tips are the radial head's intact. There's no apparent dislocation. There's something wrong with the coronoid. It's not quite right. They can be severe, where the ulnar head or the ulna is coronoid fracture is so large that the distal humerus just rides forward. There should be a wedge sign. Things should get narrower as we look medial. There's distraction if we distract, but not always distraction on the lateral side. and this one doesn't project great, but there's a double cortical line. My advice is to get a CAT scan if you can. When these need to be fixed, we need some sort of a buttress. If there's a small enough injury, we may not be able to get any screws. We may just contour plate if we don't have a commercially available one. And we can contour plates. You can even use a 1/3 tubular embedded like a spring plate in the pelvis and use it to push down on that and just adjust in the right position. This is a case that was treated by a partner of mine. Post-op, I looked at it and I said, here's that, you can see that distal humerus is riding up. It's not concentric in the ulna. That's going to be a problem. That piece is too big. The ulna needs to be reduced. And while there's different ways to do this, back in whatever year this was, I just went ahead and opened it up, got a spring plate on the coronoid, wired the coronoid as well, and got that ulna concentric. And I actually left the radius dancing at an amusement festival and fell. And these are the x-rays. So we can look at this and say, well, it looks concentric. You know, if the medial edge of the humerus is in line with the medial coronoid, and laterally I don't see that the distal humerus is subluxed really improperly. Although if I look at that radial head, there's a density, I can see the coronoid's pushed out. So this is worrisome. This by itself should be very worrisome. I don't like that. Again, I think of it like a tibial plateau. But when we get the CT scan, we see this piece, but we see more importantly, the distal humerus is articulating on nothing for a large portion of its articulation. So again, I did not do an extended medial, I did a small split and fix that way. And with these injuries, this is medial and lateral incisions. Kind of hard to see, but that's a lateral incision for a lateral collateral ligament repair. So what's the algorithm for the varus posterior medial rotatory instability? It's fix the medial coronoid or support it. If it's a chronic injury, it's reconstructed with graft, and that can be radial head, which I wouldn't do unless I can't use the radial head for something else, which is possible. Rib has been described, which I've not done, the costochondral cartilage, which is interesting. There's a potential for things in the foot or proximal tibia even, but then the morbidity is too high. There's a discussion about using the ipsilateral olecranon, which I think is a bad idea. It can fit, but now you're destabilizing that part of the elbow. We want to fix the LCL, and then the posterior band of the MCL does have some role, but that's kind of developing, and we typically don't address that unless it's a chronic problem. So we went over posterior lateral rotatory instability and how that creates terrible triads. We just went over varus posterior medial instability, and now we're going to go into transolecranon fracture dislocations and Monteggia variants. So now the distal humerus drives through the olecranon and fractures it. The coronoid may go with the proximal piece, it may go with the distal piece, or it may be on its own. Coronoid's critical. We've got to look and find it, see where it is, get a CAT scan. Radial head may be fractured, want to save it or fix it. We want to use strong plates or double plate. There's a little bit of a watershed area where these fractures occur, and then if the radial head is tenuously fixed, we lose that buttress as well. So we need to have a strong plate or dual plated. When we see these injuries, we want to prevent them from going down the wrong direction. We have to find that coronoid piece and fix it. And getting it, if the radial head is not going to be fixed well, I think it's just better to replace it. And now with the idea of using a polymethyl methacrylate radial head, I would argue that it's better to do that than to do, if you don't have small implants to fix the radial head, if the radial head is too smashed, especially in an elderly patient who has poor bone, someone who's not 20, then I would put an implant in. It gives if you put it in properly, it allows you to build the ulna up. And these injuries, we typically work from inside the fracture, so the olecranons flip back, leave the anconeas attached if you can, and roll it off to the side. Build that coronoid back to the ulna. Get to the point where hopefully it becomes a simple olecranon fracture. You can pull that back over and fix that. This patient actually did well in the sense that she had a really nice reconstruction, but she had a lot of pain from arthrosis. It was such a bad injury, so I ended up taking the hardware out. Eventually she had an elbow replacement. But we can see the whole coronoid's been reconstructed. Things aren't too wide because we've got the fixation, and the height of the coronoid's been restored. So this is the first slide that I spent time on, back to pattern recognition. If it's tip, anteromedial, or base of the coronoid, we're gonna think about what the mechanism is, posterolateral, posteromedial, or transolecron, and then treat accordingly. So this patient came to me 4 months after an injury. Anybody see anything on this? Does this look normal? Hopefully after this talk, no. Johannes, what can you tell me about that x-ray? What do you see as not normal on that x-ray?
The ulnar joint is posterior is narrow.
Uh-huh.
On the lateral arm.
What do you think laterally between the radial head and capitellum? What would you say about that? Widened? Widened, yeah. And then on the smaller groups, you can I want you to recognize a pattern. You know, look for the coronoid, recognize the pattern, and think about how am I going to treat this, right? And is it coming? Here it comes. That's all I wanted to do on elbow fracture dislocations. There it is. That's my email address if anybody wants it. So thank you for that. Any questions or thoughts or about elbow fracture dislocations? How about a show of hands of, has anybody seen an elbow fracture dislocation, acute or chronic? Yeah, okay. And then we'll do a show of hands. I'll say, put your hands up if you think most of the elbow fracture dislocations you see in Ethiopia are chronic. Are most chronic? Yeah. We saw 2 acute ones this past week. I thought we were lucky. We're blessed to see the acute ones and treat them. It's an easier animal at that point. So we're going to go on and do physical examination of the shoulder and elbow. And
for non-operative management?
yeah. So the question is there any place for non-operative management in terrible triad? Great question. Again, never say never, never say always. I think anything's possible, but I think most of them need to be treated. So is the joint concentric? If the joint's not concentric, I think you have to treat it because they're going to stay statically subluxed, and that's going to be a problem. Is the joint concentric? Is probably the main thing. Is there no fracture fragment is going to be a problem later, I suppose. So if somebody had because remember we said terrible triad is almost like it's a simple elbow dislocation. It's kind of just beyond it with chips and bone off. So simple elbow dislocations can be treated non-operatively all the time. Should be treated non-operatively almost all the time, unless everything's stripped off and they're hanging apart in the X-ray, not concentric. So we have a concentric elbow dislocation. It's been reduced as concentric. There's a small fracture, type 1 tip. So it's subtype 1 of a tip, right? So small, and the radial head is just knocked off a small periphery. Sure, I think that's reasonable. I would watch that and make sure that they don't come back subluxed or worse yet, dislocated. So I would have that patient come back for an X-ray at some point. I would advise them to avoid abduction of the shoulder so that they're not getting that valgus for at least 3 weeks. I'd have them working on rotation, inflection, so they're not rolling off. We don't want them working on rotation like this because they're going to roll that radial head off and maybe cause a problem. And I want to get them moving though. Gravity motion is great. So lying on your back, imagine me on my back and I'm going like this. What's nice about this is varus valgus is neutralized if I'm flat on my back. So having them do exercise on their back, kind of letting gravity come down and extending up. The gravity also helps hold the ulna down and follow them. So I think it's very reasonable to do that. That's technically a terrible triad. Now if the head's a real big head for fracture piece, and let's say you're not gonna, maybe you can't fix it, for you're in an environment where it can't be fixed, or the patient can't be fixed. Another option too is to try to figure out where the palm was when they dislocated, because that's the piece of the head that's missing, and maybe you spin them in a spot where there's some head that's still going to provide some support. So you might have to get an X-ray for that, but maybe most likely they came out like this, so you're probably not going to have them supinate for a while. So they can work from here to here, neutral pronation, to keep some of that head engaging and then moving. And they might have, if they have a big enough headpiece, they might have less than optimal rotation, but they might still do fine. But you want that ulnar humeral joint to be concentric. That's the bottom line. That's a really good question.
So how long in a splint?
How long in a splint? So, there's a lot of cuff and collar I see in Soto, which I like, because when they're up like this, and then there's not a lot of obesity too, which is nice too. In the States, we have a lot of people with big bellies or breasts, and because of that, they're kind of spinning that arm down like that. But in someone in a good body habitus, with a cuff and collar, that flex position, I think is probably better than a splint here. With the weight of the splint coming down, and they're kind of sagging down. So if they're in a cuff and collar and they're up flexed, I would say leave them there and come out, and they could even be working from 90 up right away. So I don't know if they even need a splint so much if they're going to be up here and be compliant with it. Otherwise, I'd say 3 weeks, and I'd watch them closely. Depending, again, it goes on the size of the coronoid, the size of the radial head.
I have a question.
Yes.
So how often do you see an anterior elbow dislocation?
Anterior elbow dislocation? I've never seen one, but I'm sure it's, so is the ulna intact or fractured?
Coronoid is fractured.
Coronoid's fractured? How about the olecranon?
Intact.
So the whole thing came forward?
Yeah, I
Yeah.
had one case when I was in Kawasa,
Mhm.
Nashi.
Mm-hmm.
So we attempted the growth reduction
Mm-hmm.
few times, but third, as we were preparing the patient for an open reduction,
Mm-hmm.
I think it's due to the muscle relaxation,
Mm-hmm.
it has somewhat become easy and
Reduced.
reduced.
Yeah. So the whole thing, was the triceps intact too, do you think? Yeah. And what was the mechanism?
Stable after
Yeah.
the reduction.
Yeah.
So there isn't really literature.
Yeah. It's like a divergent. Have you heard of a divergent? I've never seen that either, where the humerus comes between the radius and the ulna and separates the two. So it's like, and we know from what we do, there's always something that's outlined, doesn't quite fit. And that's why these things are important, and talking about the patterns are important, but we have to use our head and say, this is not quite exactly what I heard about. It's not exactly, because sometimes I think that depending on how that humerus drives through the corner, I think there's a little bit of, in the exact angle, there's variations on this. So things can always be a little different, for sure.
So how would you go about the growth reduction?
For the anterior,
Yeah.
well, the humerus had to have slipped between the, because if the triceps is intact, it couldn't have been, it had to come around one way or the other. So I would probably try to figure out which way it kind of came around and unwrap it. I don't know. Yeah. When you fell asleep, when you were asleep for anesthesia, you got it in.
Yeah.
Where, how did you do it?
So
Was it traction or?
the traction didn't help.
Yeah.
We did it with somewhat a relaxed position,
Uh-huh.
and just what we did was we pushed the distal forward
Mm-hmm.
to the lateral direction,
Okay.
and when we bring it back, it relocates.
Yeah, so you pushed lateral, so it must have had to come around the humerus that way. That must have been where the hole was medial then. And all the nerve was good afterwards?
Yeah, it was,
That's awesome. Yeah, yeah. We're always surprised, right? Always surprised. Okay, so examination of the shoulder.
So he was a young guy. He was hit by an accident. It was an anterior directed force from the posterior. To the box. I think it was a metal bar.
Oh, hit with a metal bar.
Yeah.
All right, so examination, physical exam of the shoulder and elbow. And this, down below, Jerome Sure, a friend of mine from Sydney, and Julia Lee out west in the U.S. sent me some slides, so we're kind of mixed in here. So I want to acknowledge that. So before we're going to talk about physical exam, I want to go back to what my chairman always taught me from residency, and that's 90% of what the diagnosis will be determined based on the history. And so he used to tell a tale of the patient who comes in and they get an MRI and they can't figure out what's wrong with the patient, so then they get an X-ray, and then they still can't figure out what's wrong with the patient, so they do an examination, and they still don't know what's wrong with the patient, so then they take a history, and then they get the answer. So always start with a history. And it's important to figure out, not just for what's wrong with the patient, but what they need going forward and what kind of results are going to be acceptable for them. Get their age, their occupation. As a hand surgeon, I'm always asking about hand dominance. Obviously here, eating, people will eat with their left hand, but most people don't. So, it's so important to have that ability to supinate and flex enough to get the injera to the mouth. any sports activities, and then what sorts of injuries have they had in the past. We want to know the basics. We want to listen to people when they talk about, and we want to flesh out of them onset, duration, trauma, where, nighttime pain. Nighttime pain is pretty interesting in the shoulder. I think it does lead us to certain places. What bothers them about their shoulder or their elbow? What goals do they have? What do they need to do? Sometimes when it's super complicated, in some of these cases we see down at Soto Christian Hospital, I just want to know what are they hoping to get out of this? Because sometimes it's also aligning expectations. Somebody comes in, they've been massaged by the Wogesha, and they have a complication with a Volkmann's ischemic contracture. It's one thing if they want their position better in their hand, but if they want a normal hand, that's probably not going to happen. So you want to make sure that you're relaying realistic expectations, but you need to understand what they need as well. So history. And then in the shoulder, I find, and I think other people agree, when I was looking at slides from my friends, they had similar, this is from one of them, we can kind of get those common things happen commonly. Impingement or rotator cuff tendinosis kind of comes on gradually with repetitive activity. Cuff tears, especially in younger people, it's heavier activities, it might be a fall, but it can just be a long-term wear and tear, and that apoptosis we discussed. Instability is usually a fall, external rotation abduction, fall directly on the shoulder, or some people who lift heavy weights and get a C-joint pain or problems. Falls cause labral problems. Adhesive capsulitis is usually atraumatic, often relatively quick onset. People will wake up feeling pretty bad and have a lot of pain. Same with calcific tendinitis. And then ages break down the common conditions, cuff tendinitis. The cuff problems as we're younger aren't tears. We have more problems with instability, maybe some calcific tendinitis. Continued problems from our 30s and our 50s with rotator cuff impingement or tendinitis. And then adhesive capsulitis, especially in the US, for me, I find that women in their 40s and 50s, pretty common. Calcific tendinitis, kind of the same group. Diabetics have a higher incidence of adhesive capsulitis. And then we start to get past our 50s, we see rotator cuff problems. The biceps plays a role kind of throughout. It's usually less of an actor, but having lived through it myself, long head biceps pain can be pretty significant and very disruptive. For instability, get the history, the degree of the trauma, position of the arm at the time of dislocation, frequency of instability episodes. Dead arm is more common in that Ambry pattern, where people have that multi-directional instability. The arm kind of goes out and feels dead for a while. The associated symptoms are important when we're talking about the shoulder, especially if you want to make sure you don't have a neck problem. Look for subtle instability symptoms when people would throw and sport in prior medical treatment. I think when we talk about shoulder and elbow, it's important to take care of and think about the overlap with the cervical spine. That's an important thing that we want to think about pretty much right away, because if we don't, we're going to get caught going down a pathway of thinking shoulder, 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 maybe elbow, and then we miss the real problem, and we wonder why people don't get better with the treatments we're prescribing. So cervical pathology can be posterior, it can also be lateral shoulder pain. Probably for me, one of the key things is not related to shoulder movement. It's usually that more neurogenics or a dull, boring pain. But find from the patient, is it activity related? Does it get worse when you move a certain way? And then with that, if we're going to do a more detailed examination, you can do lidocaine injections. So if somebody has significant pain, we think it's their rotator cuff, but we're not sure it might be their neck. Give them a subacromial injection of lidocaine, wait 20 minutes and do the examination again. Cervical pain is obviously not going to go away if it's an injection in the shoulder. Pain that radiates down past the mid-arm, I worry about that not being in the shoulder. It usually isn't. It was in the elbow, forearm, and hand specifically. Of course, people can have carpal tunnel syndrome and a shoulder problem, so we have to flesh all of that out. Ask about paresthesias, numbness, or tingling. See if they're overusing the shoulder at work or with activities. The slide that I swiped from my friend, he had at completion, he said, when you're all done with your shoulder exam, do a neurovascular exam and a C-spine exam and a ligamentous laxity test. I actually would say start with it. I have a little cheat sheet in my office, a piece of paper when I do an exam. I'll just jot down some notes. And the first thing at the top is neck exam, because I was finding that I didn't examine the neck or ask about it when I saw shoulder patients. So I always try to ask about it. Does your shoulder pain get worse with neck motion? How can you reproduce your shoulder pain? I do a brief examination, just at least check motion, check for worsening symptoms, document their range of motion. Ask about numbness or tingling down in the hand, have them move their hand and make sure it's okay. If I'm more worried about it, I'll do a more specific myotome examination where I'm checking the strength, C5, 6, 7, 8. You guys, 5 is deltoid, 6 biceps, 7 can be triceps, 7 can also be wrist flexors, wrist extensors are 6. C8 is digital flexors, T1 is intrinsics. So document that, and then if you're worried about somebody who might have some instability, you can look at ligamentous laxity. So know your dermatomes, know your myotomes, be able to do a cursory examination of the shoulder. And so the first thing, so once we do that, we take a good history, we check the neck, we double check to make sure nothing's going perfectly. Now we're on the shoulder examination, do an inspection, and that means have some modesty can be maintained, but have a good inspection of the whole shoulder girdle where we can look for atrophy, look around and include the scapula and look for symmetry. Do side to side. Is this patient on the right severe deltoid atrophy? We should not see that much of the acromion in anybody, even someone who's thin. Look for winging. It can be static. When we lose the serratus, the lower part swings in and it wings out. When we lose the trap, it sags down, but there's still a little bit of winging. So it's subtle, but there's a problem. But the first thing is to recognize the asymmetry, and then look for motion. I'll usually have patients forward flex and abduct and look for symmetry. And if I think they're winging a little bit, I might even have them lean against the wall and do a push-up and look for it to be asymmetrical. Sometimes, or a lot of times, the winging is dynamic. They'll move and it just will be asymmetric. It's like a limp. But when we have them stress, lean against the wall, the scapula does go against the serratus fires, and it will go against the thorax. They don't wing like someone with a loss of that muscle. We want to look at it and look for symmetry and look for motion. So this is a good video of some scapular asymmetry on the right there. So something's, so 94%, this is from Julia's slides, 94% of labral injuries have some sort of scapular dyskinesia. It can be the thing that starts the problem, or it can be the thing that results from the problem. So sometimes I tell patients that they have a labral problem. It's like having a pebble in your shoe, and every time you step it hurts, and I used to limp funny. It can be that labral tear is causing the scapular problem. As she pushes down she's pushing down and having him forward flex, we see that scapula really come and kick back. So I'm worried about this guy's serratus at this point. This isn't my patient, I don't have this pathology. I would have him push against the wall too, and then go and get an EMG. But look at that, because it plays into it. If someone has labral pathology and they develop some secondary scapular problems, then we want to have the therapist working on that. From inspection, I usually do go to palpation, including the contralateral side, looking at the I started the SC joint. Number one, it's usually not a problem, so it's a place to touch somebody and they're not going to jump off the table. Start there, palpate either along the clavicle or definitely at least to the AC joint. I see a fair amount of AC joint pain, but you need to go side to side and make sure that's where the problem's coming from. Palpate along the acromion, coracoid, right off the acromion anterior cuff attachment, bicipital groove, scapular spine, periscapular region as well. And get a sense for any areas of pain, again looking side to side. If we're worried about AC joint pain, we can actually cross adduct. This is very non-specific, and unfortunately a lot of these shoulder examination parameters are not, or tests are non-specific. AC joint pain, that can be confirmed with an injection lidocaine. So if someone's hurting crossbody, or if they push back against that crossbody and they hurt, you can inject lidocaine in their AC joint and see if that takes care of their pain. AC joint hurts obviously here, but the referred pain can be down into the area of the rotator cuff, typically not the same as the cuff, which refers down in the lateral aspect of the shoulder. So we look for that and try to determine that. Injections, selective injections can be a strong, a very powerful way to determine what's causing some of this pathology. We want to check range of motion for flexion, abduction, which is in the plane of the scapula, again side to side, rotation at the side. I like to bring people out into a natural degree of abduction of 90 and have them externally and internally rotating. I understand that their scapula is moving, but I'm going to check side to side. So in my office, this is 90 and this is 90. I understand that this is not true glenohumeral motion, but we're looking for differences side to side. However you document it, be consistent. If you're watching somebody get better or worse, you want to be consistent. But also realize that the way I have a colleague that puts people on a table and he stabilizes your scapula, and he measures internal rotation that way, so his numbers are going to be much lower than mine. So just be consistent with how you measure it. Internal rotation is also measured with the thumb going up the back and the corresponding vertebral body. So document your range of motion. Again, check the neck. Be consistent with your scapular support. As we're moving, if somebody moves very well actively, or I'm sorry, passively, their passive motion is very good, but their active motion is poor, then we know they have a poor motor. And either the rotator cuff's not working, the end unit of the motor, or neurologically, the input, the electrical signal of the motor is not working. Maybe it's from pain, but usually they have a lot of pain, they're not going to let you passively come up there. If active equals passive, they're both reduced, we know that there's either adhesive capsulitis, or osteoarthritis, or maybe even a large posterior shoulder dislocation. A simple X-ray should determine what's going on there. Occasionally I see patients in the office, they come in and they've got their active motion is poor, their passive motion is poor, and they've come in with an MRI. They've got end-stage osteoarthritis, the MRI is really not needed. X-ray would have shown us that, right? So sometimes, I always start with an X-ray. I never start with an MRI in the shoulder because an X-ray will show us some things that the MRI won't very well, like calcific tendonitis. Sometimes it will allow us to not even get the MRI, and then it will also sometimes show a little bit more detail or different details on the osteoarthritis as far as locations and whatnot compared to the MRI. So be mindful of how the scapula plays in the range of motion. Start to test for the rotator cuff. Job's test or empty can test. We come in the plane of the scapula, thumb down, to hopefully emphasize or mostly utilize the supraspinatus, checking strength against resistance. Side to side is important. Strong people can fool us. We can be testing the supraspinatus. They can have a full tear of the supraspinatus, and this may be normal if they're healthy and active and strong, and we're not maybe pushing hard enough. So this is a good test, but like all of them, they're not perfect. Checking resisted external rotation, which is mostly infraspinatus. I tend to try to check this out abducted a little bit. I think people can brace against their body and probably fight a little bit harder, so I'll bring them out a little bit. You can try to fatigue people as well and see if they'll tire out and show you that they have a weak rotator cuff. Subscapularis is tested how? It's liftoff is one way, so we're lifting off. The other one is belly press or abdominal press or Napoleon test. So supposedly, with one study I read years ago, this is upper and this is more lower subscap based on EMG, but we're coming here and we're pressing. Someone has to have good internal rotation to show both these tests. So if I have poor internal rotation, I can't physically bring my elbow here. So the first thing, or if I ask somebody to do this and they can't just mimic me right away, I'll usually grab their elbow and pull it forward and ask them to hold in this position. If I can put it there and I say hold this and they go like this, their subscap's not firing the right way. Likewise here, if I can lift them off here, like if they can get here and I say lift off and they say I can't, and I can't lift it off either, it's not going to go. I don't know if their subscap's working or not. But if I can lift it off and I ask them to hold it there and they drop, or I can lift off and I try to check resistance here and I push and they can hold it. If they can't lift it off, their subscap's not working. So this is a pretty good test. Bear hug test is another subscap test. That's Steve Burkhart described that where we come here and we push here against the shoulder, and we here just put your arm. You want to just put your hand here, and I'm just pull it off a little bit there. So you hold and I pull. Yeah, hold. Yeah, so I'm pulling. So that's subscap 2. My subscap's pretty healthy, and I had a biceps, long hand biceps, bad tendonitis with a subluxation. That hurt a lot. So I think that's a lot of crossover between the subscap and the biceps and the bear hug. So useful, but not very specific. So there's impingement tests, which again, useful, but not specific. So NEARS is straight up. NEARS or JOBs sometimes. JOBs. So this is NEARS, and also some people describe it as JOBs. JOBs test is when you do that and you inject lidocaine and see if the pain goes away. Hawkins sign is this way, right? So we're coming in and internally rotating. We're trying to impinge the cuff under the acromion. I think these are useful tests, but they're going to be painful in adhesive capsulitis if it's early. They're going to be painful with cuff tears and impingement and tendinitis. Impingement and tendinitis are kind of the same thing in my head. So they're helpful. Nears might be bothersome, and same with Hawkins with labral pathology. So going back to that history, when I see people who are painful here, I've hopefully already asked the question, where is your pain? Because when someone tells me their pain's deep in the back, and I say, is it kind of inside? And I say yes, to me that's labral. When someone says their pain's down here, my next question is, does it bother you at night? Yeah, I can't sleep very well. That's rotator cuff. If it's here and radiating down here, it's more AC. So while these tests are important, if the patient said they have deep posterior pain or pain deep inside and these tests are important, I'm thinking it's painful because of the labrum. If the patient told me they can't sleep, and it hurts when they abduct and their pain comes down here, and these tests are positive, I'm going to think it's more the rotator cuff. So these tests are helpful, but at least for me, and the way that I think, they don't differentiate between certain pathologies without the history of what's going on, and specifically where the pain is. And again, injections. Selective injections are really helpful around the shoulder. I don't always put a corticosteroid in when I do these. It depends on the age of the patient and the problem. But if I can't flesh it out, is it your biceps, is it your AC joint, I'll inject one of them, re-examine them. Maybe especially if they're a patient who's not super young, someone like my age, I might inject cortisone in their AC joint and say, okay, come back in 2 weeks. Let's talk about how you're doing. Keep track of it, because even if you're completely back to where you were when I saw you, I want to know how you were for those 2 weeks. So if you need to write it down, write it down. If they come back and they say, all my pain was gone, it was awesome, but now I'm hurting again, we might be thinking about doing something with their distal clavicle for arthritis. If they say there's nothing helped at all, I might try an injection in their subacromial space, and then if they say that helps, I'm thinking it's more the rotator cuff. So the tests are important, but if we add lidocaine, it becomes really powerful. Instability tests, we talked a little bit about this with the instability exam or topic. There's multiple different tests. It's very hard to get most patients to relax and do these awake in the office in a super meaningful fashion. I think apprehension relocation is probably the best. This AP draw, or what I think of more of a shift and low, we push in and we just are pushing back and forth. If somebody's really, really lax, that MDI patient, that Ambry patient, they might be real sloppy. They might say they don't like it, but typically they'll let you do it, and it doesn't give you a lot of information. For anterior inferior instability, that apprehension test is probably the most useful thing I do. As soon as you lay somebody down, you start to bring in this position. A lot of people don't want to be there. There's no reason to dislocate their shoulder, but you can put your hand on the front, push a little bit, and ask if that makes them feel better. That's a relocation test. Usually it will. Sulcus is based a lot on body habitus and ligamentous laxity. I do it to document it, but it's hard to know what it really means. You can pull down and see a sulcus, but a lot of times they'll have the same thing on their asymptomatic side. So it's more the Ambry patient who has it. You can document it if you're thinking along those lines, but it doesn't drive my treatment very much. Jerk test has kind of the name is almost a misnomer. I don't like the name. It's just bringing somebody in an abduction and bringing them back. Some patients, and they'll tell you, these are the people who are usually more multidirectional, predominantly in the back, atraumatic, often women, loose jointed, and when they come across in this position, you can bring them, the head will slip out the back and kind of pop or jerk back and forth, in and out. So it's just looking for that back and forth in. A Kim test is a variation of that with loading the joint as well. So we talked about apprehension, relocation, sulcus. We talked about Neer, Hawkins. And this just kind of talks about a circle of different tests. Looking at the cuff in different positions, looking for cuff strength. The other infraspinatus that you can have, if someone has a really large cuff tear, they may have an external rotation lag. That's where, again, passive motion is different than active motion. I can passively bring them out to here. I ask them to move out there and they go like this. I bring them back out here, I ask them to hold it, I let go and they drop down. They lag. They lag in here, they're missing that motor. That's typically the infraspinatus. hornblower sign. If somebody has here it says teres minor, it's usually more than teres minor. It's usually a big cuff tear. Hornblower sign is when we ask somebody like to come out in here and touch their nose, and they're up here like this. They have to hyperabduct because their rotation is so poor. In the U.S., people sometimes will say they can't eat soup. So if I have a spoon and I want to come up here, if I have poor internal rotation, how do I compensate for that? I come up like this, and the soup comes off the spoon. So they'll sometimes give a clue that they can't hold that rotation in that neutral position. The arms drop down. They compensate by coming up here. That's the hornblower sign. So I'll usually tell people just to touch their nose like this. And if somebody has a hornblower, they come up with this. It's from the French, back to the French. The hornblowers used to hold the horn like this. So that's a hornblower sign. For a labrum, just like the impingement signs or the rotator cuff signs, not super specific, but helpful. O'Brien's is thumb up, thumb down across the body. You push down, so Johannes, take your arm, hold it across this way, hold here. So I have him hold that position. I'm going to push down, you hold it there. Good. Now we're going to roll the whole arm down. I'm going to push down, you hold that there. And pain down is supposed to be more indicative of a labral tear, superior labrum specifically. Not always a specific test. Dynamic labral shear test will bring somebody back into abduction external rotation. This is O'Driscoll has this test. And just kind of milking them up and down, looking for the shear activity to cause pain. Deep inside, that's a sign of a labral tear. Speeds test, arm out in front, pushing down, getting pain in the biceps, very non-specific. Looking for a Popeye sign for proximal biceps rupture. We talked about all that. And that's elbow. So very quickly, because Dwayne's up in 5 minutes. Elbow I think is simpler in some ways to examine. We want to document the range of motion. I mean, Dwayne, is this 0 to you? Yeah, and 100. Let people fool you. Anybody have a pen? Can I borrow your pen? What I'll do is because sometimes people you say supinate and they start kind of bending their wrist and fool. So I'll give them a pen or a pencil, and I'll say don't bend your wrist, and I'll usually do the other side, and then I'll go up like this. So now if somebody's missing motion, you can even get the goniometer out and look at it. And pronation, everybody's a little different. Like if I'm locked in here at my side and I truly pronate, that's my max pronation. So it's not even 70, right? So measure that, you get a goniometer and look at that. But that's a good way to measure because when you treat people, you want to know if they're getting better or not. And a lot of people are going to fool you. They're going to flex the wrist and flex through the wrist. You want true measurements there. Check the other side. Do a good, and then probably one of the, don't forget a good neurovascular examination when you're taking care of elbow, especially pathology, right? Check the radial nerve, check the AIN, not just the median nerve, check sensation, ulnar nerve, look for wasting of the first dorsal interosseous. Palpate, that's pretty straightforward. Pain can be indicative of when and where with more subtle things, and honestly not the sort of thing I see in Ethiopia at least. But if you have somebody with pain, is it in the middle of the arc? Is it an arthritic pain? Is it at the end? Are they impinging? Is it happening all the time? And check the motors, check for strength. There's special considerations like hook test for biceps, again, end arc pain. Instability testing is a little more subtle for subtle instability. We can talk about that if we want later. And Dwayne's up. I was going to just show one. I was going to lead him with this picture. So, so this is American football. I'm a Green Bay Packer fan, and Dwayne's a Minnesota Viking fan. They're down there. That's William Henderson. He was the fullback. Do you remember him? He was good. I liked him. This is just a great picture. Sorry. So Dwayne's going to talk about what do you have, Dwayne? What's your topic? What's your first topic?
Chronic elbows.
Chronic elbow disease. Why don't you fire up your computer? So, Dwayne's going to talk about chronic elbow dislocations, and like I said, I think I said this. That's something I never saw before I came here, and unfortunately, that's something that's pretty common here. So, Dwayne really has devised an operation for this, and Sean and he had
Both Black Lion graduates. Temeskin is our first Soto Christian Hospital orthopedic graduate. All of them are great surgeons. We know the cultural practices influence the patients that we see. We've had in the past huge volumes of chronic elbow dislocations at Soto Christian Hospital, and I think you guys must be starting to do them because we're seeing less. We're going to talk about the pathoanatomy of chronic elbow dislocations, the principles of treating them, and then I'm going to show a few of my mistakes. And but it is possible to have great results. We all know Geisha. Geisha. Frequently, there's no x-rays, massage, dressings, manipulation, delay in diagnosis, even for educated people. I hear that Ethiopian television actually promotes them. We frequently operate on chronic dislocations and stiff elbows as a result. So in 2021, we had 2 per month. And I think that you have to operate actually on anything over 3 weeks, maybe even 2.5 weeks. Frequently you see them at 3 to 9 months, not infrequent 18 to 36 months, and at the time that I first wrote this PowerPoint, we actually tried to do somebody in 10 years. I'm not sure that I did that, and I don't know the result, but patients lie sometimes, or maybe more than sometimes. As you know, we use a medial and lateral approach for most of them, preserving as much integrity of the soft tissue envelope as possible so that at the end you can actually repair it to the epicondyles and gain some stability. Remove the scar from the depths in the side of the olecranon, and all obstruction to concentric reduction. And that next line in bold is really the most important part, and that is you have to make sure on the table that you're actually fully and concentrically reduced. You have to look medially and laterally. It's harder to look medially than laterally to make sure you're reduced, but that's probably more important. And then repair the soft tissues around a concentrically reduced elbow to increase its stability, and then start as early a motion as possible. We started at 3 days, and so this is a patient at 3 days sitting up, moving his elbow. And then the biggest difference between the adult and the child, of course, is you want to preserve the periosteum in the child. It was actually Sami Hailu that brought that point to me. He says, well, how is the epiphysis going to live if you strip all the periosteum? And I said, oh, you're right. So you have to carry the dissection between the muscle and the periosteum in a child all the way to the articular surface. Otherwise, you're going to disrupt the blood supply. So that's how you do your medial lateral approaches. On the lateral side, you go right through white. I tell my residents, if you see red, you're not in the right plane. And you center your incision laterally, right over the center of the epicondyle, and then right towards the neck. Kind of that sharp J sign there. On the medial side, it's different. You preserve more tissue on the anterior flap so you have a stronger repair. So you go closer to the nerve. And parallel the course of the nerve in your is the triceps. The triceps really shortens the tricep. The biceps doesn't. And this is, of course, if the patient's fixed or close to full extension. And the ulnar nerve is short and ready for you to injure it. So loss of motion leads to stiffness of the muscle units, and after reduction, frequently your elbow doesn't want to flex beyond 70 degrees. Remember that your nerve is short, and I've done both, put it inside the joint or submuscular, truly submuscular, and also put it in the subcutaneous tissue. And I think it's better to stick it deep. There's less tortuosity in a shorter distance. Okay, bones lose density as they don't see joint reaction forces. So you've got two things going on. You've got short muscles and weak bones. Okay, so I remember right before my eyes, the resident reduced it, and then, of course, you know, they think they got big biceps, so they just go, and the trochlea just crushed. And that's, you know, that's not retrievable. It destroyed the elbow. So remember that your muscles, your big muscles can just destroy the patient's elbow, just like that nut crushes the elbow, crushes the nut. Okay, so you deliver the humerus out either through the medial or lateral one, whichever is easier for you. To gain that, you have to move back and forth, and you get into more difficult, then you go to the other side. Just keep going back and forth and gain a little bit more. And usually the most difficult part is between the coronoid and the posterior humerus, and sometimes you have to just cut that blindly so that you can completely free it and bring it out through the wound. Then have to remember also that scar becomes very adherent. And that years ago, I was doing an operation on a child, and I was peeling the scar off the distal humerus, and the whole articular surface came off in one piece. And it looked like the distal humerus, but there wasn't any bone underneath it. It was just articular cartilage, just in one huge piece. I didn't know what else to do, so I just stuck it back on and finished the operation, and it fused spontaneously. And that's the only time it's ever happened. But be careful. Try to use your knife more than just pulling and tugging on it. Okay, this is probably, once you actually get the humerus out, getting all that articular cartilage exposed on the olecranon is the most difficult part, and also removing the cartilage or the scar that parallels it, because that can prevent concentric reduction. So you have to kind of peel it, you have to kind of tease it, you have to try to find somewhere where there's cartilage, and frequently it'll be right here where you can start peeling it off. And remember also that this can be flattened, and so you have to kind of try to make this as normal as you can. Okay, so there's probably the biggest thing that prevents you from completely what you need to be worried about in terms of gaining concentric reduction is removing the scar here, in this area. And because especially in the depths of that, if that scar that's paralleling the olecranon is not removed, it prevents deep concentric reduction. Make sure that all that is completely removed. Shave it if you have to along the medial and lateral sides. Okay, so if that's what your humerus looks like, when it's sticking out, then you need to remove. I just can't get. So this is the coronoid, this is the trochlea. You can see this is where the radial head was sitting. So you have to shave that off, and then the olecranon, the olecranon fossa you need to clear out to try to make it as normal as you can. And So sometimes it's helpful to have an actual plastic bone in there in the OR so that you can actually fashion it to what it should look like. When you put your fingers between the coronoid fossa and the olecranon fossa, it should be paper thin. Okay, you can see in this patient his distal humerus is flexed, and the space for the olecranon is also collapsed. So you can see I did a green stick fracture of the olecranon. Didn't do anything to the distal humerus, but you can see it's a little bit more flexed than normal. Fortunately, this didn't displace. But sometimes you have to be creative intraoperatively. I think if I were to do this again, I might put K-wires and a tension band there, but be also sure that you're concentrically reduced. So if you have a radial head fracture, of course, as Rick's already told us, you're going to have more trouble with instability in your postoperative course. And so if it's a displaced, already healed fracture, you'll need to be maybe a little bit less aggressive in terms of your physical therapy and alter your postoperative regimen based upon what you determine on the table as your stability. You may need just to splint them for 3 weeks to prevent instability. This is a bad problem, and I don't have time to talk about this today, but the way I handled this originally was just to do a medial lateral approach, put it back in, and then 2 days later it was subluxed. Then we pinned it, and then we fixed it. So the bottom line is, if this is your presentation, go through the fracture and then completely expose the distal humerus. So one posterior incision, mobilize the nerve, create a naked distal humerus, and put it back together again. And fix this as rigidly as you can with whatever device you have, an olecranon plate or tension band. Okay. This slide shows you that even a senior surgeon can get in trouble. This was a visiting surgeon that went to an anterior and had a vascular injury. The anatomy can be very distorted, especially in a child, because the epicondyles displace. Okay, so palpate, palpate, palpate before you make your incision. Okay? Do your skin incisions, palpate, palpate, palpate. Okay? And your deep dissection should be through white. If it's not white, you need to step back and say, do I need to go anterior or posterior? Make the skin incision bigger, but don't go where it's red, or it'll become more red. It can be very, very confusing. This is the repair. I prefer sticking the nerve right there on the first slide on the right. Repair it through drill holes. And then frequently you're going to have to use a needle to in situ lengthen the triceps. I would just try to get the patient to 80. I wouldn't necessarily go to 90, otherwise you may have a crushed distal humerus or ruptured triceps or something. Okay, here's one of my failures. 31-year-old, 5 months out, did the usual operation. Here's her post-operative x-ray the same day. So she had a brachial plexus block, as 95% of our patients do. And this was taken on the way to the ward. I'm not sure if she ever had a sling on or if the x-ray tech took it off. Now you'd be tempted to just reduce that And I just felt like I couldn't do that, so I took her back the next day, repeated the soft tissue repair, and one side indeed was disrupted. I don't remember which. And here she is at 4 months. What's in the chart is full motion. I'm not sure exactly what that means. And she failed further follow-up. So if there's instability problem in the acute phase, don't just close reduce it. Assume that there's a problem. Okay, another case that I couldn't find was a subluxed x-ray on post-operative x-ray. And I don't know why this is such a problem. But at least my interpretation of this x-ray, which is not the patient I'm talking about, is that it's a little bit subluxed. But get true PA and lateral x-rays and send the patient back if you're not sure. And if the patient is not reduced, take the patient back. It's usually the scar around the olecranon. There's something obstructing a full reduction. Now you could flex it up more if you could, but don't hope for the best if there's true evidence pointing you another direction. If you're doing this for the first time, over-prepare. I have a 15, 17-minute video on ViewMedi. Look at it many times. Know the anatomy. Have a plastic model in the OR. Rehearse the surgery. I ask God for help. We do for every surgery where we work. If you need help in the middle of an operation, I've called Rick. You say, well, can I call you back? I'm having breakfast with my wife. But he did pick up. And I'll be available if you need me. Just give me a heads up and I'll try to be available for you. I try not to use a tourniquet, and I find my patients are happier. Start slowly, find the rent interval, cut only in white. It can be confusing. Protect the nerve, get the bony architecture as normal as possible. Make sure you get a concurrent reduction and confirm it carefully. And determine your safe zone and start motion on the third day. Unless you have a really young patient or somebody that's an addict, then I would just immobilize them for 3 weeks and work on stiffness another time. I think we're all ready for lunch.
Your repair of your bone is with Vicro, right?
Yes. Durable.
I have a question. One is for our patients who have HO, we exercise them, and the other is if it is unstable after the reduction, do you use pin to fix or crown to the distal humerus?
So as you can see from one of those, I did remove all the HO. If it's not preventing you from moving,
What about using K-wire to fix if it is unstable?
I have not done that, except for the one that I've showed you about. You guys remember anywhere we pinned? I think if you don't have fractures and you follow this protocol, I don't see why you'd have to do it.
Probably with tendon triads, fracture dislocations.
That are chronic, you mean?
Chronic fracture dislocations.
Pins across any joint. I know you do it for 3 weeks in the shoulders.
10 days.
Or 10 days, okay.
A week.
A week. But in the elbow, the lever arm is so long, and the bone's so small, and the forces are so great. I really worry about bending, breaking, and I would try not to do it. Hopefully there's enough stability by positioning. Usually, of course you're fighting, using the triceps if it's tight can be helpful to get that compression.
I think if you flex them up to the point where they're tight, I don't see that you need.
I would say just limit their extension as a protective mechanism before you do that, for sure.
Have to go ahead and intraoperate to leave the trachea just sheared off, and we did not know what to do, so we just simply reduced it and we stabilized the patient. My question would be, how would you go about the rehabilitation if that was to happen intraoperatively? Because we splinted him for about 4 weeks, and the elbow ended up being stiff, and the patient was actually.
I understand your question to be, you suffered an intraoperative complication, a fracture. And to protect that fracture, you put him in a cast. And then stiffness resulted. I think you handled it properly. Now you just need to go back and do another operation to gain the motion. I think one principle in orthopedics is you can only tackle one major problem at a time. Okay, so let's say you have a patient with an infected, non-union, stiff knee of a femur. Okay, infection, non-union, and stiffness. You try to attack all three of those at once, you will fail miserably. Okay? Now you can treat, first thing you need to do is treat the infection successfully. Next thing you need to do is treat the union successfully. Then you treat the lack of motion. You try to do too much. If you try to tackle 2 or 3 of those all at once, you will fail. Fortunately, you can go back. So what I would do to that patient is just take them back and do it. You know what my neck top is? The stiff elbow.
When should we give up trying operation of chronic illness?
When should we try?
When should we give up? Like when should we abandon operating? Neglected elbow dislocations. Do we have to operate the radius or?
I think after 3 weeks you need to operate. I don't know what the end period is. Many of your patients will lie to you. So you might get the truth after the operation. I think the elbow is less likely to develop arthritis except for instability. So I would try. It's surprising sometimes the results people get with chronic injuries in the upper extremity. 3 years out, they get fine. Some of them.
Will you do fractional injury or will you do arthritis for every chronic elbow? Will you do the fractional injury? Is it for every case or?
And if I can't get them up past 70, then I do it. But you can do it too much and get a hematoma. You want to get them up to where you hope that they can stay in. If there's just this short zone of motion before they fall out, you gotta lengthen them somewhat. I would say you want to get them to at least 80 intraoperatively. And then they seem to gradually stretch out pretty rapidly after that.
So there was a patient with distal humerus pseudoarthrosis with neglected dislocation, and she came almost after a year. So in this kind of patients, can we just forget about the elbow and go with pseudoarthrosis, or do we need to do the elbow reduction open followed by fixation of the humerus? How can we approach this kind of patients?
I couldn't hear you.
Okay, sorry. So we had one patient with a history of road traffic injury a year back. So she came after a year, and on the X-ray it shows there is a distal humerus non-union with neglected elbow dislocation.
Whoa.
Yeah, so clinically, when we try to examine her, she has like a few degrees of movement as the pseudoarthrosis. It's not that much painful, but her main issue was cosmetic issue, as well as she was asking whether it's possible to gain more range of motion. So we were in a dilemma whether to address the pseudoarthrosis as it is, or to go with elbow dislocation.
That would be a difficult problem. So you're saying that pseudoarthrosis was stable.
Yeah.
If the pseudoarthrosis is stable, then I would probably do the elbow dislocation first. But in your attempts to reduce it, you found out that if there was more motion, then you'd be in a difficult place. What did you end up doing? Nothing?
We advised the patient, and finally she agreed to just go with the pseudoarthrosis.
Oh. Yeah. Difficult problem.
Time to break, why not?
You know what a boomerang is? It's an Australian toy that you throw it and it comes back towards you. That's a boomerang. What do you call one that doesn't come back? Boomerang. That's the worst joke that Okay. I have to credit two really smart guys that have taught me a lot of elbow, Sean and Rick, for basically teaching me everything that I've learned about a stiff elbow. So if you're in the United States and you're an elbow surgeon, you like the scope, but most of us aren't really good with the scope, number one. And when I was in the US, I did quite a bit of arthroscopy, but I've only done one elbow scope, and I thought, this is just too crazy. I'm never going to do this again. Okay, so you can do safely open elbow surgery, I think safer than arthroscopic, and the results are variable, but many of them are great. Some of them are good. So there are a lot of approaches to the elbow that you can consider when you're doing an elbow release. Medial, lateral, posterior. I suppose you could even consider just doing a straight anterior approach for a flexion contracture. But when is a nerve release indicated? Okay, so as a guide, nobody's going to operate on mild stiffness, so moderate stiffness is typically simple. Sometimes there's a little bit of heterotopic ossification. Severe stiffness can be associated with fractures, heterotopic ossification, intra-articular adhesions, and ankylosis has some joint preservation, always with intra-articular involvement and sometimes fracture malunion, etc. Okay, so for moderate stiffness, do a simple lateral column approach. Okay, so that's basically the same kind of incision you would use for chronic elbow dislocation, but instead of taking down the lateral collateral, you leave it. So you basically start here on this vertical limb. This direction is the shoulder, this direction is the elbow joint. And as this starts to widen, then you widen this and you preserve the soft tissue. In essence, you're preserving the lateral collateral ligament. So you do it in this direction. So we all know that it's a very large ligament laterally. This is the one that's more important. And so you can incise right through this and then repair it. And then you can go anteriorly and posteriorly. And you should do a limited release because as those that really know about the elbow, the ulnar nerve at least has some component in creating some of these elbow stiffnesses. And so I think that Sean and Rick would agree that you should always release the ulnar nerve. Okay, so this was first described by Dr. Sean's mentor and Rick's mentor, Dr. Mori. And this is what we just drew out. So it's basically the same thing. From this original article, you can go all the way across. So anteriorly, you just can excise some of this, and then on the medial side, where you can't see very well, then just incise it. So basically, why would you then go medially if you can release all of the capsular tissues from just the lateral approach? Well, Dr. Driscoll said that nerve irritation may be limiting motion already. Is there a key range of motion to do trigger release, or should it always be done? So we're recommending that you always do an ulnar nerve release. Okay, so you do this anterior release, or as Rick prefers, an excision of this. This is Rick's slide here. Basically excise this proximal capsule, believing that it allows the brachialis to move better. It's untethered. And then posteriorly, which is where my finger is do your posterior release, excision of osteophytes, adhesions, etc., as far as you can around the lateral side. And then make a small incision directly over the ulnar nerve course, release it, mobilize it, leave it in place, and cut the posterior band of the medial collateral ligament. So the ulnar nerve would just go right through here. You just cut this band. Remember, you got to preserve this for elbow stability. So that's the moderate elbow stiffness operation. Big procedure laterally, minor procedure medially. Mobilizing the nerve, releasing the nerve, and cutting the posterior part, posterior bundle of the MCL. Okay, here's a stiff elbow, more HO. It's got 15 to 25 degrees of motion, so about a 10-degree arc. Really significant HO. You think that you're going to need probably a dual approach here because you have some HO in the area of the medial collateral ligament here. So again, you work back and forth to try to gain access to the HO, release the ulnar nerve, leave it in its bed, and look for the nerves on the preoperative X-ray. So here's the medial column approach, put up by Jesse Jupiter. And I don't see the year on this, but it's basically a mirror image of the lateral approach where you're preserving the MCL, but in doing so you also have to preserve muscle that overlies it. Okay, so there will be your medial side. Here's your lateral side. Okay, so this patient had really pretty extensive heterotopic ossification almost circumferentially. The ligaments were not encased in bone. And Rick and I and Sean talked about this, and Sean feels like he can follow the nerves on a regular CT, in and out of this bone. I am not confident at all, and Rick just shared with me that he's not confident. Do you use an MRI if you're more concerned?
I mean, I look, I try to see where the nerves are. And, you know, there's something called a Matev sign where literally there's a hole in the HO because the nerve's going through it, so that you look for that. Otherwise, as we did last week, I'll go in and maybe make some separate windows and find the nerve and then know where it is so I can know where I can go.
I think that that's a really wise advice. In this case, I did not do that, and so my blood pressure was up during the whole case. Probably up until I knew the nerves were working. I think it would be helpful if you reviewed your previous preoperative CT scan with the radiologist. I'm sure they're probably better at you than picking up the nerve, following the course of it, comparing it with your anatomy book. Carefully look at your anatomy book and at your CT scan and just anticipate where they might be. Here's normal neuroanatomy. So the median nerve is really superficial, right? I mean, it's sitting there with the artery. It's right next to the biceps, right next to the brachialis. And so you know where it's at. The radial nerve's a little more crazy. It's deeper. That's the one that really makes me worried. So we know all where they are, and we just need to do our best to try to avoid their injuring them on our stiff elbow surgery. Again, here's the medial column. So you basically incise along the course of the ulnar collateral ligament and leave the muscle intact over the top of it. So here's your ulnar nerve, and there's your ulnar collateral ligament. In this case, we removed heterotopication from underneath the MCL. We were able to sneak underneath it and remove it. So in this case, we were able to leave both the MCL and the LCL intact. So we did a medial and lateral column approach. The elbow was completely stable at the end of the operation. After excision of the HO, he didn't need anything for mobilization, not a sling, nothing, just an elastic bandage. So on the table, he was 0 to 120, where he had just 10 degrees of motion pre-op. And he was completely stable. Ligaments were preserved, stable on the table, no sling, indistinct. So here he is 2 weeks post-op, and like many of our patients, he never came back again. Okay, so here's the next level, ankylosis. 40-year-old male, injured 10 months previously. Pretty significant injury as you look at the CT scan, and of course he was massaged repeatedly. Essentially had no motion of the elbow. Okay, so in this case, you need more of a drastic approach. Basically, you're doing a chronic dislocation operation. You're basically dislocating the elbow so you can remove HO, osteophytes, and interarticular adhesions. It's going to be an exercise in patience. You need maximal access to the elbow joint. Just a massive ball of HO, front and back fractures, front and back osteophytes and heterotopic ossification. The joint, there's still a joint, fortunately, and it's congruent, but it's irregular. There will be adhesions inside the joint. You will have to have realistic expectations and be ready to do a full release and exposure of the elbow. There's HO everywhere. So, we're just going to basically do a chronic elbow operation where we just dismantle the elbow, preserve all the scar that's adjacent to the elbow, remove the HO, go back repeatedly, carefully. Once you get into the elbow, you start to look for the articular surface, so you're not just buggering up the joint. You're trying to use a knife more than you are a cob and an elevator. You're trying to see where the joint actually lies. Avoid articular and neurologic injury. Remove the HO, and like we did with the chronic elbow dislocation, just deliver the whole distal humerus out of the wound. So then you can remove all the osteophytes, totally remodel it, make it look as close to anatomic as you can. Remove all of the encroachment into the olecranon and coronary fosses. In this case, the patient had no rotation preoperatively, and I just felt, and I confirmed it with Rick here recently, that it just doesn't make a whole lot of sense to do that in addition to this major operation. Basically, what you want to do is have your surgical efforts and the patient's surgical efforts to gain one motion, that's flexion extension. And like we mentioned earlier, if you have a really complex problem, attack one problem at a time. If you want success, nail the one thing that's the most important to the patient. There's the distal humerus, patchy articular islands of cartilage remaining, a lot of scar, and basically the same kind of repair. Now in this case, I don't remember if I put the nerve underneath or not. I don't think I did. I think this was an ankylosis close to 90, so I probably just put it back in its bed. So here he is, 3 days post-op, 0 to 80 degrees of motion. Avoided extension. In the OR, he was 0 to 80. So we did immobilize him because there's the potential for him to dislocate. We only worked on flexion for the first 2 weeks. He was in a sling at 90 degrees, and he was on Indocin, of course. Here he's at 4 months, 10 to 120 degrees, essentially no supination, neurologically intact. You can see it's still not a pretty elbow. I mean, he still has fractures, he still has HO, but he's concentrically reduced. Here he is 10 months post-op. Which one's the operative one? Hard to tell, isn't it? We had to ask this patient to come in. You know, that's how we get follow-up for studies, is you have to beg people to come in. And the good news here is that you do an elbow release operation, and theoretically, if they work on it, they will continue to improve for a year. Now, Rick and I have talked about this, what would you do next? And we all know that a proximal synostosis has not a great chance of success, so maybe if we have time, we can talk about that later. But so when do you go on a stiff elbow? Well, when I was in residency, we didn't go in on HO until the bone scan was negative. You don't have bone scan in this country, but now it's been shown you don't need a bone scan. You just wait 6 months, and the results are the same. Whether you wait 23 months or 6 months, the results are the same. So you can go as early as 6 months. Sean is saying it might be closer to 3 months. Is there clinical evidence to that?
No, but there's other people who say the same. I'd say 3 to 6, a lot of people are doing it before 6, but there's no harm in waiting probably either. A lot of people talk about kind of when it's got a little bit of a margin, you can see it's not that diffuse, indistinct margins.
It's
margin.
got clearer
Right.
edges.
But some of the people who are, and Sean's not the only one, and I have not tried it. Some people are going arthroscopically and removing stuff, and they say it's easier earlier, but yeah, you know, I think for most of us, definitely want to wait until there's margins on it, and then that's 3 to 6 months.
I'm gonna have a case that's gonna be controversial. Just want you to open your mind. This is a case report, if even that. Okay, so this is a 30-year-old male, bilateral elbow injury. The left one was open. This is the right. Basically an olecranon fracture. This is an open supracondylar canal fracture. This is convoluted. And so 2 months post-op, he comes in for an exam. And he's got limited motion on the right side. He's happy with the motion on the left, and I am too. Slight numbness in his right hand, but it's not in the ulnar nerve distribution, it's in the median nerve. So he's got like this amount of motion on his right. That's his motion on his right elbow. 5 degrees. At 2 months. Two months, 5 degrees of motion on olecranon plating. Manipulate him? Who's? You don't have to raise your hands. But should I manipulate him? Should I send him to the therapist? I'm really past Indocin. Should I get a turnbuckle brace? Well, it's not available in Ethiopia. Remove the hardware, do a capsule release. Just wait. Neurogenic elbow contracture. I remember Sean Driscoll's talk about neurologic elbow contracture, and I walked back into the room. I did a Tinel's on his ulnar nerve with shocks going proximal to the shoulder. So he had median nerve symptoms, but a positive ulnar nerve test. So I scheduled him for an ulnar nerve release the next day. I didn't transpose the nerve, I just made a medial incision, released the nerve. I was very careful not to manipulate him under anesthesia. In fact, I didn't even examine his elbow motion under anesthesia. It was like I was fearful or something, I'm not sure. But I didn't manipulate him after. No sling, no nothing. Just released him. That's all I did. Next day, I did an ulnar nerve release. Now, I can't explain that other than say, Sean must be right. Because it completely resolved his loss of motion. Okay.
You know, that case, I think an important thing about that case is what would have happened had you gone and done a manipulation? It would have got worse. A nerve was stuck. You had traction.
Then he would have had neurologic symptoms.
Well, right, but then he would have, his contracture would have, even if it was an easy release, and he got full motion on the table, he'd wake up the next day with probably more neurologic symptoms, more pain. He wouldn't move, his stiffness would return, his nerve pain would probably be worse.
And you'd be in
It'd be a real trouble.
you would really regret.
Everyone would be sad.
Yeah.
But it's a great lesson. And it's hard to be wrong in releasing the ulnar nerve on a stiff elbow. I'd much rather, your earlier slide you said, I do it most every time.
Yeah. In summary, there's 3 levels of approach. You do a lateral column and an ulnar release. A medial lateral column, you can do a complete release on one side and a column approach on the other side and sublux the elbow. You can do the radical dislocation of the elbow, mixture of the above. Remember that ulnar nerve is not your friend and could be the sole cause of elbow stiffness. Any questions?
So when shall we consider the neurogenic elbow?
Every time.
At least think about it.
That's what Sean O'Driscoll would say. It's part of every stiff elbow, somehow.
So, in the previous case you mentioned, how do you know whether the neurogenic contraction is coming from the median nerve or the ulnar nerve?
I just thought, you know, the surgery was superficial posterior. It was an and I think my memory was also of a patient that I had many years ago that I did just a simple tension band wiring of the elbow. And you had ulnar nerve symptoms post-op. So I made a determination at that time that I would routinely release the ulnar nerve on any electron I did. Then I came to Ethiopia and my partner started to do electrons without releasing it. And I just thought, maybe it's not necessary. But I think maybe we need to revisit it. If you're going to do an electron tension band wiring, should you do an any release every time? I'm not sure.
Probably depends on the beauty of this too.
In cases where there is impulse stiffness but X-ray looks normal, and we take them to the OR and anesthesia remotely, moves freely, and once we come out of the OR, the impulse stiffens than the previous one. In this case, what do you do?
So you say you didn't open it, you just manipulated it?
Yes.
And take it back and do it all over.
So when the X-ray is normal still after we done.
Don't assume the ulnar nerve is not involved. Assume it is. I think in that patient, even though the patient doesn't have ulnar nerve symptoms, your stiffness is going to come back because it's probably neurological in origin. And I think I heard you correctly saying it was easy to manipulate.
Yes.
I think that's probably, well, either way, whether it's hard or difficult or moderate, you probably have to release the nerve. When you think about it, the ulnar nerve is just right next to the joint, and it's got this close proximity to the bone. I think it's, if you've got any scarring around it, it may just be some local tethers that creates this tension in the nerve, and then it doesn't want to, and then it's subliminal, subclinical, just prevents the patient from moving. I don't understand it, but I think it's real. Fascinating subject, isn't it?
But before we do that, we'll figure out how to get this to everybody. This is this little GIF file or GIF file of how to make radial heads. This is not my idea, I wish it was. Somebody smarter than me figured this out, and it came up on that WhatsApp group. And just using syringes and ET tubes from your OR, and we just did this week for the first time. So it's a little bit of trial and error. You got to find the right sizes. You cut them, you put a wire inside to make it stronger, and then you inject the cement, and you can, as much as you inject is the thickness of the head. You got maybe a saw to kind of smooth them off. Ours were a little rough, but ideally you can do this and even have them on the back, have them wrapped up sterile, and now you've got a radial head spacer. So when you look at these cases, I won't tell you what we did, but you might see some of these, a couple of these cases. So we have 4 cases, and were you able to send that out, Sammy? So let's do this. Let's go. All the tables on that against the wall do case 1. Down the middle do case 2. Not this table, but everything back there do case 3. And you guys do case 4. So look at the case amongst yourselves, and just then we'll go through together. We can you guys will have the case that's yours, so to speak. And maybe you come up with some ideas like what would you do on these elbow cases, and then we'll talk about it. So give it 5 or 10 minutes and take a look at them, and then we'll go over them. If you can't find the link, I can always show the case. I'll show the cases up here too. So if you have no access at all, take a look. That's case 1 up there. What's the mechanism? What's the pattern? This is that one patient. This guy's only 10 days. I don't think he made it to Washington. Yeah, you can see that underneath the skin. It's like it's just thanks everybody. That was great. I walked around a little bit and I spoke to many of you, and a lot of great thoughts and a lot of great ideas and understanding. So it's really rewarding to see that. So obviously you all saw one case in a lot more detail. So we'll go over these all together, and I'd love to have the groups chime in and give thoughts or ask questions more in depth. This guy actually, this is the one case not from Ethiopia. This is somebody who I grew up with, who lives a little further away, and his brother lives in our area, and they got a hold of me so I could take care of him. He's a big guy, probably weighs 120 kilos, taller than me, and he just fell. And within a week or so, he came back to see me. I couldn't find his x-rays last night, but as I mentioned to those that had the case, to give a little bit of information and not make it impossible, because the x-rays show pretty clearly. This is the tip of that's a triceps insertion. So this is a triceps bony avulsion plus this distal humerus fracture. So always look for these weird combinations that aren't so common. The triceps can be a bony avulsion, sometimes with radial head fractures, and MCL injuries as well. So the triceps avulsion is interesting and actually does afford for something when we think about exposure, but that's pretty easy to fix. And I was talking about treatment options for this. So what are the treatment options for this distal humerus? In Ethiopia, it's pretty much leave it alone or fix it, right? Or start excising fragments. In other parts of the world, there's distal humeral hemiarthroplasties. That's not approved any longer in our US, so I don't have access to that right now. So it's either a total elbow, which is not a good idea, or fixing it. And these are really small little fragments. Any thoughts on approach, first of all? Any thoughts on, would anybody think that they can, have a good idea for an approach? Would anybody want to go dual? Anybody want to go anterior? Anybody posterior? Who here is going to go posterior? That's all right. So the olecranon is like a traumatic osteotomy, so we can flip the triceps back, right? I can't approach these high shear fractures, highly common shear fractures, without an osteotomy of the. If they're a big piece, we can go lateral, soft tissue, but if they're comminuted, I want an olecranon osteotomy, and sometimes I want to get lateral. I want a lateral release of the soft tissue as well. For me, that's often an osteotomy, but this guy's got a bony fragment that's separate, right? That smaller piece. So we can flip his lateral collateral on that piece, and now we've essentially done an olecranon, he's done for us, an olecranon osteotomy and a lateral epicondylar osteotomy. We'll talk about this. Tomorrow I've got some pictures I'll show you, so I'm not going to dig them up right now, of an elective osteotomy of the distal humerus with those combinations. But that's what I did for this guy. But those releases, those osteotomies were already done. Flip his triceps back on that olecranon, open that door of that lateral piece, and now you're looking at the whole distal humerus. Okay? So that's the exposure. So now we got the whole thing exposed, and his bone's not horrible, but we got little pieces. How are we going to fix this? Is anybody here on the Cubitus Mundi group? So if you're interested in elbow, do that. It's a WhatsApp. You should be able to log in and do that. It's very good. It's got its, it's like any other group. It's got its pluses and minuses. Has anybody here heard of the skinny wire technique? Probably not. There's a guy, George Dwyer, is at the Brigham where I trained, but he came after I was there, and I'm told he learned this when he was in Haiti. And somebody there had figured this out. So skinny wire technique is, you get this case, you've got the exposure, which you have to have to get fixation. Again, trying to make little windows here, trying to do a lateral exposure and work in the front and see that. I can't do it. So you're now looking at the whole distal humerus. Now it's actually a pretty easy reduction. You're carefully teasing the pieces together. You come in from lateral and start shooting K-wires and just spearing these pieces and getting as subchondral as you can, preferably anchoring into that medial epicondyle that's intact. And you do multiple wires, and then you bend them backwards, and then put them underneath a plate. Now I chose a plate. I've got a plate that's locking, which is nice, but I think I could have done this without. I've got some pictures I can show you of just a 1/3 tubular plate. With a 1/3 tubular plate, all it does is trap those wires down. So the wires are smooth. They're small. They're flexible. They're forgiving. We can hug that bone. You can see I've got some shot to the medial side all the way over. They're smooth, so they want to back out, but they can't because the wire is bent and trapped into the plate. It can't go in any further. It can't come out any further. It's kind of a locked K-wire. And you start to get enough of these in, and it's surprisingly rigid. Like I said, this plate's got the benefit of some screws from front to back and the bigger capitellar piece. But this is all about low fixation. And then if one of these, and I've got another case where I had to use some smooth wires that were intra-articular. And that's acceptable if that's the only thing you can do. So if one of these wires were to even go in and out a little bit, it's a smooth wire. It's not ideal, but it's acceptable. So skinny wire technique for distal humerus fractures can be combined with screws as well. So if we've got a fracture where some of the pieces are bigger, but some are smaller, we can put those skinny wires in and bend them over and trap them under. Does that make sense? Yeah, so the wires they come out of the bone and they sit on top of the bone and are literally wrapped around posteriorly and trapped. You can kind of see it right there. So the plate just squashes them down and holds them in place. So that's case 1.
It's really amazing.
It's extremely powerful. What's going on here? All right, so case 2. All right, 72, older patient, 10 days acute. No Waukesha here. So fracture pattern. I know not everybody's seen this. Is the coronoid fracture? Yeah. Is it the medial coronoid? Doesn't really look like it. I mean, you can see the sublime tubercle coming over. And I know you don't have all the views and you'd want to look at it. I want to spin it around. Radial head's fractured. We see much of it in the back there. There's another little piece in the front. Coronoid's fractured. Looks like it's transverse. It's a tip. And it's dislocated. So radial coronoid fracture, dislocation, radial head fracture, terrible triad, right? Transverse coronoid, tip, all that leads to posterior lateral rotator. So it all kind of fits. This is where, like I said, not everything has to be absolutely always 100%, but if the pieces of the puzzle start to fit, it starts to lead you a certain way. So we say, okay, tip, transverse tip, yes. Radial head, yes. Dislocation, yes. No. Posterior lateral rotator instability is a terrible triad. Okay, what's the algorithm? I want to obviously reduce it, but I'm going to have to fix the LCL. I've got to do something with that radial head. I'm going to fix it, I'm going to replace it. And that coronoid, it's not huge, maybe I don't have to fix it. And then, so I want to at least look at it and probably think about fixing it. It's small enough that maybe I can't get a screw into it. So who here would approach this posterior? Anybody? Kind of hard to go through it and tackle, like or not. So I'm going to come through this laterally, and this is where we, and then with the radial head out, it's already out, it's going to be on the back table, whether we fix it or not. I can look across that gap and see the coronoid. And this was, we thought ahead of time, let's try this radial head replacement idea. He's 72, probably not going to have great bone, pretty thin radial head. Could we fix it? Yes. And I have to also say, you'll see a picture in a second when we talk about one of the other cases. Getting a good tripod from that lateral isn't always super easy because you can't always get it all the way around. So there's a component here where this is actually easier as well. So this is what we did. We made a radial head. There's a central wire. We just kind of left it long. That's why it snakes down. And then if you look real close, there's there's drill holes coming up. So we drilled 3 holes. And I'll find a picture of this in a second. 3 holes coming from up and over, and we used Ethiopian to tie the coronoid down. We could see, before we fixed the lateral collateral ligament at least, when we tightened those sutures down, it definitely made the elbow more stable. The head's a bit undersized. That's the biggest syringe we had that wasn't too big was the, was that a 20, I think? A 20 cc syringe, I think? Yeah. So just with what we had at Soto, that was the biggest head that wasn't too big. And then when we had it all reduced, I was measuring how thick the gap was. That's the other thing, you want to be not too thick. And so I found a ronger that slipped just in on the neck cut, and I could see that the elbow remained reduced. It wasn't being gapped open, so we knew that's how thick to make it, so that's how much cement we wanted to inject in, although we had actually pre-made it. But we knew we were too thick when we measured back and forth. Actually, no, we injected that one this one we made while we were doing the case. And then we fixed the lateral collateral ligament on the way out. So replace the radial head, fix the LCL, fix the coronoid, very stable, didn't have to worry about the medial side at that point. So we started moving him. And then the nice thing too is we don't have to worry about the radial head falling apart. So aggressive about fixing it. I'll see if I can find the picture of the suture technique. Actually, I showed that today. I showed the suture technique today. All right, so this guy, again, we got lucky. Only 2 weeks out. He's 30, falls down, has this injury. So the coronoid's fractured from both the olecranon and the shaft of the ulna. So Sean's new system. So that's when I showed those two circles intersecting. Right. This is the one that is both a transulnar injury and both a coronoid injury. So we have to fix the coronoid. We can't ignore it. We can't just put a plate from shaft to tip, and I've seen people do that. It's a disaster. Radial head it looks like it's involved. Get the 3D recon. And we can see there's the radial head in the back. A good 2/3 of it. There's some in the front. We can look at the coronoid and see immediately the sublime's intact, the medial coronoid's intact. There is a crack going across the very tip, but that's non-displaced and it was relatively stable. We could leave that alone. So these are the injuries. When I see these, I want to go through. I want to go through the fracture for a couple reasons. One, I can use the fracture itself to basically dislocate or sublux the radial head up. I'll show you a picture of a different case. We didn't take a picture of this one, unfortunately. But we can get to that radial head by pulling the whole radial head posterior. The medial collateral ligament stays with the big piece of coronoid, and the LCL is typically with the shaft or with that piece as well. And so we can just dislocate the whole proximal radius, proximal ulna, exclusive of the fractured piece of the ulna, and see the whole radial head and fix that. At his age of 30, we wanted to fix that, and so we did. We put they're non-cannulated. They are small. I think they're 2-4 screws with small heads, so they're countersunk screws. We fixed the head, take the two pieces together, then put that back down with 3 tripod screws. If you're going to do that technique, and again, I'll show you a picture in a second. Actually, I'll show you right now, I think. So this is a different case, but a similar approach. And radius subluxed up, out. Olecranon is here, pushed out of the way. Median, actually on this one, the ulnar nerve is just, it's not transposed, it's just, I think I just open it up a little bit. But I can sublux this all the way out and see circumferentially around that head and be able to fix it. So that's the head, I'm looking straight in, right? There's a couple keys with this. One, we have to be careful about, and Dwayne was just asking, like, how do you dislocate it and how do you get it back without wrecking it? And we did this on this case that I'm showing you. You have to set everything up ahead of time in the sense of know your steps and be ready to do it. It's not a good idea to fix the radial head and then try to figure out how to reduce the other fracture fragments. So you pull everything apart, you learn the fracture, you get to know the fracture, and you can see there's 2 small plates. We could have, and if you don't have plates, an option here would have been even 2 7 screws and wires between them in like a figure of 8 fashion. I've done that before where the wire holds the 2 screws together. So if you don't have real small plates, there's other ways to do this. But what we did was we had it all apart, made sure we could pull the head out. I had the head back together on the back table with a K-wire, and then we had a handle to hold on to with that K-wire. We left the radial head on the back table, wrap it, tell everybody where it is, put it in the middle of a basin or case so nobody can throw it away by accident or knock it off the table. Then while 2 of us were putting the radial head together, 2 other surgeons were looking at that large piece of ulna and seeing how it fit back to the shaft. Because the idea is to fix it to the shaft for a couple of reasons. One, it adds stability to the whole construct. It's easier to kind of get the reduction.
and two, then it becomes a very simple olecranon fracture, hopefully. So we had the radial head pinned back together. The team on the table figured out how to reduce the fragment. We didn't do it, but we figured it out. We had the plates ready. We all talked about how we were going to do it. And then we let it fall apart, pulled the head out. We could hold on to that K-wire. Another surgeon put their finger or their thumb on the head to put compression on it. So now it's compressed. And then we just put neutralization screws down. And then we carefully put it back. We already knew how the olecranon, or the coronoid piece went. Teed the coronoid piece in. And then we pinned it and plated it. So then at that point, their head's fixed, the coronoid's fixed to the distal shaft, and now it's a matter of just swinging down the olecranon and fixing it, which we did. A couple of comments. One of the screws you can see actually pushed. We had that coronoid piece keyed in perfectly, and as we drilled one of the holes, it kind of pushed it out a little bit. It was actually splintering, so we just left that alone. That's why there's a short screw there. That's one of the screws that wasn't helping. And then the home run screw we thought was very close. We didn't have C-arm initially. We got it once we had fixation. That screw was extremely strong. I do think it's close to it's subchondral at least. It may be intra-articular, but there was no crepitance feeling that we could get. And my argument was if we changed it, we'd have to drop the trajectory, maybe hit the other screws, or worse yet, displace that fracture fragment. And if it's a problem, it's longitudinal, it will create a bit of a groove. It may stop grinding if it ever does, or it can come out. So my argument was to leave it. It's not going to cause severe damage, and we don't want to lose that fixation. So sometimes you have to make a decision in the OR of, and I don't like the saying of, better is the enemy of good. I mean, you want to be as perfect as you can be, but sometimes you have to accept, okay, here's what we got. There's a significant risk of a loss here if I change this. And it's going to be detrimental to a lot of things, but most importantly the patient. So we made the conscious decision to leave that long screw, and I don't think it'll ever be a problem. If it is, get a CAT scan. If it needs to come out 8 weeks from now, 10 weeks from now, it comes out. All right? Questions about pulling up the head like that through a olecranon fracture? Does that make sense? I wonder, and I haven't done it, but I'm thinking about it, the skinny wire technique for a radial head if you don't have good implants. I've wondered about an angled pin, smooth, small enough then to bend all the way around and smash down with a plate in the safe zone. So I think that's a possibility. I've not done it. So it's a compelling thought. So there might be a way to use that skinny wire technique in the radial head. So we'll get this patient moving. There's really no need to mobilize him. He'll start moving in full rotation. His ligaments are actually all intact from bone to bone, and the bone's been rigidly fixed. So he can move aggressively and get that moving. So the last case, I don't remember how old this guy was. He's the guy who was in the Somali prison for a year. 40s maybe? But yeah, 30s to 40s, middle-aged sort of a guy, slight build. I didn't get the mechanism, but this is him clinically on the table. So that round disc you see is his radial head. And so he's a year out. I look at his CAT scan, his table head. I looked at his CAT scan over and over again. I could not figure out his olecranon. I repositioned it in Osirix to try to figure out exactly what was going on with it. And it is just, here, so you can see the lateral side radial head, and again, his olecranon. And it was until we got in there, we had no idea what was going on with it. It was rotated. It was twisted 45 degrees and had an HO in one of the fossa of the olecranon. So it's just completely non-anatomic in its position even and its morphology. Very, very, very deformed. He was articulating and had worn, you can see even his distal humerus on the right had kind of worn into the proximal shaft of his ulna, but more distal than where his coronoid used to be. And his coronoid is kind of, who knows, right?
How much motion?
He was just fibrosed. Supination, pronation, and flexion extension.
So, what did you guys come up with?
So we have this problem.
Yeah.
It has dislocation, coronary fracture, radial head fracture, stiffness, osteopenia.
Yeah.
So treatment.
Right.
So
What's the problems?
the list of problems are dislocated elbow, coronary fracture, olecranon fracture non-union, radial neck fracture non-union, stiffness and osteopenia are the list of problems we had. So our goal is, our target is to have a stable, concentric reduced elbow, fracture union, and the repair of the radial head, or replace or excise radial head. So that's how we want to approach. So first we want to deal with the fracture non-union. We want to go direct posterior approach and rephrase the olecranon fracture, use it as a window, take out the radial head and use it as a coronoid. Then fix the olecranon with a locking plate, deal with the bone gap, either with bone graft, and then radial head we either replace or excise it. It's middle edge, we prefer to replace it if we have it with implant, or if we don't have implant, we want to use bone cement. Then our target during the first stage is no nerve injury, no infection. We want to have a stiff and a stable, concentric, healed bone first stage. Then we'll deal with stiffness later.
Awesome. Yeah. No, that's awesome. What is there any thoughts on? Well, a couple things. One, you talk about excision versus replacement of the radial head. Besides the fact that the radial head used to be there, what advantage does putting the radial head in give you acutely on the table compared to leaving it off the table? Excision versus replacement. What does replacement give you acutely? Any thoughts on that?
Yeah, we don't know.
So
in this case, we don't know when coronoid fossa the coronoid is.
Mm-hmm.
So if we put in the radial radius in its place, it will tell us specifically when this is.
Yeah. So if you're gonna use the radial head as a graft, and you're not, well, two things. If you're gonna use the radial head as a graft and you're gonna leave the radial head out, there's a lot of stress on that graft. So you're gonna unload the graft a little bit by putting a prosthetic in. And second, what you just said, it's gonna give you a height. And kind of one of the benefits of this case was, as bad as it was, is we had a lot of freedom of where to put that, right? Because the radial head, we could have resected more, and we could, or left it, and so we could kind of build the two together. We weren't stuck with just one. So what we chose to do is exactly what you talked about. We went through the back. So that the picture on the left there is the radial head stuck to the bone, and it was fibrosed to the bone. And so we took it off, and the first thing I did is, well, as we started to look at things, we were looking at things in the back table. The first thing I did was take the olecranon, which took over an hour and a half to get out of the fossa, because it was completely scarred in it, and then there was HO, and so we basically carefully got it out. The fossa was normal, olecranon fossa was normal. So we had the radial head out, the olecranon out, released all along the lateral border, and then I had to release a little bit up the medial border as well. So the triceps was attached to it, free off the bone. So now it looks kind of like an olecranon. And it comes up a little bit, but there's no coronoid on it. So we had that, and I took the olecranon, and and the patient was awake at this point and decided to move because we had been there for long enough. And I went to put the olecranon to the shaft, and it wasn't even gonna touch. It wasn't even close. It was too tight. So I said, and this is where Dwayne's talks come in, and what he's taught me. I said, we need a naked humerus. There's just too much soft tissue contraction, too much deforming forces. So we then released the distal humerus, so it was completely naked, and all the epicondyles were clear of their soft tissue. Ulnar nerves released and carefully out of the way. So at that point, then they could kind of touch, almost. And so now I could bring the ulna up, and that's what we see on the left. We could bring it up, and I took the radial head and put the radial head in its full state and I started kind of moving around. I know there's a good paper that I can share references on, a couple, on using the radial head for an autographed coronoid, and different ways to put it. And Dr. Sean O'Driscoll puts it one way, and there's a paper, I think out of Japan, where they looked at both different directions, and that there's an argument, and it can work different ways, basically. I just take it and hold it in my hands and see kind of where it goes the few times I've done this. So I took the head, and we actually used the face of it, that normally goes against the capitellum, and I won't be able to blow that up, but put it on the medial-most trochlea and saw that it kind of fit. And then I could, at this point, this picture here, it may not even be fixed yet, I literally wedged the piece of bone between the ulna and the humerus, and it kind of found its natural site. Because we had a prosthetic radial head in at this point, I had something to balance against. I wasn't like trying to balance two knife edges on each other. So at this point, because the front's so tight, I've got this piece of bone wedged in there, I've got a radial head in there, I can extend a little bit, and someone from the team can shoot a K-wire into that radial head, and all of a sudden we have a proximal ulna that's got a coronoid on it. And then we fix it with screws. So now we've got a proximal ulna with a coronoid, we have a radial head, and it's simple in the sense that we just need to bring that olecranon up and plate it. There was a little bit of a gap, so we had bone graft ready to go. I had to trim it. I trimmed it up, a little bit of carpentry work, and trimmed it up. And that's what it looked like when we were done on the table. So we can see on the x-ray on the left, if you look in the corner where my thumb is, that's the prosthetic radial head articulated on the capitellum. If you look at the x-ray on the right, we can see shaft, and then we see something in between. That's radial head, bone graft, and then olecranon. So radial head and bone graft, that's olecranon. Another advantage that we utilize is because we had the olecranon piece completely free, we can flip it over and make sure that the screws we put in weren't interarticular and put them as long as possible. And then there's two cerclage wires because we knew there was osteopenia of that piece of bone, and the screws weren't going to be great. So we went ahead and cerclaged it as well, because the last thing I want to do is bring this plate over, long plate, and have it rip out the olecranon. That's the weak link, is the olecranon at that point. So we cerclaged it as well to get that. So that's the radial head. Sorry, not on this side anyway. So there's the radial head there, the graft, autograft. And then a little bit of an obliquogram, but we can see it looks like an elbow now. So those oblique screws coming from the medial side on the x-ray on the right are in the radial head autograft. So solid fixation, didn't move a lot. I did Dwayne's pie crust technique with using a 15 blade, not a needle, and pie crusted the triceps. When we were done, I think it was about, if I remember right, I want to say like 50 to 90. So, but smooth and full supination pronation. So we'll see, but that's what we did. So that's kind of that kind of brings a lot of the stuff all home together. We talk about instability and patterns and secondary stability from the radial head, utilizing approaches for chronic dislocations. So all these principles apply and you put together. I think the biggest challenge for this here would be implants. We use some small screws, 2-4 screws, which are nice. That radial head probably could have taken a 3.5, 2.7 for sure would have been okay. And then the long contoured olecranon plates was very helpful. If we would have contoured a recon plate, definitely would have had to put a lot of cerclage wires on it, but that would have been doable, I think. And now it just has to heal, not get infected. And I think if this patient ends up even with that 40-degree arc of motion, that'll be great functional elbow, better than a fusion, and maybe it'll even do better motion later. Any questions?
So on the last case, when you graft the radial head as coronoid,
yes.
How can you balance the stuffing in the joint? Like, how do you know how much size of the radial head you use?
That's a great question. Yeah, how much do you use? Couple thoughts. I look at it just from the side, which you don't quite see. I wanted to see it come up further than to be about equal to the tip of the olecranon, right? And then I'd rather be too big than too small because it'll be stable. What I didn't do here, although it was kind of impossible to do anyway, it's nice to flex them up and see if it's too big, then you can actually burr out or create a little bit of a deeper fossa for it if you need to. But it's just trying to mimic it as much as possible. It is not normal. It's not a normal, it doesn't somehow replace a coronoid in a way that looks exactly the same. It's not. And even if someone could hand me a coronoid autograft that's perfect, or print one out of a 3D printer, I almost wouldn't want it. I'd rather have this, because if you think about the coronoid, how thin it gets, it's not going to take screws very well. This holds screws quite well. It's big enough to get screws from a couple of different directions. So I think it's just try to make it look normal. Sometimes it overhangs on the medial side. You need to trim it off if you have a micro saw, or even a rongeur if you're real careful. And so it's just making it look relatively normal and making sure it doesn't impinge too much. But these are big salvage situations. These are typically very abnormal elbows, so you're going for some significant improvement that may not render the elbow normal, but will get it functional. So I look at it, try to make it look to be about the height of the tip of the olecranon, and then if everything looks really good, but you need to kind of dig out the distal humerus a little bit so it can clear inflection, that's fine. Any other questions?
Do you need the loss of this for replacing the forward if this was not replaced by the radial?
Yeah, so if we didn't have the radial head for this, what else could we use? Non-articular bone. We could. It's not ideal. We could go to the clavicle if we wanted to. We could go to the rib if we knew how to do that. I don't yet. I want to learn. So those are the options for articular bone. But that's the benefit of the radial head. It's articular.
Is there any position you recommend for the radial head to be placed?
Right. So there's the way that Sean does it. It's like taking the. I have to think about it. I'm upside down. I can dig the pictures out. Maybe I'll just show them tomorrow. Sean uses the periphery of the head and either puts it right in the middle or off to the side. In the paper out of Japan, they also looked at what I did, which is to use the face of it. So what I've done, I've probably done this only.
The face faces the trochlea.
Yeah, the capitellar face faces the trochlea. I've done that. That's what we did here. But Sean uses the periphery, the articular periphery. And I would just say that, I mean, I'll get the pictures I can show you. My recommendation is just to take it in your hand if you want to put a KY on it so you don't drop it, but to just kind of see what makes sense.
So you can use either way.
You can use either way, absolutely. Yeah. The capitellar surface fits that medial side of the trochlea pretty well. And this one, we put the whole thing on, and it was probably luck more than anything. We put the screws in, and then I trimmed it to even it up with the ulna, and I didn't run into one of my screws. So I kind of was thinking about it, but probably not for now. I think I just got lucky. So, and then the other thing about this approach, and we talked a little bit in the back about windows to get to the radial head, and like that other case I showed, the more acute one. The benefit about going through the fracture isn't just that I think when you sublux that out, it's a better view of the radial head, but that secondary window does, to some degree, devitalize the tissue and open you up for seromas. This patient was super thin, very, very thin, and everything we did was there's no soft tissue flap elevated. We're down to basically bone, and everything's inside, including the radial head. So when we closed him, there was no sub-Q dissection. So hopefully that'll help decrease the chance of an infection. Yeah, so that's what I had for the cases. Thanks for, you guys did great. So if there's questions later, or I can try to dig up some pictures of some of these things, as far as pictures of the radial head implant, autographs where they can go, Sean's suture technique, I'll try to maybe put that together. Otherwise, I think we have a head scheduled for Dwayne or for a break.
Just continue with crocodile and finish today, right?
Yeah.
Yes.
Okay. All right. All right. Thank you.
It's great to be here. Thank you for the invite, the ESOT team for this presentation. Very honoured to give this, although feeling I'm slightly an imposter here, as my interest is more limb reconstruction, but there are principles here which cross with limb reconstruction as well, which I'm going to highlight. I'm Dr. Tim from Cure Hospital, and I'd like to give credit for this presentation to a number of people who have contributed, Prof. Ignacio Sampera and Federico Canavesi from the EPOS group, and my colleagues at Cure, Tedros and Lawrence. So the objectives of this talk are to overview, really, supracondylar fractures and the malunion, its treatments, modern treatments, to discuss some of the controversies which are always there in children's orthopedics, and perhaps review some of the context-specific surgical treatments. Who here has fallen from a mango tree? There's no one has climbed a mango tree and fallen from it? Okay, well, this is a common thing in many parts of our country, and where I did my orthopedic trauma and cut my teeth was in South Africa. Mango season was big, and children were falling from great heights. And we used to have operating lists in mango season of, you start with your list of four MUAs of elbows. And lots of children in traction on the ward, which I'll explain later. So this is the type of x-ray that we got. It's kind of, the penetration is poor. You're not really sure exactly what's going on with the fracture. Is it comminute? Is it not? What's actually happened there? Well, you just got that. And more often than not, you probably need to get an x-ray under traction and C-arm to see what is actually going on with the fracture anatomy here, and make your planning. So some of the planning does happen intraoperatively, not on the first x-ray. I just wanted to remind you guys, I'm sure you remember this, the Bauman's angle. The capitellum forms in the immature elbow at what age? 1. Exactly, critor, yeah? So C is capitellum, that comes at the age of 1. And then from that you can determine the angle of the distal humerus, because we know it's 72 degrees. If you use that line from the physeal plate of the capitellum, it should intersect the vertical of the humerus at 72 degrees, plus or minus 8, which is the variability. Right, there's a classification which is the Gartland, that's for extension type supracondylars. Of course, the flexion type is rare, but I think probably falling from a mango tree and landing on your elbow is probably, you have a greater incidence of flexion type, but I don't know if that information has been obtained. But my guess is that we see probably more flexion type fractures from falls from trees, and of course that includes other injuries as well. So according to the ATLS principles and protocol, please take a look at the whole child, look at their abdomen, chest, neck, head, and also the rest of the extremity, because there's a lot of these children will have coincidental type of injuries. So we know the Gartland classification, I'm sure people know this. So it's Gartland classification is an extension type. That's the extension mechanism of injury. Usually the child will, if you examine the other elbow, they'll have a bit of hypermobility and go into hyperextension as well. That seems to predispose. The flexion type, as we said, is falling onto the elbow. So type 1 is undisplaced, type 2 is there's a hinge posteriorly, and then that's been, as you can see, the type 1 has got the fat pad sign posteriorly, which is pathologic for some kind of fluid in the joint. Type 2 is the posterior hinge. Then you've got modified to 2A and 2B, where 2B has some rotation as well. Type 3 is a displacement, but with intact periosteum. Type 4 has disrupted periosteum posteriorly. When there is a complete displacement, or if there's rotation, that probably should be reduced and fixed. And you can see here different types of choices for fixation, some parallel wires, some divergent wires, some cross wires. But I think you can see that the distance between where the wire crosses the fracture site and the other wire where it crosses the fracture site is the key. So the parallel wires, where they're quite close together, is essentially functionally operating as one wire. And probably the other two constructs are more stable. So Gartland 4 probably best seen under anesthesia, unstable inflection extension, no periosteal sleeve at the back there to help. And sometimes this is a iatrogenic injury. So it's a 3, but then someone's manipulated it and pushed a bit too hard, there's a pop, and it's gone at the back, and it's now a 4. Okay, so that's the mechanism there. So do look for compartment syndromes in these children, high incidence with, if you have a floating elbow, or for example, a coincidental injury elsewhere, do look at that, and be careful to document your neurology very carefully before the patient goes to the operating room. There's nothing worse than coming back and finding that no one documented the neurology and you've got a neurology deficit. Remember the 3 A's of compartment syndrome in children. Does anybody know the 3 A's? Anyone guess what they could be? Yeah.
Anxiety.
Anxiety.
Agitation.
Agitation. Agitation. Anxiety. Good. Yes. Analgesics. Yeah. Good. So I think you got those 3. So a bit different from the 5 P's, right? So be aware that the child wanting a lot of painkillers, agitated, anxious, is probably early compartment syndrome type signs. Have a good look at the compartments. Okay, the treatment here for these is, of course, the modern treatment in the West might be percutaneous pinning, closed reduction and percutaneous pinning, but that wasn't always the case. And when I was training, it was perfectly acceptable to do this. So Gadgill from the UK published an article in the JBJS when I was doing my training to say that for closed fractures without vascular concern, under the age of 10, straight arm traction for 22 days was very effective and very good, and had excellent results and completely equivalent to operative outcomes, and did not have the risk. So if you had a child that came to Stoke Hospital at that stage, you'd get that treatment, and it seemed to yield very good results. So that's to reiterate younger children. So in where I was working in South Africa, we did a slightly modification of that. We started with the traction. We went for traction until the swelling was completely resolved, and this was straight arm traction above the head. And then once we'd seen that the swelling was indeed resolved, we'd take the child for a closed reduction under C-arm, make sure that the coronal alignment was good and equivalent to the carrying angle on the other side, and then flex them up and make sure they've got good flexion. And it seems safe at that stage, with the swelling gone, to give them a good amount of flexion and hold them in that position. We tended not to see any requiring osteotomies after that, and seemed to be a successful way to manage what was a a very common problem in a fairly low resource setting. So, what about pulseless limbs? What's the? I think everybody here will have read this for their final exams. What to do if children come in with pale and pulseless limbs with supracondylar fractures? And this is kind of like what I like to think about it. So I'm thinking that the pale and pulseless one should be immediately explored after an attempted closed reduction. Does anybody have any other thoughts on that? Okay. Then there's a whole heap of controversy about what to do about the others. I think if the limb is pulseless at the radial pulse, the fingers are pink, it's worth doing an urgent reduction, attempt at urgent reduction in the operating room. And some people would say, yeah, you could leave it for the next morning, that's okay. Some people would say, no, it probably should be done, and unless you have a really, really strict monitoring, unless you're going to be up all night watching that child, you should do it. Anyway, I think the recommendation is to watch it very closely if you're not going to do it very, very urgently that night. Then once you've reduced it, take a look. Is there a pulse back? And if there's not a pulse back, then is there a Doppler signal? Is there poor oximetry tracing? You know, the actual trace of the oximeter. Is there a median nerve injury or gaping at the fracture site? And if you've got those things, you should probably explore it and remove whatever's in that fracture site, because the concern, of course, is that the vessel is in there. Sometimes, of course, there are injuries to the intima of the vessel, and that can be a problem. And an anterior approach is an approach which allows you, doesn't really give you the best exposure of the fracture site, but at least it gives you really good access to the things that you really want to see, which are the neurovascular structures. Okay, so remember, dysvascular limb greater than 6 hours of muscle ischemia, a prophylactic fasciotomy will be a good idea. Here is the recommended technique for closed reduction. This came from Blount in 1951, and is typically done prior to prepping and draping the limb. So you've got traction and counter traction happening. You then wheel in the C-arm, check on the coronal alignment. So you're looking for varus or valgus. You're then got your thumb under the olecranon tip, and you're flexing the elbow to make sure they've got good flexion. And once that happens, you get the X-ray in flexion. So what about forearm rotation? What position do you put the forearm? Well, most people would start with it neutral. If it's a posterior medial type of fracture displacement, there's some thought that because the lateral side is intact, the medial side is intact, then you can position it in pronation, and that will help to further reduce in the coronal plane. But I think it's a bit of a nuance, and I've maybe once or twice seen that work, but it's certainly not consistent. So anyway, try various different places of forearm rotation. Probably pronation is the better place for the forearm to be in. So the technique itself, I've got some pictures here which are from Dr. Federico. So he's working in France. He's got this nice little table for his supracondylar fractures. He brings the C-arm in here, and he does the sort of over the top, rather than the under the table C-arm position for the laterals. And what he doesn't like doing is doing this and this, because unless you move the whole shoulder and the whole arm as a composite entity, you're inevitably causing a malreduction. So for severe ones, it is nice to be able to flip the C-arm over the top to get your lateral X-ray. So the basic tray of instruments, of course, a wire driver, wires, and these wires are not. You don't go for slender wires. Go for something 1.8, 2 millimeter, something decent size. The small ones tend to back out. Go for have an assistant that, of course, helping you because that's entirely needed as well. And here's a pre-op view of a fairly high supracondylar fracture, which we're preparing here. They've done the pre-drape attempted reduction. Here they've prepped and draped. They're going to do the reduction maneuver and then pin it. So presumably he's got the X-ray on underneath there. He's checked the coronal alignment, and he's going to flex it up with a thumb underneath the olecranon. He's keeping us in suspense. Yeah, there's the coronal alignment achieved, and then that's the movement there. You find if they're not reduced, you won't be able to get that full flexion position. And there he's dragged the C-arm over the top to get that lateral. Okay, it's looking good so far. So once you've got the reduction there, putting the wires in the coronal plane is easier than spotting the wires in the lateral plane, which is why he's kept the C-arm in the lateral position. He's felt the capitellum, and he's going to put the wire into the capitellum first on the lateral side. With the elbow in full flexion, don't go for the medial side first. You'll find the ulnar nerve is twitching away if you start to go for it. It's recommended to go for the lateral side and pass it obliquely across the fracture site with one wire. To put the medial wire in, a little bit of extension is good. Perhaps into about 30 degrees of extension is safe. And then you can actually feel the medial epicondyle, go down onto it carefully without traversing the ulnar nerve. So here he's adjusting his position just to get the perfect line up the humerus. It's quite a high fracture, this one, so he needs to go carefully. He's got one finger on the humeral shaft, so he knows exactly where it is and where he's aiming in the coronal plane. This is hopefully the easy bit of the operation. Getting the bone reduced, I think, is the difficult bit. So I think he's then going on for a third wire. So it's 3 lateral wires to control this. I think afterwards, if you have the C-arm, it's good to put it through a range of motion. Look at it in the lateral plane. Make sure it's not displacing. Get coronal plane. Just give it a little bit of stress as well. Make sure you have actually stably reduced the fracture and pinned it properly. Right, and there you are. And then after surgery, he's not put it into deep flexion. It's in a 90-degree position there.
Approximately.
So, how many pins is enough? I think if we're going for a, probably we said that parallel pin was not ideal, but as many as necessary is enough to maintain a stable reduction. Clearly you should be getting the far cortex, capturing the far cortex on your wire, and just go slightly through it. So this one, of course, you can see the pins have been placed, but what's the problem? On the right side, pins have been placed. Doesn't look quite right on that oblique view, does it? So an oblique view can show you those columns quite nicely and can tell you that you've got a malrotation going on, which you may want to address. So someone's picked that up and redone it. Okay. I think it's good to look at the Bauman's angle and look at the carrying angle of the limb compared with the other side. And as I said, column views can be helpful to show you which is oblique, internal and external rotation views. It can be helpful to see those columns better. And there you have the column views on the right. So what is an acceptable reduction for a child? Well, that's up for grabs really, and hugely controversial. I think in terms of reduction, it's important to get the extension and varus out. Yeah, if you have someone who can't get their hand to their ear for their mobile phone use, or scratch their head or whatever it is, that's not good enough. You should correct extension deformity. Varus, of course, can be due to a simple varus alignment with medial comminution, or it could be compounded with internal rotation, which is quite a common a sequence of things. So you have extension, varus, and internal rotation going together as a deformity. So try and correct extension and varus. You may correct the flexion and valgus. A little bit of translation is acceptable. Mild rotation may be acceptable, but can contribute to the deformity. And all of this probably depends quite heavily on the age of the patient and their growth potential. So if you have a very young patient, you may accept a little bit more than someone who's closer to skeletal maturity. Remember, the elbow grows slowly. It corrects slowly. Particularly, rotation does not remodel, and varus valgus does not remodel. So late complications is cubitus varus. Sometimes valgus, although I've not seen that often. Volkmann's ischemic contracture, which we see a lot in Ethiopia as delayed presentations with Volkmann's, and iatrogenic ulnar nerve injury. This is the gunstock deformity. So the gunstock is the position of the butt of the rifle compared to the barrel. So traps. Don't make decisions based on poor radiographs. Make sure you've got good imaging. If not, make your plan in theatre sometimes. I think that's a good idea to recommend. Malrotation can make the gunstock deformity look worse. Respect the pink pulseless hand, and try and get that pulse back if you can. Avoid doing surgical treatments in the presence of severe swelling, because you won't be able to stitch the wounds up, and you just have to leave it open. Can cause problems. And of course, all the manipulation that goes on during during the process of the reduction can also lead to increased swelling as well. Fractures that you open will be stiffer than fractures that you get closed reduction and pinning. Look for the medial comminution in these posterior medial supracondylar fractures. That's a sure thing for getting varus deformity, malunion, and ideally mobilize by the end of the month after reduction. So I'm sure there are a lot of controversies in that topic, and I've just gone over some of the basics and things, and I'm sure there's a wealth of experience here and different ways of treating it as well. But hopefully that's a general consensus on a modern way of treatment. Are there any questions that myself or my colleagues can answer? Yeah.
Yeah, so for the flexion type, any tips on reduction as well as post-op immobilization?
Okay, so flexion type of fracture, hints on reduction. I'm not going to give you the hints. I'm going to ask someone else for the hints. Who's going to tell us what to do with a flexion type fracture? Sorry, it's not going to stretch. Sorry.
Yeah. And there were injuries, but if you want to keep the periosteal sleeve intact, right, to accentuate the deformity and translate it back, and then use the anterior periosteum and extend a little bit, especially a little pinning. Should be an easier. I haven't seen it. I don't know that I've ever pinned an extension flexion that I've seen. So it should be easier because you should be an extension and then pin it.
I don't think I've ever had to pin one. I think I've just treated them in an extension
Well,
station.
you might,
I mean, it's safe.
Yeah.
I can't remember pinning much.
Yeah. In the U.S. had a flex on pinning. Nobody's been going at this, but I think by this completely reasonable. Get a reduction. So just hyperflex a little bit more. Don't tear that periosteum. Translate it down. Extend them.
Mm-hmm.
So what
Thank you.
Is just treat them closed.
I'd try to at all costs. Yeah.
No pins.
Try not
No
to
pins.
open it up.
No pins in it.
Oh, pins are, I think I would put pins, but yeah. I try not to open it, if possible. Right. Yes.
Is there any practical tips to put medial pins?
Okay, practical tips to put a medial pin. Yeah. So when I started out, I used to explore and see the ulnar nerve and make sure it definitely wasn't on the ulnar nerve. But I don't do that anymore. I just make a little incision and then blunt dissect down onto the medial epicondyle, and it's usually a long way away from the nerve, and you can feel the medial epicondyle. You know that you're not there. It hasn't been seen, the nerve, but you know that you haven't gone through it, and put then the wire straight onto the bone. That's done with some extension, not in full flexion, but in about 30 or 40 degrees of flexion of the elbow, which also helps, I think, as well, in case you might have a child with a subluxing nerve or something.
Or you put K-wire directly at the medial epicondyle.
Yeah, and then that's right, but it will be my second wire. It wouldn't be my first wire. My first wire is always the lateral one in deep flexion. Yes.
In terms of presentation, duration of presentation, how many days is you treasure to do open or close reduction? Because most patients, they present late, after a couple of days. They will have swellings. Some might go to the local bone setters.
Yes.
What's your treasure?
So everyone, this is a really fascinating question. Thank you. So late presenting cases, what do we do? Because to be fair, here that's the common presentation. What do people do? If it's 3 weeks, after, and there's some early callus, do you take it down? Are people taking it down? Open reduction, yeah?
I feel strongly you should not.
Okay.
I feel like you should give them a year, tell them to come back in a year, or, you know, if you want to follow them closer, fine,
Yeah.
but I think there needs to be a randomized study.
There does.
I mean, it doesn't even have to be randomized, it just has to be
a good study.
A large number of people who were managed conservatively and those that had the fracture taken down, and
according to your
treatment algorithm, just
your
follow
treatment
those
algorithm.
patients for a year.
Yeah.
And see how happy people are.
It's a great study out there.
Because our temptation usually is when we get them after a couple of days, even like a week or two, the temptation is, should we treat it as a malunion later on or take out the callus early on? That's the problem. I think most people agree with me. So what's your threshold in terms of like maybe days or weeks? Which patients do you open them up or you don't open them up at all?
Yeah. I'm more leaning towards what Dr. Duane is talking about in leaving it and seeing what the residual problems are. So if I can't get a close reduction, and that would mean doing it in the first week, then I would leave it and would ask them to come back once it's healed and deal with the malunion and the problems therein. Often I see them coming with a lot of swelling after that kind of delayed presentation because they've been to other practitioners and they've been massaging. They sometimes have like skin blisters as well.
Yeah.
I've seen that, and it's highly unfavourable to go into that kind of a situation. Better to let everything settle down, heal, and then go into a more elective situation. I think is my take on this. But definitely it's a place where we need some research, because it's not just here in Ethiopia that you have this issue. This is across the continent and in other places definitely as well. It's a really important paper to be written. Right. So cubitus varus. Let me move on. So the causes here aren't other issues. It is cosmetic. So everybody knows that this is a can be a functional problem as well as a cosmetic issue. And in 2001, Sean O'Driscoll wrote a paper about this, I think with about 25 or 24 patients, each having problems some years down the line from leaving a cubitus varus malunion, which was interesting, very interesting paper for us in pediatric orthopedics, and made us really consider being a little bit perhaps more aggressive with these cases. However, that was probably a learning from a high. Sorry, what I meant to say is those patients were referred to Sean as an expert in upper limb and particularly in elbow problems. So this is, I don't think, truly a very common problem, and it wasn't a big study looking at what the prevalence of elbow instability would be after cubitus varus. It was just a flag to tell us that this is a potential problem. So still, I tend to see these issues as a lot of cosmetic problems, but just to qualify that, we do know that some patients have problems. And I think the mean varus deformity of those patients that had problems in Sean's paper was only 15 degrees. So it was very mild amount of varus that he was seeing. So remember, the growth of the upper limb happens a lot from the shoulder, a lot from the distal radius and around the wrist, not a lot at the elbow. that means remodeling is poor. Remodeling potential is poor. So here's a case. I think we've kind of touched on it already. So initial X-rays at 3 to 4 weeks. What would you do? So let me ask, hands up for a takedown of the callus and fixation, reduction and fixation of the fracture. Who would want to do that? There's one. Anyone else? Okay. There's a lot of people doing this, and I think you can see here it's very tempting, but let's just follow the natural history of this child. So what is the age? The capitellum is there. The radial head, I think, is on its way, but not really very visible. So let's say the child is 3, yeah? And the history, so a fallout of a mango tree. The examination, there was a posterior interosseous nerve palsy. So the child could not give you the thumbs up. Yeah, the extensor pollicis longus was not working. The wrist extensors were, but EPL was out. Okay. So 6 months later, the posterior interosseous nerve function was recovered. There was definitely a block to flexion, and you can see that was maximum flexion on the radiograph, that lateral. So what would we do now? Should we leave it? So it's blocked at 90 degrees.
And it's 6 months.
6 months.
Consider excision.
See, of what?
Excision of the disc.
Yeah. So my colleague Dr. Lawrence took an osteotome to the end of that fragment, and the bone spike was removed, and then this was 1 year after injury. So it wasn't normal, but it was looking better. And in a 3-year-old, I think that's a very appropriate approach to it. I think in the West as well, into a maturing fracture may not be the right thing to do, is my contention, but I'd love to see that study being designed in Ethiopia. So what to do with a simple varus malunion? Here we have some lines. So planning, I think, is an important part of deformity correction and can be applied to the upper limb as well, using the ABC method as come out of Baltimore. So A defines the apex of the deformity. B is where you do your bone cut. And C is where you put your hinge, or the correction, where you put your hinge. So, has everybody come across this concept? Yeah? You can't do much about where the apex of the deformity is. That's set for you. That's there in the malunion now. The apex is where the apex is. You can't change that. But you can change where you do your osteotomy, and you can change actually where you put your hinge, where you put your correction axis. So here's the cora. So there's 2 lines here. One is drawn down the long axis of the humerus, and the other one I've just used Bauman's angle of 72 degrees. They're intersecting here quite low, just around the olecranon fossa. So the apex is low, and the bone cut is going to be not in the olecranon fossa. It's going to be a bit higher, right? So what's going to happen? So if we did it and lined it up with the bone nicely, we'd end up with that great big bump on the radial side of the elbow. Yeah? The correction at the bone cut causes a disfiguring prominent lateral bump. So you'd have switched one obvious deformity for another one, really, and given them a scar in the process. So the way it probably should be done, according to the limb reconstruction purists, is to keep the correction hinge at the apex of the deformity. So the apex of the deformity is low, and when we do the correction, it must rotate around that apex. Is that clear? If you get your Detroit bone setter out tonight and put in a deformity like this and play with it, rotate it, put the apex of the, set the apex of the deformity, then put your hinge or your correction axis somewhere else, you will see the response that you get. And you can do it on your phones as well as your computers. Has everyone got access to the Detroit bone setter? Yeah? So it's a great piece of kit for doing this, and especially for osteotomy corrections. And anyone who comes to Cure should do their planning using the Detroit bone setter. So here you go. If you can see that on that right-hand side, the rotation is happening around the axis of the deformity. Other people call the axis of the deformity the cora. Yeah, the rotation is around the center of rotation angulation, which is where that red cross is. And it's rotated around there, producing an obligatory translation as it corrects the deformity. Okay. That means when you come to do these osteotomies away from the apex of the deformity, you will expect to see some translation which is obligatory. So concept, to use the limb reconstruction principles when tackling upper limb deformity also. Here's a case. This is an obvious deformities following supracondylar fracture, I believe, or maybe even a transcondylar fracture. Restricted range of movement and a clinically posterior lateral rotation instability with the radial head subluxation when this boy does press-ups. So let's have a look at his radiographs. So you can see there the extension, you can see the trochlear is abnormal, you can see the varus, and perhaps it's not as obvious as it was clinically, so we're thinking maybe there's rotational malalignment as well in this case. And this is a case of my colleague's, Dr. Lawrence. So he addressed this with an osteotomy that was, the patient was put in the supine position with the arm elevated over the head on a roll. The triceps was reflected, and then what's called a pentalateral osteotomy was done, which allowed multiple planar corrections, and the triceps was realigned on closure. So I'm just going to go through this, because this is something when Sean came, Sean O'Driscoll, he showed us how to do this. And this was the case we did after he left. So you can see here that there has been, I can show you this middle image. The humerus is at the bottom here, the radius ulna at the top, so it's upside down. And the lateral side is this side, the medial side is this side. And you can see there's like a spike here. And from the way I see this pentalateral osteotomy working, it's about making that spike. Because that spike gives you some stability once you've corrected it. So you've rotated it round, and the spike gives you stability, which then allows you to place a couple of screws, which then compresses the osteotomy site. Here we go. This is Sean's explanation. But basically, we've taken a triangle of bone out, but a little bit more than a triangle. So we've taken more bone out. We've taken more bone out of that lateral side. Do you see that, where his finger is on the left? We've taken a bit more bone out here than we've taken out there. And you can extend that and take more if you want. You then rotate it, again, around the cora. So it rotates. You have to take off some of this callus and all that kind of stuff that's getting in the way. You come to this image here, and you take off the corner of the metaphysis here, so that it slots in nicely, and you have that. You have this this piece of bone as a spike, which is abutting against the cortex of the distal humerus, and then you fix it with wires or screws or whatever you want to do. So some intraosseous, intraoperative photos here showing the dissection, and it's a fairly major dissection for this. So good exposure with the triceps reflected medially, and at the end a stable osteotomy configuration. And supplemented there with the screws for compression, and the child was obviously had a much straighter arm, although I don't think his flexion range had improved, but his arm was straighter, and he was not getting that rotatory posterolateral instability. So a multiplanar deformity, which is the usual type of supracondylar fracture malunion, is varus, its extension, and its internal rotation. So that's quite a difficult set of deformities to correct all in one go. My approach to it is to do a dome osteotomy and some shortening, which is very much like that pentalateral approach, and then fix it. And I often will put a wire in the medial side and a plate on the lateral side, but that's my preferred way of doing it. C-arm is absolutely required to do this. They're very complex, and you think you've got it right. You have a look at it on the X-ray during surgery, and you found that you haven't corrected some extension, or you haven't got it where you want it, and you end up doing it again. It's quite common to have a go initially, and think, oh gosh, and then take all the screws out and have another go at it. In my experience, that's the case anyway. Would anyone in the faculty like to explain their approach to that kind of deformity, because there are different ways of doing it.
I don't think my experience probably is as large as yours, Wayne's, but I found, a closing wedge osteotomy is tempting because it's easy, and they don't look good. People aren't happy with them. So I have done them, and I suppose if you're in a situation where you just need to get the varus corrected and you're convinced that's the only thing that's important, they are easier. But I've tried a dome, and I struggle with that too. It's hard to get a good dome that interdigitates properly and is smooth enough to allow one to really correct in an infinite manner and doesn't create more issues. So I'd be curious to hear how you get a good dome. I have done the pentalateral, and I've done them here and at home. And although I have to sit down and study the night before and make notes and write it out and put things up on the board, I've been the happiest with that. So, if you go back and read the original paper, it helps a little bit, but there's a lot of empty spaces in that paper. So talking to people who've done it before helps. You can correct the rotation as well, and if there's not a horrible amount of remodeling, you've got to get a sense where the bone was and get a sense of how you can correct the rotation, and of course you can change the angle of one of your main cuts and check that correct extension as well. But it's a finicky operation. The one here that I did had an ulnar nerve that was went to sleep for a while afterwards, just probably from retraction. So I don't know if my exposure wasn't wide enough. But getting that notch is key because we can really draw into it, get great compression with minimal fixation. So I think these are difficult operations. And I don't have a lot of experience to know the best way, but the pentalateral has worked well for me. That's the next one I get. I'll go back to learn how to do it again, maybe give you an email message on WhatsApp, give me some tips again. But so I like it, but yeah, it's plan, know your anatomy, and spend the time, have your images, because you have to correct the 3 planes.
Thank you. Dwayne, what you say?
I don't remember the last time I did one, so I have very little experience doing these, and I think that your initial impression here is that cubitus varus is commonly tolerated, and so I have not been quick to jump on this.
Thank you. Any questions? Any points or questions, comments? I think Samson, everyone wants to finish up. Yeah.
What's your experience when you do these open procedures in pediatric patients in terms of their rehabilitation possibility?
Right. So rehab and things. Yeah. I like operating on children that have got functional limitations already, and like if they haven't got a good range of flexion, that particularly makes me excited. I can help them. Is that kind of way what you're thinking?
My struggle usually is when we operate on pediatric patients post-operatively, rehabilitating them is difficult.
Yes.
Sending them to physio because they are
yes.
children is difficult.
Yes.
So always there is a struggle of stiffness.
Yeah.
After you do open procedures. So how do you usually rehabilitate them, the young ones?
Yeah. I think what Dr. Dwayne said earlier, tackling one thing at a time. If there's a if the problem that you want to address is stiffness, or is it a varus malunion that you're or is it both that you want to do? Sometimes you have to separate them and do the varus correction and then go back in for the stiffness and do a further release. And particularly some of these neglected elbow problems, they do have a huge amount of stiffness. And we'll tell the parents that we think probably this might need a second stage before we go in for the first. So so to separate the problems, and I don't know if that makes sense, but we also have severe challenges in children moving their elbows after surgery, particularly if they have fixators on or anything like that. And so we like nerve blocks and nerve catheters. We like to send those children to a rehabilitation unit if possible for an extended period of stay if there's a bed available and the family can do that. That's an ideal situation where we have the physio going in 2 or 3 times a day. But it's a problem that everybody will struggle with, and particularly with those open, the neglected elbow dislocations. I find that a particular problem with stiffness in children. Yeah.
Maybe one question from online participants.
Oh, really?
Yeah.
Okay.
And the question is, which approach you prefer, the anterior one or the lateral one? Usually, we use the lateral one.
Okay, yeah.
If we need open regard.
That's a good question. So this is in the context of a supracondylar fracture?
Yeah.
Yeah. So the question was, do we like to do a lateral approach or medial approach or anterior approach or whatever? So I think the open approach, particularly for vascular, for vascular concerns would be good to do it anteriorly, like you said, because it's there in front of you.
Usually in our setup, we don't have CRM, and in most of the country they do open reduction and pinning.
Yeah. So you're doing an open reduction and pinning without you haven't got any vascular concerns.
Yeah.
And then which is the best approach? So like I think probably when I struggled to get reduction, I did need to open it. I've gone on the medial side and exposed the ulnar nerve and done it that way. But no open approach is probably better than any open approach. Does that make sense? I prefer not to do it. I'd only do it if I was forced to do it. And I agree that C-arms are not plentiful functional C-arms are not plentiful, but that's something we've all got to work on. As orthopedic group to make sure that has to happen. It's a great question, right? Obviously,
Thanks everybody for coming, and thanks for yesterday. So we've got a pretty full morning, but I just told Samson I think this talk's going to go over. I've got the most slides, and I think time for this talk is probably the most important talk, at least to me, this morning. I asked to give a talk on surgical approaches of the elbow, and I actually had a talk that was not, it had some stuff, but I reached out to some friends, and George Athwal is a friend of mine from London, Canada, who does a lot of shoulder and elbow work, and he had a really nice talk, and I've used a lot of his slides, so probably a third to a half of the slides are from him. Thank you. I think if we're going to talk about approaches, we should go back to the anatomy a little bit and think about the anatomy as well. And there's a couple studies that back I think from the 80s where they painted with a metallic paint the ligaments, the attachments, and then the coarse ligaments. I can dig up the references if anybody's interested, but the point is, it's helpful to really understand where the collaterals are and the shape and their attachment points, the sublime tubercle medially and the supinator crest laterally. You go back and look at Netter, and I think I mentioned this yesterday. It's funny how these drawings are old, but they're always accurate. The naming may be a little bit different. Here, radial collateral ligament. But I mentioned to Dwayne, there's a paper from the 1980s where a well-known elbow surgeon said there was no lateral collateral ligament. So the stability of the elbow is predominantly from the medial collateral ligament. So we really understand these so much better. But even if we go back and look at the right papers, we can see that there was an understanding that goes back. But we have to understand the collateral so we can know how we can exploit intervals and go in and around the elbow and maybe preserve them if that's the goal. Lateral side of the elbow, attachment of the LUCL or LCL is from the epicondyle to the supinator crest. And again, looking at different models, we can kind of get an overview. So understand that if you don't, go back to the textbooks, look. They may be called different things in some of the older textbooks, but it's important to understand where they are. Lateral ulnar collateral ligament, same thing. Medial collateral ligament, medial ulnar collateral ligament. There's this, I think LUCL is becoming more common than LCL, but of course the collaterals go from the epicondyles to the ulna. The lateral side wrapping down in a little bit of an arcuate fashion around the radial head. MCL and MUCL, it's not a perfectly isometric point. This study was done way back, of course, by Dr. Sean in the 90s, early 90s, looking in the anterior band. The MCL is that red circle there on the right. It's a little bit posterior, and it's not even 1 point. So it's important to know kind of where the epicondyle, of course, is, and then where the medial ulnar collateral ligament is. And if we're gonna, I don't typically do a osteotomy here, but to know where to do it if you're gonna do it. If you're gonna reconstruct the ligament, where we're gonna put it. Most of the ligaments in that middll portion of the epicondyle. If we look at this mid picture here, looking here, this is where most of the MUCL is off the medial or the mid portion, I should say, of the epicondyle, that way out to the side, not too far close, because we don't want to rub against the trochlea. Understand if you get a chance to go to a cadaver lab or if you're doing a case, take a moment just to
really get a sense of where that sublime tubercle is, where the collateral attaches to. And then of course the course of the ligament, where the ligament comes off at about a 45-degree angle off the long axis of the humerus, and the ulnar nerve runs right behind it. The anterior part of the ulnar nerve is at the posterior part of the anterior band. So if we're anterior band of the MUCL is here, the nerve will come right here. So if we just, the nerve's basically touching or even overlying part of it. So understand that relationship, and so as we come in and exploit the intervals, we can protect the collaterals. And then we've got center rotation. If we're going to try to get a reconstruction, and I know we don't have any fixators here, but if we're trying to drive a pin through the center rotation, it's at the lower part of the epicondyle medially, and coming out the center rotation laterally in the center of that circle. So this first dot lateral, this dot medial. So once we know the anatomy, when we're in an interval, we can look at the deeper intervals as well. We did this past week when we were training us in HO. Medial side of the elbow. Of course, we know where the ulnar nerve is. We can go to that fat stripe anterior or to the pronator, coming between the pronator brachialis, median nerves right there. So remember these intervals. If we're working, if we're digging, and all of a sudden we stop, we need to get a. And we'll hear about this from Dwayne with the shoulder. Kind of get back to a standard base of where we are. We can find these intervals and find the nerve and protect the nervous structures. Radial nerve. The picture on the right's from Henry, which is a great textbook. If you don't have it, I'll try to post on your file sharing. I've got a digital copy of it, Dwayne. It's a great textbook. It's one of the few anatomy textbooks you can read, and the prose, the language is enough to just take you through the anatomy. It's not just looking at the pictures. It's one where the words actually make sense, at least for me. Great book. So if we come down, we can come down looking for the radial nerve at the elbow. Where, again, we're lost. We had a case last week looking for the radial nerve, multiply operated, lateral incision, lateral plates that were taken out. I couldn't find the radial nerve effectively or safely from a posterior approach. So we twisted the arm over, anterior, relatively small incision between the brachioradialis, and as Henry says, you can kind of, once you get in there, you can run your finger in there and plunge that interval once you find it, and the nerve's right at the bottom. And then you can work up, and then you can work back and forth. So it's a great interval to find the radial nerve at the end. I think you've kind of skipped over
He's taught me.
Yeah, well, yeah, you learn from Sean. And I've seen it when I come to SOTA, that's kind of how everybody thinks, because that's what you've done. But when I started, it was usually a big posterior incision and then a big flap, and you could go in different deep intervals. And while that's effective, now you've got a big flap, and you get seromas, and you have delayed healing, and when those break down, it's very, very troublesome. So you can minimize soft tissue flaps, just kind of going in directly to where you're going right to that deeper interval almost immediately, and then you don't have seromas, you probably have better healing. Or you can make a single incision, usually posterior, and have these deep flaps. It is probably easier to do a single incision. It's probably, I think it is worse. I'm doing less and less of that. I'm doing more and more of the specific incisions. In that case we showed you yesterday, our last one, with that guy's radial head sticking out, we went down almost to bone, and everything was inside that. So when we closed it, we had, even the thin guy, thin arm, his skin wasn't devascularized, I don't think. I think he should heal well. The only thing about the medial and lateral that worries me a little bit is the cutaneous nerves. A little bit at risk. You can try to flesh them out, or I think I mentioned yesterday, even if you have to make a sharp incision in one that just has to go, but you might have a numb spot, but you shouldn't have a neuroma. The posterior incision, the idea is universal. Graham King looked at this with some people in his lab. That it's a watershed area for nervous structure, so there's probably less numbness around incisions with the posterior incision. We don't have to deal with the cutaneous nerves like we see here, but it's also going to have the other problems. I don't like to see a dissection like this with that dried out twig of a nerve there, and so I try to keep it mobilized and moist and in the skin flap. But again, if I have to take it, I would. So that's the posterior incision. Here's Henry's extensile exposures, and I'll
later tonight or tomorrow. I'll try to upload it. You're all in the file sharing group that Dwayne has, right? So I'll try to upload that. So now, so before we can talk about an approach, we talk about patient positioning. We go lateral decubitus, which has some advantages where gravity is positioning the patient. Harder to keep them, their airway protected depending on how you're doing them. If they're awake, maybe they don't like it as much as it drapes over their face. I don't do much open surgery, lateral decubitus. I find it more difficult. I do my arthroscopy this way. I don't like to do fractures this way anymore. I do everything that I can, supine, and usually kind of over the body with a positioner that I have, which is nice, but if you have enough resonance, you don't need that. You put a bump on the chest and come over this way. But that way I can come out if I get in trouble and I'm working, and I'm here, and I'm working and I get lost, I can come out here and get that anterior exposure. So I just have a lot of freedom to go where I want to go. I can bring a C-arm in and work on it. The only thing I do on an arm table is a biceps repair, or if I have a simple lateral procedure like a radial head, I might do just from having the arm on an arm table. But usually the arm's free, patient supine, I might have a little bit of a bump, it's over the chest and I'm working that way. And then one last thing, which we'll see in more detail as we come in, I like to use osteotomies about the elbow. I think they're very helpful. Obviously, olecranon we're all familiar with. There's a little bit of discussion about where to put it, and then there's some slides we'll talk about. What do we do with the anconeus? The way I was taught to do a osteotomy of the olecranon in residency, no one even mentioned the anconeus. It was just cut in half. No one even mentioned it. And I think at least understanding it and what can be done with it, and maybe what should be done with it, especially the pediatric patient, those were the slides I was adding this morning. I think it's important to understand or think about it with a olecranon osteotomy. Words spelled wrong, I just saw olecranon. Lateral epicondyle I use a lot. I like it. It's a very powerful tool to get in the elbow and get wide access. It's typically easy to close, and then you don't have to worry so much about soft tissue stretching out or not healing properly. I don't think I've ever done a medial epicondyle osteotomy. Supinator crest I haven't done either. That's termed the Wrightington approach. It's been written up. It's analogous to the Boyd, which we'll talk about, but it's with bone. Okay, we're almost there with exposures. I don't know why I put this one at this point, but this is kind of showing lateral exposure. I think this shows the osteotomy. Yeah. So sometimes we come in, we can see what we need to see, but we want to see more radial head. Maybe then it goes down the neck. We want to use a prosthesis. So if we come in above the equator for sure, or if we know we're doing an osteotomy, I'll cheat even further and keep a lot of that LUCL attached to the epicondyle and then make an osteotomy. And once we make that osteotomy here and flip that out, it's like opening a door and we can see straight down the radius. And then we can put it back with screws or a plate or even circulash wires. So here's a video showing kind of what you can see with an osteotomy. Just in case there's audio here. Yeah. This is for OCD of the elbow. So it's already been made. You can see all that vascularity on the collaterals. You don't have to worry about isometry because we're just taking it all down. I've cross-cut and flipped. So there's the radiocapitellar joint and a little bit of a split in line with the extensors. But the nice thing is with that off and a little bit of retraction, and now I put a bone clamp on, I can roll that distal humerus out and see that lesion and get pretty extensive exposure. So it's a small skin incision. It's a very direct exposure, but it's very extensile into the cartilage. And they can let you do things like this. You can see that single screw, put back in for that. But this was a complex radial head fracture of a young kid. I think it was a high school classmate of my son's. But I've got a cross screw getting two pieces together, and then I've got 3 tripod screws. And as we mentioned, I think yesterday I showed some pictures, a very powerful fixation, very strong, with limited fixation, no plates to get stuck. But it's hard to get around that circle and get those screws down. You open it up with an osteotomy, now you're looking down much, much easier. So if I'm doing a radial head fixation through an isolated exposure, I'm very quick to do that. Okay. I think, so these are anterior approaches. I mentioned yesterday, I don't do these really, but I did want to include them. I think it's, there are people that do them. I think it's certainly an option. I think there's better ways to get to the coronoid. That's typically what people talk about with the anterior exposures, but it's worth talking about quickly. This is a slide from George. He likes extensile exposures as well. Henry talks about going from delta pectoral all the way down to the elbow, all the way across, all the way down to the wrist. He's got all that in there, and they're pretty well defined. This is the one paper I found that was pretty reasonable, and what I found interesting is, you know, they actually split the brachialis, which I think at least answers some of the issues I've had with the one time that I did it in person and a few times I looked at it in the lab. So this is a 2012 paper. They're coming between the biceps and the median neurovascular bundle, and then they're splitting the brachialis. This picture shows their coronoid exposure, which is it's impressive. I think for a thin arm, for an isolated coronoid, I suppose it's an option. I haven't done it, I don't do it. Another way to get to the real tip is just extending your lateral soft tissue exposure, just retracting. I would argue that in a thin person, that's probably going to be as good as this, but again, I have not done that. All right, on to posterior. So typically it's going to be a posterior skin incision. We're going to go posterior olecranon osteotomy. We can leave the triceps on and work around it, and there's multiple ones for that. And then we can attach the triceps. I'm just going to briefly talk about those. I don't think those really have a place here. They're more for, I don't think they have much of a place other than a tongue for total elbow replacement. That's the only time I detach the triceps now. But there's splits and extended columns and whatnot. So olecranon osteotomy, you all know, but what are some of the details? Find the nerve, get the soft tissue out, and then I think most people make a chevron. That's how I was trained to do it. I like the way that it keys back in. I like the way that it allows for the rotation to be proper and then get good compression. I use a saw. I think a good tip, I don't have a picture of it. I will dissect a little bit more. These are George's pictures. I dissect a little bit more here. I want to see the joint on both sides. I will slip a gauze through, which usually can take an artery and just come through, grab the gauze, and then you can lift up with that. It does a couple of things. One, as it lifts up, it finds the center of the articular surface, so it kind of guides you to where that is, because I've made the mistake of making my tip, my chevron too distal or too proximal, so it guides me that way. And then if something happens where I go a little deeper than I should with something like the osteotome or the saw, the gauze is there lifting it away from the cartilage. That's a Jesse Jupiter trick. There's a picture somewhere, and I don't know where, I'll have to find it. I like to do this where I'll start with a saw and finish with an osteotome and crack it so that there's less of a kerf or loss of bone from the saw itself. And just kind of teased it off, but he hasn't done anything with it. But I just, in our residency, we just take the whole triceps and flip it back and kind of ignore that. Of course, if we do that, if we make a proximal deeper dissection along the edge of the triceps and cut the anconeus, we take the neurovascular supply out because that runs through the triceps. Some people call the anconeus the fourth head of the triceps. So as we come through that, we'll denervate it, we'll kill it. So my philosophy is, well, if I'm going to kill it, I might as well dissect it out and use it. It's a viable piece of tissue I can use as a flap to close over things, or maybe I won't even attach it all the way. We all know the exposure we get, especially for something like a supracondylar on a osteotomy. But I like to save the anconeus, so I'll dissect it off and flip it back on adults, and then use it for soft tissue closure. And of course, here's the typical exposure. So how do we find how do we preserve the anconeus? There's a fat stripe that we can usually see between the anconeus and the extensor, and extensor carpi ulnaris. Once I'll usually make a little nick, slip something in there and size it, and then I can find the anconeus and work around it, free it up. Just like any other attachment, like we talked about the subscap, a little easier to find the separation distal and work my way back so I can keep the capsule intact in the LUCL. So this is a case of a intra-articular osteotomy for a malignant of a distal humerus. I think that Tade showed us a case that he's got coming up like this, I think. But here's my, so I've got the fascia on, that's my anconeus. It goes a lot further than you think. I think that's probably one of the disadvantages of doing this, is you do have to make a longer incision up the ulna to get to the tip of the anconeus. That's just the medial side. So here we are, I've flipped it off. Most importantly is I've not gone deep and taken all this off. This is the LUCL, so the attachment of the collateral here, coming up over the radial head and attached to the supinator crest. Supinator is coming off this way. So as I take the anconeus off, I can use a cob or something and take it right off a bone. But as I get here, I want to take it and peel it off the capsule and leave that capsule intact. So I've peeled it back, and then I can flip the whole thing back and see what I normally see. The other thing I like about this too is the way I was trained to just cut it and ignore it. There's the remnant anconeus that you've just cut is stuck to the back of the capitellum, and it just gets in your way. It obscures visualization. So I'd rather see this and see that back of the capitellum free of tissue. I can see into the capitellum and see over there. So I think it's just a better view. A little bit more work. These are the slides I put in this morning. Dwayne and I have talked about this. This is a variation of this theme. This is a case of about a 6 or 7 year old kid with a lateral condyle non-union. So how do you get to that interarticular problem in a kid who's got periosteum intact, has got growth centers intact, the back of the anconeus is a pedicle probably to the capitellum. So this is a variation. So I've come in, you see what's medial, you see what's lateral. I've left my anconeus attached to the back of the capitellum. I've left it attached distally. I'm not rolling it back. I'm taking it off the periosteum of the ulna and rolling it. So an osteotomy of the olecranon, and I'm just flipping it now and rolling it. So I'm not taking it all back and bringing it back this way, but rolling it lateral. So this is actually the end of the case because the pins are back in. But you can see the osteotomy up here, osteotomy of the olecranon. Anconeus is here. And now when we roll that, I've left the anconeus attached to the back of the capitellum. Here's capitellum. I've peeled it off here, hopefully leaving the periosteum. I've left it intact. So I've left a lot of vascularity intact, but now I'm down into the elbow and I can see the trochlea and the non-union and work. Now I can work in the fracture. There's a big defect. Unfortunately, I did not graft this with autograft, which is what I should have done. It didn't heal. Osteotomy healed, but this did not heal with this procedure. But we can see when we're done, we're back, medial, lateral, all that soft tissue is still intact because I just rolled back. This I closed with 2 pins, and I made a tension band with actually Vicryl. I braided Vicryl and made it. That way I could pull the pins in the office and leave the Vicryl. And so the kid healed his osteotomy with no problem. And that osteotomy, you put it kind of where you normally put it, and that is distal to the growth, the physeal center, so you're not getting into the physeal center. Just to show a picture of how I do my lateral epicondylar osteotomies, I'm doing them from inside. I want to come inside along the trochlea. I want to countercut the humerus here so that it doesn't splinter and it has a place to kind of go. I start from inside and go out because if you start from outside and go in, it might be too thin or too thick. This way it works out quite well. You can protect the cartilage, you come in, lever it out, and open it up. So this is that case I had showed that I flipped the olecranon back with the triceps or with the anconeus attached to it. But I added a lateral epicondylar osteotomy, and now that's the exposure we get. So I needed to get in and move this articular piece. Now this is a piece, I don't know how I can do this and keep all the soft tissue attached to this piece. I would argue that the fracture didn't have much attached initially. But this allows me to get all the way down. We can see the radial head off to the right. We're looking down, the medial collateral is still attached. The lateral collateral is attached to the osteotomized piece. Olecranon is flipped back. I'm in the elbow joint. I can osteotomize the joint itself. This is a 15-year-old kid, and that actually healed real well. Oh, so paratricipital, I think I put a question mark here because I don't use it too often nowadays. But this is coming out both sides of the triceps and anconeus. So we're on the outside of the extensor mechanism, mobilizing the tissue, mobilizing the nerve, and coming up the columns. They get good soft tissue exposure, leaving everything else intact. It allows us to get to the bone, but it's limited, very limited joint visualization, and it can be difficult to do fracture fixation with this sort of exposure. But it's doable. This is George's case.
Sorry, what do you do to anconeus on this side?
This one, so the paratricipital is on the outside of the anconeus because the paraolecranon is on the inside, which we'll see next. Yeah. So lateral paraolecranon is then to take the anconeus and take that off with the extensors, or to split it coming along the olecranon. So we're splitting, and we come up into more of a triceps split then. So we're limited proximally a little bit, but looking at a right elbow here, typically like around, that gives us more exposure as we release. Now here's the back of the capitellum because we've released the anconeus. Tricep split, directly up, splitting. I think that's good for limited exposures. I've never used much tricep splitting. I'm always worried about the radial nerve. I'd rather just mobilize the triceps. And then this is a slide from Athwell from Georgia saying you can, I mean, whether you call it extensile or not, you can come up and detach the triceps. But triceps attachment, that's a whole other complication you've just really essentially created. It's hard to get these to heal real well. When we look at the data on triceps releases, I don't think they're worth doing. I would say don't do it unless there's no other way to do what you have to do. So tongue procedures, Van Gorder, Campbell, Wadsworth, some sort of a VY, or Sean now is talking about doing it, and I've done what he calls a diamond pop-up for total elbows. There's some discussion using these for fracture. I'd rather have bone heal than the soft tissue. I worry about this. I don't do a lot of these. Void is to come down along the right along the ulna and release the anconeus off, coming down to the radiocapitellar joint and the proximal radius. If you go to do this and not release the lateral collateral ligament, it's a very small exposure. You can do it to get a peak if you want to see the radial head, maybe to put a screw in, but other than that, you're not going to get enough visualization. So this picture on the right, the lateral collateral ligament is with that soft tissue sleeve. But the nice thing about this is we don't have to worry about this picture's small. We don't have to worry about the radial nerve. So this is a revision case I did, and I came right down the ulna, right to the radius, and the radial nerve is lateral or anterior, and if we're going to even take soft tissue off and elevate it, it's in the supinator as we do that. So it's a great exposure. It's easy. It's fast. It's pretty reliable. We just have to make sure that we fix the lateral collateral ligament when we're done. If it's a real stiff elbow, we might be able just to close the soft tissue up, preserve the scar tissue when we do a big release or something like that, and that probably is enough. If it's an elbow that had relatively normal motion before, I think we need to do something through bone tunnels. Alternatively, we can do a Wrightington supinator crest osteotomy. So in the pictogram here, we've got we want to come in through the back here. We've released the anconeus. We osteotomize some bone, flip the rest of the anconeus with the supinator tuberosity or crest, and now we're looking right at the proximal radius. Some people on the elbow group talk about fixing radial fractures with this approach. I haven't done that. I think for a plate it certainly is very reasonable. I've done more of these recently than I started to do. I think it's a good approach to know how to do. Lateral approaches, Kaplan, extensor, digitorum communis split, Coker, and osteotomies. You've seen the osteotomy already, lateral condyle. Coker's interval, so you can see this in a nice picture. It shows that fat stripe right here. So this is all anconeus. You look for that, you split the fascia, you're in the interval. You can go up to the epicondyle, down to the insertion of the anconeus. If you took a knife and you went right down to bone on Coker's, you're going to go through the LUCL. If you leave it, you can, but if you elevate the anconeus and retract and see that deep layer, you're leaving the lateral collateral intact. So you want to go from distal to proximal and preserve that deep layer. You don't want to just start plowing through and taking it down. So that's the interval there. Again, these pictures are from George. So this is he's in his Coker interval, but he's pulling the ligament down. And I do, it's interesting, I see pictures sometimes, especially if we're looking at radial head work and some of the papers that get published. Sometimes they're retracted, and I wonder what's left of that ligament afterwards from the Coker approach. I think the concern I have here is you put an elevator under that neck and you really retract. I think you're tearing or stretching out that LUCL sometimes. So I think the exposure can be okay, but I wonder if it comes at a cost of the ligament. So he's got his rake now on the lateral collateral ligament. This is a pretty extensive exposure for a plate through a Coker approach. We can go real small and just grab some tissue, go through bone tunnels and fix the lateral collateral ligament. This is a great way. This is a great technique for like a varus posterior medial rotatory instability injury, where we're going to do something on the medial side to the coronoid, put a plate, fix it, lateral incision. And again, I think when I was taught initially, I would have made a big, huge incision, gone medially, fixed the coronoid, come lateral, and fix the ligament. But this is much better. Small, especially the lateral. The lateral can be a very small incision. So EDC split, George had this talk split up. He had an EDC split separate from a Kaplan. I honestly had to go look at the pictures to see what the difference was, because in my head they're kind of the same, and it's very minor. So you know, EDC split, splitting the EDC, that's the upper picture on your left there. Basically on the lower, the Kaplan on the lower one on the right, just above, so you're at the top of the EDC, behind the ECRB, the ECL wrist extensors, and so you're seeing maybe a little bit less. I don't know if when I'm making my incision, especially in trauma, I don't know if I can differentiate between these tendons. And if you look at some of the, I think Mark Cohn's got a paper where, again, they dissect distal and come proximal to find these origins, because it's really a fan of origins altogether here. So I'm not good enough to separate these out. So to me, this is kind of the same exposure. I'm finding the epicondyle, I'm staying above, I'm at about the equator, about the halfway point, and then splitting down to the neck. And that's so to me, an EDC split Kaplan is kind of my radial head exposure, kind of the same thing. Again, we're not elevating big flaps. This is just for the anatomic dissection. We're finding that epicondyle coming down over the head, supinating, coming down to about the neck. When I start to go past the neck, I get nervous about the nerve, and I'll do something about that, which I'll tell you in a second. So we'll come down to the neck. This is not my picture, but if this was my case, we can see the extensors on the left here split, and here this is probably supinator here, and so you can typically get your finger. I don't know if that may or may not be that may be supinator here, but when you're there, you can slip your finger under the extensors on top of the supinator and feel the radial nerve, and then know where it is and not go distal. You could extend distal superior and then split and look. Or if you want, you can come up on the inside here and look for the fat and find the supinator, or find the radial nerve coming into the arcata froge. And that's what we did in that other case where we had some HO, we found the radial nerve up here. As it went to the arcata froge, we could retract it and then take out the HO. So know these intervals, know where the nerves are, so you can be protective in how you approach it. So going for the radial head, I'm not a big Coker fan. I feel like it's a little bit too far posterior. I'd rather make this EDC split / Kaplan and come and take care of it that way. This is a small split. This is a capitellar shear fracture, small piece with a radial head fracture. And then we can just come down, we can split, and then we can close in layers and get a good closure of the soft tissue. The lateral collateral ligament's kept intact here. I already mentioned the radial nerve. Again, Henry, he talks about taking 3 fingers and going from the radial neck down is where it enters a supinator. It's palpable in the supinator, and you can do a little bit of a split window there and find it, and work your way back if you like, or find it up here. And this is just showing radial head exposure. This is more of this is a split. I think this is George's pictures. So we can go into that. We can go with Coker or even split and then up the lateral column. Dwayne showed the column exposure for stiff elbow, and I do this all the time. So split, Coker, either way, come up the column, take the triceps off the bone. So here's that fat triangle up here if you want to find median nerve flexor pronator mass here. Or I'm sorry, I'm on the wrong side, lateral side. So brachioradialis here. So we release here. We can come and release the brachioradialis off and get the exposure, leaving the collateral ligament intact. Posterior capsule. So the forceps are showing the approximate position of the LUCL. Come further posterior. Open that window there. Brachioradialis. We can elevate that off. come all the way across. So once we combine these exposures, we can get pretty far. As I mentioned, you can get to that anterior coronoid, and even if you extend that up far enough, if you come up far enough here, you can get a drill bit down even and come straight down on that coronoid. So you can get to the coronoid from the lateral side of the tip. I mean, I haven't done it, but I've seen presentations on it. This is a good picture to show you what you could get if you want. So that's lateral approaches. So now we go to the medial side. The Hotchkiss is analogous to the column. It's coming down and then coming into a split. We can find that median nerve in the window, like we mentioned, between the pronator and the brachialis. We can look for the ulnar nerve and palpate it or open it up. And as I was going through this last night, looking at the different approaches, there's a lot of different descriptions now. There's been multiple papers written with different eponyms, names of people who describe things. The Taylor and Sham name gets thrown around a lot. I had to go back and look it up, and there's a lot of soft tissue releases distally, including the digital flexors. Shukla and Hausman just talked about being more proximal and basically lifting the whole flexor peroneal mass up with the nerve. Other authors leave the nerve behind and lift it up without the nerve. I think, as I wanted to kind of come up with a unifying theory here, or unifying discussion. The bottom line is the flexor peroneal mass is covering your coronoid. And you know where the nerve is, you're looking at it. You know where the sublime is, you can feel it, and it's just anterior to your ligament. You know where the ligament runs. And I guess I would say split or release what you need to do to see what you need to see. I mean, it's great to have these windows and to talk about them and have names, but sometimes I think it complicates things, at least for me. At the end of the day, if you need to release the whole flexor peroneal mass, do it. Have your exposure. If you want to split it and you can get in, and you want to make a couple windows even for a plate, if you protect the nerve, you'll be fine. You can split the flexor peroneal mass distally, at least to the sublime tubercle and beyond, and that's safe as well. So this is not a Taylor and Sham. It's not the modified Taylor and Sham because the nerve's left down here. But this is just showing lifting that flexor peroneal mass up, starting distally, coming back, finding the MCL and lifting up. Elevating the flexor peroneal mass at the attachment off of the MCL, right? There's the MCL right there. And then here's the coronoid. So we've got distal humerus, MCL here, and there's the very tip of the coronoid, leaving the nerve intact here. So that's a great option. We can see quite a bit here. But if for some reason we were struggling, we can release some or even all of this. If we're talking about elbow instability, especially if we have the luxury of being there on an acute case, you want to get that fixation right. You want to get really good fixation. You want to get that elbow stable. If the flexor peroneal mass has to be repaired at the end of the case, I think that's the least of our concerns. So know your anatomy. Here's a fracture here. This is George's case. So MCL, we've lifted. Now this is more, this looks to me like it's his, I'm using that modified one I just mentioned, because here's the ulnar nerve coming up. A flexor peroneal split, he's left the posterior aspect of the head intact. Flexor peroneal mass. Here's the fractured coronoid. You can put that back in. Same case. MCL, sublime, plate right on the sublime going down to the shaft here. He's elevated that posterior head of the flexor carpi ulnaris off the ulna. So it's all about just seeing what you need to see. You can split that flexor peronator in line with the fibers and get down. That's more of a technique for if you're going to just treat the ligament, but if you have something that's a big piece that you think needs one screw maybe, or you're doing fixation from the other side and you want to augment it somehow, certainly reasonable. That's a split. This is the case that I showed you yesterday. So this is a split. I've released the MUCL here because there was a secondary. I couldn't get that piece the sublime wasn't completely free, and there was a piece from between them, so I just had to open the sublime open to get the other piece in and back in, and I pinned it, and I just fixed the MCL. So the point is, if you have to do some soft tissue releases, do them, get the bone right, and then again, as I mentioned, if you have to, take the whole thing off, that's okay. Here's a flexor pronator release. Ulnar nerve's been transposed, it'll be left here subcutaneously. Not great pictures, but this is a chronic big piece right here that we were able to manipulate because we had everything released. So this is my first visit in 2020, and this was a couple days ago. So, Scanalo, thanks everybody for the time here with you, and thanks for sharing with me. I've got one more to give, but or one more talk, and the other one won't be slides. But I really appreciate everybody's attention. Any questions on approaches, thoughts about that, anatomy, or maybe even comments about what you like to do that's different than what I spoke on?
So if you were to recommend one approach for the coronoid, it would be what?
So medial coronoid, right?
Yeah.
So if I'm going to recommend one medial coronoid approach, I'd say get the nerve mobilized, probably, especially if you haven't done it before. Get it out of your way. I'd elevate the flexor coronary mass up, and then if I needed, I would just start to release it on the way up from the bottom up to get a little more exposure, keeping the MCL intact. Yeah, that's what I would do. Because that way I've got all the ulna exposed for a plate and the nerves out of the way, and I can see everything I want to see, and if I just can't see enough, I just keep opening the window further. And that to me, it just makes, it's just easy to describe. Instead of saying I'm going to split, this way or that way, or make two windows, or because after a while, it's like, why am I spending all this time trying to preserve the flexor pronator attachment? That's the least of my worries. It's the least of the patient's worries. I mean, look at the chronic elbows you take care of. You release the whole thing and don't even put it really back. I mean, you're barely back. Not that you want to restore anatomy. Obviously, we always do. But the worst thing is to go into an acute elbow fracture dislocation and not render it stable. Then we're going back again. It's a much harder operation. That first one's always the best one. Is there another question?
Yeah. So, for the medial approach to the coronary, can you just specify the medial epicondyle?
Yeah. So yeah, question is, can we medial? I've thought about it. I haven't done it. Can we? The question was, can we do an osteotomy of the medial epicondyle? I haven't done it. I guess the only comment I have is, I think there's a possibility that if we did that, then the MCL would be on the piece we osteotomized and on the fracture piece. It could be completely free. And while that would give unbelievable access to everything else and probably could be fixed very well, we certainly wouldn't want it to end up on the floor. I mean, I think there would be a risk of that. So I would be concerned about that. So I think if I needed to get into the joint that otherwise was relatively intact, for some sort of interarticular problem on either the ulna or just the humerus, I might consider it. But I haven't done it. And then of course you got to flip the nerve if you're going to do that, because if you osteotomize the medial epicondyle, even if you kept the nerve safe, the nerves, as you jack the joint open, the nerve's going to slide up into your exposure. So you're going to have to transpose the nerve. Right. So transolecranon, basal coronoid with radial head fracture, and I didn't put those pictures in. We showed some yesterday. I'm going to go through the fracture. So I'm going to work through the olecranon fracture. Posterior approach, minimal soft tissue dissection, and my window to my radial head is through the fracture. I'm going to slide it up. I think that's much easier than sneaking around more soft tissue dissection. Sneaking around to a separate deep window, or even a separate skin incision, I think it's harder. That pops up. You remember those pictures I showed yesterday of the radial head popping up, right?
Yeah.
Yeah.
So I remember you fixing the coronoid first, radial head second.
Not really.
And then the shaft first.
Yeah. So I go in. I want to make sure I can fix the coronoid first, so I get it all ready. Like, how's the reduction look? What are we going to do? Where do we put a clamp? Where are the screws and wires going to go? So I know it's all reducible. Then we let it fall apart again, and then we sublux the shaft up, the proximal radial shaft up, and we use that fractured coronoid to let it, that falls off to the side, so the stump of the ulna comes up with the radial shaft. The ulnar and radial shaft both come up, and then we can fix that head looking straight down, and then we carefully put it down, and then we close the book on the coronoid piece to the shaft of the ulna. Does that make sense?
I'm not sure if it does. He agrees with me. I can't picture it.
Let's see here.
So you want the medial coronoid ready,
So-
the coronoid ready.
They're usually
But you don't fix it.
Right.
You sublux the radial head, rigidly fix that, reduce the radial, the proximal shaft, but then how do you see it?
So
You still can see it.
see which one?
The coronoid.
The core, you can still see it. Right? I mean, these are usually pretty big pieces, and there's usually a medial wall of ulna to up into the sublime. Even if it's a smaller piece, you come up into that. So you're looking down. I'm supine. I'm looking down. Let's say it's a to be a left elbow, I think. So the radial head's over here. I'm looking straight down. I got my ulnar nerve here. As I look down that medial wall of the ulna, and then I have that piece of the coronoid. It has that, I look at that medial. I get that medial read, right? So that's my reduction. I can see that when the radial head's reduced. But what I don't want to do, I'm afraid well, two things. If I fix the coronoid first, the proximal ulna, well, it's actually the distal piece, but the shaft of the ulna and the shaft of the radius don't want to move as much because they're tethered by the MCL, right? So I can't get that radial head out probably if I fix the coronoid first. Or if I can, I'm really going to be levering on that radial head. And even though I think my fixation is good, it's not that good. So I want to fix my radial head without any, with maximum exposure, and I want to put it back with minimal trauma. But I'm also concerned if I get in there right away and I just see my radial head and I pop it up and I fix it and I put it back, and now I look at my coronoid, I'm going to spend all this time trying to figure out where do I put my clamp, how do I get it reduced, I got to clean it out, and I don't want to damage my repair on my radial head in doing all that. So my first step is to come in and get a read of everything, get pieces on the back table if I have to, especially radial head. But one of the, if not the first thing, one of the first things I want to do is get my reduction doable, completable of the coronoid. Clean it out. Again, where am I going to put my clamps? Maybe sometimes how you put a little drill hole for a clamp tip or whatever. I want to be able to decide where my plates are going to go. Sometimes I'll use, in this case, one of the cases we did last week, we put a little mini plate to hold it, but also to hold the reduction. And then a second little mini plate to make it become one ulnar piece, so that then I could bring the coronoid or the olecranon over and close it. But I want to have that all set up. But I don't want to fix any of it. I just want to know.
Is that clear in your PowerPoint from yesterday?
I don't know.
You don't have to check it out.
Yeah.
I think that'd be very helpful to have that order.
I wish we had pictures. I wish we would have taken more pictures in Soto, because that case we did was really good. And I've got a couple other cases. Next time I do it, I'll take pictures, because I think that's a very good exercise to go through your head of what's the order. And I mean, we were talking about it to the team. I said, okay, this is what we're going to do. I'm going to the back table with Ian. We're going to look at this radial head. I want you two guys to figure out how to reduce that coronoid piece. And so Ian and I are on the back table taking the radial head. We put a K-wire in it. We put a screw in it. Now we made it one piece. Come back over, and they're like, okay, here's a reduction. We put a clamp here, and we got this piece here, and they had a perfect reduction. Okay, great. Let it go. So you have to just let it go. Popped up that radial shaft and ulnar shaft, and we had a radial head. It was actually on a pin. We could align it. We had a good cortical read. A little thumb pressure, compress it. Screw, screw, screw. Three tripod screws. Again, great visualization because we're looking down at it. We had a 360-degree look at it. Okay, let's put it back in. Reduced it carefully. Now we've got proximal radius is intact. We can kind of balance on that. Bring your coronoid piece back, clamp it. That's it. Hold it with some K-wires and a plate. Plate. Now we've got shaft of ulna to coronoid. Now we have shaft of radius to radial head. The coronoid's intact, the radial head's intact. It's now a simple olecranon fracture. Bring the olecranon over, and I wouldn't K-wire I like the K-wire in tension band, but not for a fracture like this. Way too much, even with that rigid fixation. I want to bypass that coronoid piece. I'd love to get a screw into it as well. So now we've plated the medial cortical reed with a unicortical plate, but we've also got a screw through the main plate of the, here I can pull it up. I've got a screw through the main plate, and I think it's case 3. Yeah, that's it, case 3 right in the other one. So I've got, so we're leaving this alone, or to get to the radial head and fix that, and then once we reduce it, radial head's been reduced. So we've got a read on that. We bring this in and reduce it. We put a plate here and a plate here, and then it's just fixing this olecranon. But again, we actually cut the plate down. It was too long, but could probably want one shorter. But long plate, bypass it. We got to screw up into that coronoid piece, and then we got this screw across it as well. So this large coronoid piece has been neutralized with unicortical plates medially here, and then it's been fixed with a screw up into it, and then it's got a home run screw into it as well. And it's neutralized with the plate.
So that coronoid, you can fix it after you reduce the radial head, shaft. What if it's really anterior and you can't see it from the medial side?
Well, we just talked about medial exposure, so you should be able to elevate that flexural coronary mass and get up there.
No, but you're doing it through the
Right, but you can, so you're looking down, you're seeing the ulnar nerve, right?
Yeah.
It's a deep exposure. You're not elevating the skin flap. The ulnar nerve, you could leave it and do that, where you elevate, or you can flip it out. You can get there. You're on the bone already. Just keep coming up on the bone. You're in that deep exposure, and you can extend it that way. But I don't think you need to make a separate flap, skin incision, or a separate deep window even. You just come right on the ulna. But usually they're big enough. Now if this piece had a fracture right here, right? It was non-displaced when we left it alone. Let's say that there were 2 pieces here. Then while I was working on the back table, I would have been telling them to try to figure out how to make this one piece, right? Let's get a screw up there, or some K-wires up there. And that's the nice thing about from working from inside. Let's say this piece. An option would have been to take a K-wire, even a threaded one, right, and thread it up. And here to protect it like rebar, and then just leave it. Cut it right inside the fracture. And then that wire can't go anywhere. So leaving wires inside fractures is great because they can't migrate out typically. So that's another option too. But right, we fix it here, to your point. We could have marched further up from the inside and gotten up here if we had to. All right, great questions, great discussion. So now we're on to, yes, go ahead.
Yeah, we don't have like a smaller saw. So while I was starting my practice, like I was doing olecranon osteotomy, it takes like a bigger size for us, and it will shorten the olecranon. So now, rather than doing olecranon osteotomy, through time I accustomed to do tricep splitting, and I was just working with IB6, pulling, and the whole fracture line is visible, the intraocular surface. I fixed everything, and then finally I drilled 2 places on the olecranon tip and SHR bar. The only thing which I always worry is like to have like a full cuff of tissue on the bicep, so that I will cover it back. So do you recommend still the olecranon osteotomy than tricep splitting in resource.
Right. Well, it is, yeah, so the tricep split better when the resources are limited. A couple comments. I mean, if you don't have a small saw, what I would do is use multiple drill holes and then complete it with an osteotomy. It'll be even more irregular and probably lock in better. So I think that's an option. If you have other reasons because you're just so short on, you don't want to have to wire it or fix it or plate it, I think it speaks to the skill of the surgeon. I think it's harder to do a split. It's harder to see. If you can lift up and see the whole distal humerus, you're probably releasing some of the collaterals. That may not be a big deal in a distal humerus fracture. But I just find the visualization more difficult and difficult fractures because there's many times I've said I'm going to leave the triceps on today and try to work through windows or a split and struggle and then just do the osteotomy. So if you can do it, I think it's great. If it's a true split and you're just releasing a little bit of triceps and you can close it, I think that's fine. I'm not a fan of a complete triceps release just because I think the failure rate on those is significant. And then you've got a soft tissue problem too because you've got thin skin and the bone. I mean, the triceps almost kind of protects, right, that knobbiness of our bone. And if that only comes through the skin incision or through the skin itself from a pressure sore and there's no triceps and it's retracted, it's a horrible complication, lose the extensor mechanism. But if you can do it, if you can see it through a split, great. It's just a matter of can you see it and can you get it? So it's kind of like the coronoid. I mean, if you can do, people are at the podium and they talk about, I always do this split or this interval and that's great. I don't have a problem with someone leaving the ulnar nerve in situ and doing their coronoid work through some sort of a window. I just find, especially in talking to other people, and it's me too, but then they'll say, well, it's hard to see. And so again, my answer is get the exposure. And get the exposure and don't worry about releasing more soft tissue. So, but yeah, I mean, a big curve from a big huge saw, yeah, you can, and if you go all the way down, you are actually compressing that a bit. Or even if you crack the articular surface, now it kind of angles weird. And that's why sometimes I think pre-drilling doesn't work so well, because you may change it just a little bit, now the pre-drilled stuff doesn't work quite the way it used to. Any other questions or comments? All right. Some of you, if you were at St. Paul, this is a variation of a talk I gave when I was there a few years ago. What time are we supposed to have tea break? We're pretty good, right? What time is tea break? 10:20 is tea break? Okay. And then is physical exam after tea? Okay. Yeah, we'll finish it. So change the length of the flexors. That's why we deviate and extend in power grip. It's not a simple motion. We talk about flexion, extension. Scott Wolf has done a lot of what he calls the dart thrower motion. He argues that that's why humans evolved to the point we were at with using tools. The dart thrower motion is the motion we use, obviously, to throw darts, but more importantly, to throw anything else, or to use tools, hammers, mallets, and so that kind of what allowed us to advance with our tools. Full wrist flexion reduces finger flexors to 25% of their strength. We come down here, we're very weak, right? So wrist is important for power, important for motion. Radiocarpal joint, 66% of wrist extension. Mid-carpal joint, 60% of wrist flexion. So, this dual joint allows for flexion and extension, but we get more from the radiocarpal for extension and more from the mid-carpal for flexion. So we can't, as soon as we lose one, we lose a lot of one of the directions. Most important structures, we need to understand the carpal ligaments. I think I mentioned them when we were talking about, maybe that was last week, we were talking about scaphoid fractures and scaphoid non-unions. I like to think of the wrist as being a bit spring-loaded. There's a tension built into it. The scaphoid is a link between the two, and there's potential energy stored up in there. And the scaphoid is like a spring that's been wound, and if we cut the scapholunate ligament, things separate, the scaphoid flexes down, the lunate goes up in the DC like this, and we lose that potential energy. So the scaphoid is a link between the proximal and distal carpal row. It stabilizes the compression forces of the capitolunate articulation. It allows for the two rows to work together. Scapholunate ligament injuries, that's part of a perilunate injury. That's falling in an outstretched hand. We look for pain, we look for widening of the gap, we look for the scaphoid flexing down. So kind of a relatively common injury. Scapholunate instability, most common pattern of instability. The scaphoid flexes, it pronates a little bit. The lunate extends, triquetrum goes with it. The scaphoid moves with the capitate. If that's left untreated, we get what's we call a slack wrist, scapholunate advanced collapse. And that's what we see. We see this DC pattern here. We can see this when we can see the lunate tip up when we have a male union of the radius. It's called non-dissociative. So we look on x-rays for the angle of the scaphoid. It's flexed farther down on it when the LT ligament's cut. There's different classification system for acute injuries. This gets really into a lot of complexity that there's a lot of disagreement about as far as what's a pre-dynamic problem if they really exist. Dynamic is when things still move, but move improperly. Static is when things are stuck. And then when things start to break down and wear down and get arthritis, we get a slack wrist. We'll talk about exam in a bit. Watson's maneuver or dynamic shift. This is another thing that you can get a couple hand students together. They'll talk about how you really do this the right way, what it really means. What I do is I put my thumb on the patient's tubercle of their scaphoid. I radially and ulnarly deviate. I try to compare it to the contralateral side and see what it feels like. If it feels the same, I think it's kind of normal. If it clunks or you can feel it subluxing as a scaphoid, some people say it catches up. It's flexed way down, you extend, it extends up, and then you come back and it clunks back down. That's abnormal. That can be a sign that there's a dynamic problem. On x-rays, if we don't see any fracture, we look for the signet ring sign. That's because the scaphoid's flexed down. We're looking at it now, it's like a tube instead of a longer bone. That's a sign the scaphoid's flexed. The lunate typically looks a bit odd on those x-rays as well. As it extends up, we get the lateral, we can see that lunate up, scaphoid down. We start to see the scapholunate angle increase past 70. So normal is about 45 degrees plus or minus 15. So this is what we see on a scapholunate ligament injury. That's the first problem that occurs if we're headed towards the perilunate. We can get x-rays. A cleansed pencil view is nice. This is good because we're grabbing a pencil, we're squeezing, we're applying compression. We're probably going to separate the scaphoid and lunate if they're abnormal. What else is nice about this is it forces us to get two views of the wrist, or I should say one view of each wrist, right and left, in the same plane. It prevents rotation as well. So this is a nice way to get a decent x-ray, hopefully. Looking for that widening on the pathologic side, like that. So that just shows that if we don't have the pencil in there, we're not in the right angle. So we can look with fluoroscopy, arthroscopy, MRI, arthrography, looking for that tear. And then the treatment's kind of controversial, even for acute tears. Capsulodesis, tenodesis. We're not going to go into this too much. Brunelli is what I typically do for a tenodesis. Limited fusions, and then when there's arthritis, there's procedures for slack wrists. Brunelli is what I typically do. Take a piece of the FCR, bring it up through the scaphoid and hold the scaphoid down in a more anatomic position. There's a more anatomic procedure that's making its way through the hand literature and hand surgeons called acronym ANAFAB, anatomic front and back. So it's a very multiple drill hole, multiple ligamented procedure to reconstruct the scapholunate ligament here to tether the lunate down palmarly and also recreate the palmar aspect of the ST joint. Indications, this is again controversial. If someone doesn't have arthritis, if their joint's reducible, a lot of people will try to fix a ligament acutely if it's in 3 weeks or so of injury, maybe even up to 8. Chronically, they'll do some sort of a capsulodesis or tenodesis. There's an argument growing that, especially if you see this injury in someone my age in their 50s, or Dwayne's age, you're 65 now, right? That we leave it alone. when people have a scapholunate injury ligament, and it probably can go 20 years or more and not bother them. So if I fall on my way out here and we get an x-ray and I have a widened scapholunate ligament, a gap, I'm not going to have anybody operate on me. I'm going to rest it, I'm going to rehab it, and probably do just fine. And maybe even that was there before and I didn't realize it was chronic to begin with. Young people, people your age, most surgeons will fix it, but there's some concern that maybe we don't know how to fix it the right way and maybe leaving it would be just as good. There's been some descriptions of procedures that have a lot of implants and a lot of drill holes, and when those go bad, it's a real big problem. You make somebody worse. So scapholunate ligament injuries are an interesting animal. When I was a medical student in 91, I was in Australia, and I couldn't make the appointment, but I was going to spend some time with Tim Herbert, who ran the Herbert Screw, and I remember calling up, and his nurse, who was really nice and was going to let me visit for a day, said that, oh, he's working on a new procedure for the scapholunate ligament. Well, 30 years later, we still don't have a really good one, and he was a genius at that sort of thing. So there's this anafab might be the answer, but nobody knows for sure. So scapholunate ligament problems are difficult, and there's not simple solutions. Intercarpal fusions have been promoted as treatments for ligament problems. I don't typically do them. I think it's more than is needed typically, and they have their own complications. Watson is a big proponent of that. Reconstructing the scapholunate bone like an ACL with a bone tendon bone, that was a big deal for a while. That's kind of fallen out of favor. Putting a screw across there after cleaning it out is Mel Rosenwasser's procedure. It seems like he and a few others are the only ones that can get this to work. I don't use this, and a lot of people don't use it. The results deteriorate over time if left alone. You do end up with a slack wrist. Fusions can be salvaged, proximal rose salvaged, complete wrist fusions. Some I have, but we'll come to it in a second. These are the injuries I start to think about denervating the wrist. And we did a case like that last week at Soto. Ones that have a slack wrist, but not much else going up. Denervation is an option that more and more people are trying. Low morbidity and faster recovery. Snag wrist is another advanced problem that happens with arthritis. This is a very advanced case where there's now arthritis between the proximal pole and the capitate. First, we get arthritis between the scaphoid and the distal pole. We get hypertrophy. We get osteophytes here. We can end up with getting more arthritis here at this at the scaphocapitate junction, and then eventually pancarpal arthritis. When the problem is just distal, which is what we saw last week, and the proximal articular surface with the proximal pole and the radius is intact, and this has to be okay too. So this is not a case. But when the arthritis is just around the distal pole, when it's a well-established non-union and there's an osteophyte and it's very sclerotic, I just do what's called a Maller procedure where you just excise that distal pole, and that's a procedure with a 20-year follow-up in the literature with good results. So that's a good option for that. So even for, now this patient has, again, advanced collapse. So now here we're going to have to go ahead and do probably some sort of a limb fusion. We could try a denervation and see how that works first. Proximal carpectomy. That's an option when we don't have arthritis here. Some surgeons will do a proximal row here and then put soft tissue between the head of the capitate and the articular surface. So those are the options. We don't do, not many people do total wrist. So this is what I was supposed to talk about, perilunate injuries, Mayfield classification. This is how the energy kind of enters and exits the wrist. What this doesn't show is it has to come in either, it has to start somewhere. It either can kind of start here and come around, it can go through the scaphoid and come around, come up through here. But the energy is coming in tearing the ligaments between the carpal bones and causing a dissociation of the lunate from the rest of the carpus. So there's a possibility for a perilunate where the lunate stays in place and the carpus dislocates, or a lunate dislocation where everything else stays and the lunate is ejected, typically palmarly. There's different ways the energy can come through these planes, through the scaphoid. It can come down through the scaphoid and around the lunate, transscaphoid translunate. It can be pure perilunate. It can be an inferior arc here through a styloid fracture. It can come through the capitate. When it comes through the capitate, this and this can look very similar because it can be a very low capitate fracture. So when you start to see these injuries, try to look at everything else. Get a reduction view and look at it again. Get a CT if you have access to it, because you don't want to miss a capitate fracture, and you don't obviously want to miss a scaphoid fracture as well. My partner's son was in the emergency room with a scaphoid fracture, and they missed the fact that it was a transscaphoid perilunate fracture in the ER of a teaching hospital. He sent me the picture. He's an anesthesiologist. Sent me a picture. He said, "Hey, can you fix Brandon's scaphoid?" I said, "Sure." Make sure they reduce the risk first. He's got a dislocation. So look at the X-rays. Look at that lateral. Make sure you get a good lateral, not just an oblique. There's a high incidence of missing these capitate fractures. There's a high incidence of missing lunate dislocations, right? Complete dislocations of the lunate. They're missed often. They're ejected volarly. If they're seen acutely, sometimes they can be reduced acutely. Difficult to do, but it can be done under fluoro typically. Of course, this is the X-ray. This is the lunate ejected out, looking straight down. Something looks wrong here. We may not know exactly where we are, but if we start to look at things, the normal arcs are completely out of place. We look at the lateral, we see the lunate's out. We want to reduce that. If it's acute, we can reduce it. Reducing and pinning, or some people will put temporary screws across and take these out at 3 months. We want to, there's different configurations of pinning, but we want to basically pin the LT back together, get the scaphoid to the lunate. We want to get something across the lunate to the capitate to prevent that, to extend the scaphoid up and prevent it from flexing down. And then some surgeons will want to either hold the lunate in or even hold across to stabilize from radius into carpus in addition to the lunate. If the injury is not as severe, we may just have a tear of the lunate to the triquetrum, less common. And I think these are often missed and often probably not that problematic for many people. So again, when we're looking for either lunotriquetral instability or scapholunate instability, we want to look at these Galula's arcs and see that they're intact. We shouldn't see overlap of the carpus, right? Here's a subtle shift here, showing some LT problems. We can blot and look. Again, treatment's conservative for LT problems. So is there an operation for a lot of these problems? That's not for everything, but denervation, either a classic or modified denervation of the wrist, and sometimes even just AIN, PIN, can decrease pain. If we have a pretty functional patient who is after had a traumatic injury to their wrist, carpus is aligned, they still have a problem, and denervation is an option before we start to get into fusions. Transscaphoid perilunate fractures, I don't have pictures of those, but that's something that they tend to do well. I showed the X-rays of the pinned perilunate. If we get to it acutely and we can get it reduced and pinned for a long time, at least 8 weeks is what I do with my pins, if not 10 or 12. They end up doing okay. They'll lose some motion. They'll typically have pretty good function, and you don't see those patients back typically once they're recovered. Maybe you'll see them back in 20 or 30 years with some problems, but the long-term outcome is pretty decent. If they have a transscaphoid perilunate, rigid fixation of the scaphoid really does, those patients do very well. Why? Because their scapholunate's intact. What's the hard thing to fix? Scapholunate. So if somebody fractures through here and has a perilunate, we get them reduced quickly, we can pin their LT and fix their scaphoid. And those patients actually tend, the kid I just mentioned, the son of my anesthesiologist friend, he's done very well. He has no symptoms. He has a normal wrist. So if we can get to them acutely and they have a scaphoid fracture, or even a scaphocapitate fracture, and the capitate fracture is big enough to fix and we don't miss it, those patients do well. Perilunates do okay. If they're chronic, take the lunate out, do a carpal tunnel release, because they almost always have carpal tunnel symptoms. Even if we did one last week, we got the lunate out from the top, we still did a carpal tunnel release. I didn't think he had a lot of burning pain, a lot of dysesthesias, and the next morning those were all improved. So I think you want to do a neurolysis, do a carpal tunnel release in that patient too. So these are bad injuries. If they're missed, they're problems, but they're salvages that are reasonable, short of fusion. If they're picked up acutely, they can do pretty well. Questions on wrist instability, perilunates, transscapular perilunates, things like that?
But what we doing for us to do sort of is just reduce it to damaging around.
Yep. Yeah. Yeah.
Rather than going and fixing the ligaments.
No, yeah, right. So if you can reduce it, if you can reduce the perilunate acutely and pin it, do you need to fix the ligaments? I don't know that fixing ligaments makes sense. First of all, you don't have the anchors here anyway. Second of all, when you have the anchors and you're looking at this tissue and you're like, what am I doing? You're putting an anchor and trying to grab this little bit of something. That's even an acute scapholunate, which kind of has the stoutest ligament there is. It's very hard to make that look like it's going to do much. So I think doing that is fine. Reducing and pinning, you want to go, I mean, you talk about diamond pinning, kind of go around the circle. I mean, I think more pins is probably good. Getting things reduced and held and kind of recreating that stability and leaving the pins in. How long do you leave them in for typically?
6 weeks.
6? I would leave them in for 8. Yeah, 3 months, yeah, if you can, yeah. I mean, longer is better. 8, 10, 12 weeks is fine.
Especially the chronic ones.
Oh, yeah. But even the acute ones, I think, especially if when you do your diamond pin, is one of them through? You're not going through the radius, or are you?
Not usually,
Yeah.
unless it's trans.
Right. I mean, I would probably.
We go like that.
Yep. Yeah. So I would say I would be afraid of leaving a radial carpal pin for 3 months, just because even in a cast it might move a little bit. So I'd probably pull that at 8 weeks. But that's not based on anything others, I thought. Do we have are we on to a break, or are they not ready yet? You ready? Tea break. When do you want people back?
20 minutes.
20 minutes? All right. 20 minutes. Thanks, everybody. Started. The next topic is hand and wrist examination. I don't have a presentation for this. You saw some slides, but I didn't really have a good one, and I also think it's kind of nice just to go through it manually as well. So that's what we'll do. We'll try to make it a little bit interactive, so stop me if you have questions. I'll just kind of go through fine-tuned sort of examination things. So, a complex system, hand and wrist. We talked a little bit about the bony anatomy of the wrist. That's pretty complicated as far as the biomechanics and the intrinsic ligaments. There's some things we can do, but it's a lot of localization, I think, in the wrist. History, again, becomes very important. Imaging is important. As far as further down in the hand, we want to think about the soft tissues, the muscles, the tendons, the sensory, and then the motor nerves. If we have penetrating trauma, we want to think about what's upstream and what's happening downstream in ways we can look and determine what's been cut. With the hand, and we of course have a way to read the forearm as well and see what's happening up there with motors, and that being the nerve supply or the muscle or tendon supply. And then of course we've got vascular issues, which are less common, unfortunately, because it's such a redundant system. So for me, with a patient, take a good history, do an exam. When you're taking the history, it's important to examine the patient, see how they're functioning. I think there's a lot of secondary things we can pick up when we walk into a room or a patient walks into our room and we examine them. How they hold the limb, how they treat it. If we know it's a different situation when they come in and it's in something or away from something where it's almost disconnected from them, where it's almost not part of them, that's a whole another spectrum where we start to worry about the way they're dealing with these things emotionally, maybe a trauma or an injury, and as well as potentially some nerve problems, such as complex regional pain syndrome or CRPS or reflex sympathetic dystrophy. Do you see much of that here? Do you see what we call RSD or CRPS? So you think there's a psychological component, or a grittiness, or toughness of patients, or?
I bet you I've seen maybe 3.
Yeah. Yeah. So a lot of discussion about that amongst hand surgeons, especially in the States. So it goes by a lot of different names with CRPS, complex regional pain syndrome. There's a 1 and a 2. It used to be RSD, it used to be causalgia. But basically, usually people think of it as a sympathetic overtone or some sort of a short circuit in the system, the neurologic system. You get dysesthesias, you get allodynia, it hurts when we touch the hand, hair pattern changes, sweating changes. There may be, and probably is, a significant component of psychology, the mind. Not that people intend to not be well, but sometimes their mind kind of takes over, I think, and causes the illness to be worse. So there might be a component of grittiness, and I think Ethiopians are pretty gritty or tough people, and I think that maybe that's part of the reason why you don't see that sort of thing. But when we see someone come in, we want to examine them, see how they hold their hand, display their hand, use their hand, take a history and see what their problems are. Just like with the shoulder, I'll inspect the hand and see what it looks like, and see how it looks compared to the other side. Does the skin look normal? Is it scarred? Is it contracted? Are there obvious sweat pattern changes or hair pattern distribution changes? And then have the patient start to range their wrist and motion. If I'm doing a hand exam, sometimes I will start with the shoulder and have them just reach up both their hands. So if I just show somebody just a bilateral range of motion, forward or overhead elevation, touch their shoulder for full elbow flexion, full elbow extension, tuck in their side, full supination, full pronation, touch the tops of their hands together for full wrist flexion, palms together for full wrist extension, make a full fist, open up, and then if I'm looking more distal, maybe cross the fingers over, thumb up, thumb down, okay? So very quickly I can check the range of motion, and it's interesting how many times you'll pick up something proximal that might even be playing into their problem. Someone comes in with wrist pain, and you ask them to do that, and they can only touch this close. So, or they only supinate to here, and maybe their wrist pain is because they're trying to force supination through their carpus instead of their forearm. So it's helpful to go upstream and look a little bit, and it can take literally 5 seconds to have them just do those exercises. The other thing too that it does, I think it does take the patient their concern level down a little bit, that they're going to maybe grab their hand and start to do things that might be painful. So it's just a way to introduce yourself to the patient, get close, talk to them, and then say, go ahead, and again, bilateral. And so you just checked all that, and you've kind of introduced yourself to them, you've gotten a little closer, and then I'll usually ask them to present me their hand instead of grabbing it. And I've had young doctors with me, and one in particular, he was quite rough. And patients that like that he'd walk up and just kind of, without even introducing what he's going to do, he just would grab them. And so, especially with kids are really important to be a step away and do this, and then approach slowly. And I'll often ask if it's this hand, I'll say, let me look at your normal hand first, and grab that hand and maybe do some things. If I'm going to do a provocative maneuver, I almost always do it on the normal side first. 1, it gives me a sense of what's normal. 2, it gives them a sense of what I'm going to do. And then 3, it just kind of relaxes them. So like an elbow exam, a dynamic valgus test that I do, I always do the other side first, because I don't want to, people are like, what are you doing? They're all tensed up. So I'll have them present the hand, and I might look at it, and then I might even, if I see something, and they have, let's say they have a lot of waste in the other hand, I might ask to see the other hand, and look at that and do a comparison side to side. So now I've got kind of a picture, and depending on what's going on, I've got a history, I've got a picture, I know what the range of motion's like. I might start to focus even pretty quick at that point on my physical examination. If they're coming in with thumb pain, I don't need to test necessarily every flexor in the hand. If they came in with a stab wound or a cut, I need to check every flexor in every finger, or if it's kind of an obscure history. So if someone's got thumb pain, I might start focusing on their thumb as soon as they tell me that's the case. So if I'm talking about the wrist, I want to know where the pain is, and it's helpful. Obviously, the patient's described it, but and you can, sometimes it takes a lot of kind of questioning. Show me exactly where it hurts. Try to use one finger. Try to point. When does it hurt? Where does it hurt? Because usually there's enough subcutaneous structures, you can at least eliminate those. Is it a tendon problem? Is it a tendinitis? Is it a pain with palpation over a certain tendon or motion? Is it a nerve problem? The radiosensory nerve is palpable, and that can be a problem if somebody has trauma or blunt or sharp. So I'm examining the kind of more superficial structures. If their motion is limited, now I'm going to be palpating and thinking about that. I've probably gotten images in my clinic of, if as a new patient, I've gotten at least x-rays. So if they have arthritis, I would know that and be looking or examining that location. For the carpus, I want to point or palpate directly over the intercarpal regions if I can, palpate over the scaphoid. The snuff box is kind of is when we come up with our thumb and extend between the abductors and the EPL. We can push, and that's the snuff box. That is scaphoid traditionally, but it's also STT joint. So when someone's got some pain and I'm trying to determine if it's arthritis at the base of their thumb or their STT, for me, this is more STT, snuff box. Base of the thumb, I'll palpate here. I've already checked range of motion. As I drill down, and maybe I have them pinch thumb to pinky to fire their thin air mass. I can check side to side for integrity of that, firing of that, mass, size, strength. I can try to pull my fingers out and fire that. I can go in an OK sign. The first thing I typically do if I'm doing a generalized exam, even though I'm looking at OK for AIN, right? FPL and FDP to the index, okay? But one of the things I like to do with that is I'll have them pinch hard and palpate the first dorsal interosseous. That's the last thing to be innervated by the ulnar nerve. So if I'm thinking about ulnar nerve, that's an end point I can look at and see, is that firing? I can have them point at me and I can try to push the finger that way and see if their first dorsal interosseous is working. So I can check the muscle, I'm checking the nerve at the same time, check intrinsic function by crossing over, abducting, adducting, and then I've already checked range of motion. Maybe something was funny. When I was a kid, I tore off my finger, my flexor. So when the hand surgeon walked into the room, I was amazed that he knew what it was when he walked in the room because my hand was sitting like this, right? So he walked in and my finger's like this, and he immediately knew I had an FDP rupture in my ring finger because the posture was different. Look at the posture, rest. You can tendice a little bit, right? So these are all things you want to be kind of taking in as you look at the hand. If we're going to do the tendons, FPL, FDPs, the FDPs all are together, right? So when the FDPs, we can fire them, but they all kind of fire together, and that's important as we examine through. FDS fires independently. So we can, if somebody's trained in it, they can fire their FDSs independently. Otherwise, we hold their finger down and they bring it down, right? So here's like a hand nerd thing. So this is FDS, this is FDS. FDP to the index sometimes is independent. So sometimes, like I can come down here, I'm actually using my FDP and my FDS because I'm flexing down here. If someone has a laceration right here, we want to know, should I put Dwayne on the spot? If we want to know if somebody, I won't put that spot. Because this is one of these things I didn't learn until, I think, past fellowship, and fellowship. Okay, FDS, some people don't have it to the small finger. And I had it in both, and one spontaneously ruptured in the last year. I cannot bend that down. Painlessly, spontaneously ruptured. I have an FDP. I no longer have an FDS to my small, just ruptured. When we look at it surgically, it's very small. So, not an important tendon. But, okay, so we have a laceration here. I come into the see Dwayne, and I have a laceration here. He touches my fingers, he checks sensation, which we'll talk about in a second, and it feels normal. And he says to me, okay, and he's really worried, he checks, he says, go like that. Okay, FDS is okay to my small, I go like that, FDS is okay, FDS, yeah. And he goes like this, and he says, I think your FDS is okay, but he knows that I might be using my FDP. And he goes like this, and then my FDP works, and my FDP works, and my FDP works, and my FDP works. How does he isolate this? Well, when we isolate FDS to any other finger, we can go like this. And what we're doing is we're pulling the FDPs out. And now I can't fire my FDP. Do this to yourself. Take your fingers, come like this, and bend your pointer, your long finger down, not pointer, sorry, your long middle finger down. You'll feel you're pulling. You can't use your FDPs anymore. And then here, Sammy, bend it down. Bend it down. Do that. Bend it down. Bend this down. Hold that back and bend down. You didn't have to yes there? Bend that down. You hurt yourself? Bend that down. Can't you do that? Do that. Bend it down. Bend it, hold it down. Yeah. Look. Feel. Just go like this. Abscess finger. See? These FDS is out. So when you do that, your FDS is floppy because your FDP is held out. All your FDPs are pulled out. So how do you independently check this if FDP is possibly doing the work? So again, this is like a hand nerd thing. Go into that OK sign and pull it down like this. So the FDS is hyperexciting the DIP. You can't do that if you don't have an FDS. Because you'd be using your FDP, which would be forcing you to go like that. Yeah, that's like a really minutia thing. But the point is, flexors, FDS is independent. You check it by holding out your FDPs. FDPs work together, but you can check them and you can check to make sure that they all work that way. FPL, right? EPL, digital extensors. Digital extensors are all blocked, they're all together, right? The EDC is combined. That's why if we put our hand flat, do this now, put your hand flat, bend all your fingers and leave your long finger out, try to keep your phalanx flat on the table, right? Flat on the table, push down, and now try to lift that finger up. No, Sam, so you gotta lift this finger up. You can't. Lift that finger up. You can't because your EDC's been pulled out to length. And you can't, your EDC is, so there's a relative, and that's this whole quadriga effect in the hand. No, hang on a second. Yep. You're cheating. Hang on. Now do it. There you go, see? You're still cheating. You can't, there you go. So there's that, but this is important. This is important when you, maybe at a test you read about a quadriga effect. That's when, and it has to do with the Roman centurions driving the chariot and the reins all the horses. But the idea is that, and we had a patient in clinic where we talked about this a little bit. So he had a traumatic injury to his index finger, and he had really poor flexion of his PIP, and no flexion of his DIP. Was very deformed. So when he went to make a fist, his index stuck out like this. So here's something else. So turn to your neighbor if you want. So go ahead, let me have a finger. So squeeze as hard as you can. Can you squeeze hard? No. Take your finger and squeeze as hard as you can, but hold one finger out. Or go to your neighbor and grab their wrist and squeeze as hard as you can, and then hold one finger back and squeeze. You can't generate the force. Why? It's quadriga. You're holding your FDP and your FDS. FDP is more important. You're holding your FDP out, and it can't pull because this is out. And this is why, well, multiple reasons why. If tomorrow I wake up and this finger has been very damaged, so tomorrow I wake up, or maybe 6 weeks from now I wake up, I've been in an accident, and despite really good care, this finger is very scarred, and it doesn't move very much. Let's say it's normal otherwise, it has very good sensation, but it's stuck out like this. My grip power is dramatically decreased, right? And I can't even use that. I can't even reach it. So, and I've talked to plenty of patients, I know amputation here, especially of the hand, seems to be pretty down on the list of what people want to do. But I can tell you, for me personally, if I wake up 6 weeks after I was in a road traffic accident and I have my finger out like this, I'm going to turn to the hand surgeon who's taking care of me and say, okay, let's get this off as soon as possible. I want to get back to work. Functionally, I can lose, especially an index, very quickly and get normal function back, because I immediately transfer to the long, and I get my grip back. Maybe not normal because I've lost a finger. A lot of the grip comes from the ulnar side anyway, but that quadriga effect of holding that finger out and losing that grip. So when we see a patient who's got poor function of their hand, we want to think about looking at the relative motion of the tendons and how that affects strength. And maybe we can do something to reconstruct that. And this guy, we did do a release of his PIP, and he got on the table, he was flexing here. So he's going to get better strength. The finger still, it's numb, it's not a good finger. I actually recommended amputation through his PIP, he didn't want to do that. But there's a paper called Why I Hate the Index Finger by a plastic surgeon, and what he meant is, when he takes care of it, even if he does a really elegant operation, a lot of times the patients, as soon as they're recovering, they bypass it. They start using their hand, and then get stiff despite a good operation. And now they have this stiff finger they never use, and he's like, I wish I would have never even operated on it. They'd probably be better off without it. So stiffness definitely plays into strength, of course, motion. And then the ability to kind of check the hand on an examination, looking at where the stiffness is coming from is important. So there's a difference between intrinsic and extrinsic problems, right? So if I come into the office and I say, I can't bend this finger, it can be a lot of things that's wrong with it. It could be an intrinsic problem. I'm stiff in these joints. Something happened, I'm stiff, and as hard as I try, I can't bend it. It could be that my flexors were cut, and I can't bend it. And you walk up, and or I even say to you, the only thing I can do is or you ask me to bend it, and I go like this on exam. You say go like this, and you watch, and I cross my fingers over, and I curl it down like this. I trap it, and I bring it down. And you say, no, put your hand out. Now bend your fingers like this, and I do it again. I go like this. No, bend your fingers and don't bring them together. And I'm like this. Well, okay, now there's a motor problem here, right? I don't have a motor. I showed you I have good passive motion. You're going to examine it too and say, okay, he's got motion, but he's got no motor. So now I know he's got a motor problem. Is it? And if it's probably going to be tendon, right? But it could be nerve, I suppose. Not likely, or I can't see how it'd be nerve if the other ones are flexing, because the FDP is a common muscle belly, right? So you have to think about how the motors work, how the motors are innervated, at what point they're innervated, and then how the tendons go. And you can typically, by looking at just the hand, you can figure out where the problem is. So extrinsic, it's a problem in something outside. It's a tendon problem, it's a motor problem. Or intrinsic is a joint problem. There's another extrinsic problem I could have too if I said, listen, I can't bend down, and you look and you say, oh, he must have a flexor tendon problem. You look a little more closely and you bring it back maybe, and you really put tension on the tendon, and sure enough I can fire it a little bit. Or maybe even you put the wrist back and I can bend it a little bit, but down here I can't. So I'm like, no, I can't bend it. And you push it back like this, and I'm bending it like this. That's another extrinsic problem. The extensor tendon is trapped. So somewhere along the way, there's maybe some scar tissue. It's a tether, right? Motor works, muscles work, flexors work, joints maybe even, they probably won't be supple if I haven't been bending it, but maybe it happened not that long ago. And again, as you take tension off the extensor's tight, so you try to, maybe it's tight up here, you get as much tension off as you can. You can see I actually have some motion of my IPs. So it's not intrinsic there, it's extrinsic. It's a scarring of the extensor tendon. And the flip thing can happen too, right? So I can't bend because my extensor's stuck. Well, maybe I can't extend because my flexor's stuck. So we have to think about that system and where the problem is. Other things that kind of go in that path. We all know what a trigger. Do you guys see trigger fingers? I don't think I've seen a trigger finger, but and so a patient comes in, especially if they're locked and they're triggering. But sometimes they say, "Oh, I'm triggering my," and I've been fooled by this on both of these cases, both of these examples. So there's two ways to get fooled on a trigger finger. So a patient comes in and says, "Okay, when I bend, it gets stuck, it's locked. You push on them, it hurts. You pull on it, you feel a pulp, you feel a pop. That's a trigger finger. You give them an injection to get better. That's a trigger finger. That's easy, right?" So I had one patient who, I think he had surgery or trauma here, and he'd say, "Okay, look, I come like this, I straighten, and then I go to bend, and my finger, and it locks, and I gotta pop it through." And it's kind of weird because it's an extension and he's popping, but he's showing it very, very, very consistently, showing me he's popping. He's here and he's popping. Now what I didn't notice is he's hyperextending here. And he's scarred in on his palm. I forget why. He can't straighten his fingers all the way out. As a matter of fact, he's tight enough that when he goes to put his hand on the table, he can't lay it flat. It wasn't Dupuytren's, but it was post-trauma. So he's like this. That's as extended as he can get. But like most of us, we try to be normal, so he's extending his fingers as much as he can through his IPs. He's hyperlax. He's going into a swan neck. And he's hyperextending here to the point where as he bends, the lateral bands are snapping down. So his locked joint is a swan neck. But he comes in with, and I think maybe I took care of him because I'm focused here. I'm like, oh, he's got scar tissue from his trauma. He's got a trigger finger. I need to release here so he can move. I'm pretty sure I operated on him, and he didn't get better until I figured it out. So that's one. That, again, it's examining and looking, and not also like everything else in orthopedics. Don't be fooled by what you think is number one. Have it, common things are common, but other things happen. The other way to get fooled on a trigger finger, similar story, patient will come in and say, well, when my fingers are straight and I bend them, it snaps. That's painful, I don't like it. Well, you have a trigger finger. And if you're busy, Samson spent one morning with me in clinic. Yeah, it's busy and running around. And so if you don't pay attention or you're distracted, you say, oh, give me an injection, and your nurse who's going to help you, you get the injection, it won't get any better. What's happening to that patient? Again, if you would do a good exam, you pick it up. If you do a really good exam, you say straight because of attenuation, or my mom just had a osteophyte tear her sagittal band so that she had a luxation. So that's what she was doing. She presented to me with this very problem. So that when they flex, the central band slides over, and then when they come up, it's in the gully. They can't come straight. And then they hold it up and it stays, and they bend and it snaps, and it comes like that. So again, these subtle little things in the hand, looking at the tendons and knowing what's normal, looking at other ones, that's the most important thing for the tendons. I mentioned sensation. When we look at the patient, we look at sweating patterns. If someone's had a cut and the digital nerves cut, the sweating pattern can be different. The way it looks atrophic. It'll look a little different. And then of course we can do light touch sensation or 2-point discrimination. Take a paper clip and bend it so it's about 5 millimeters apart and see how the static 2-point discrimination is. And that's a good way to at least get a rough estimate of what people's sensation is like in their digits. Let's see what else. Mallet fingers, I'm sure you know what mallet fingers are. We see the finger drop down. Same sort of thing. We can always look. There's not really a reason to have an extensor lag, but is this a flexible will lag down and go into our lateral bands will pull too hard and we go into a boutonniere, right? So with both of these problems, you want to see if it's flexible or not. You want to splint in the opposite direction if it's acute. And then if it's chronic, you try to get it flexible. There's some tendon releases that can help that I won't go into. Let's see, wrist, hand. I think that's a lot of what I wanted to go through.
Veins, based on that.
Okay, so Dwayne's asked about Descartes veins, which interestingly, I don't see a ton of wrist and hand anymore. I rarely see it anymore. But Descartes veins, and I'll talk about something related to that, which is second dorsal wrist compartment tenosynovitis. You will see, and sometimes even in younger people, Descartes veins, you can see it in new moms because they're nursing or bottle feeding a lot and holding the baby's head this way, or dads sometimes too if they're bottling. But that position, that kind of head holding position like this, a lot of stress on the first dorsal wrist compartment, extensor pollicis brevis, abductor pollicis longus, and it's a tendonitis right here. Sometimes overuse will happen too. Sometimes this is chronic. A cortisone injection usually will resolve it. It doesn't typically snap like a trigger. Sometimes there's a little, you can palpate a painful little cyst off of the sheath, and an injection of cortisone into that usually works pretty well. Make sure you're deep. Make sure you aspirate before you inject because there's the veins there. Do you see depigmentation of the skin frequently in people with cortisone? Do you give much cortisone around the hand or wrist?
I've seen 2 patients with depigmentation.
Yeah.
But it improved a lot.
It can improve. I tend to tell patients it's permanent because it takes a long time to improve. It may not be normal, and the skin can get kind of thin. And obviously in darker skinned people, it's more obvious. So if you're going to give an injection for cortisone, you want it to be, or for Descartes, you want it to be deep, and you want to let the patient know they may have depigmentation. And I've had some patients. I had a patient. She's actually Haitian. She's like, nope, don't want it. It was enough of a concern for her. She didn't want the risk of it. So I would let people know, and that way no one will be mad at you. Second dorsal wrist tenosynovitis is interesting. It's much more uncommon, and it's when I've seen it, it's somebody who's younger, like in their 30s. And I remember a friend was making chili all weekend, stirring a big pot. So, or someone else was helping somebody roof or tear tile up. But people who maybe don't have a job that's real manual, who 1 or 2 days do a lot of things that are real manual, and it's kind of, there's something called a wet leather sign, which feels kind of like 2 pieces of wet leather sliding against each other. You put, and they'll even tell you about it sometimes. You put your hand right there and they go up and down, and it's the second dorsal wrist compartment, so it's the wrist extensors, and you feel this almost squeaking. It's really pretty interesting, and it's very painful. Usually rest will help, cortisone, and very, very rarely a release. That is probably, there's some people think that's the same or the same as intersection syndrome. There's a discussion whether that exists or not, intersection syndrome. The second and first dorsal wrist compartments where they crisscross, rubbing against each other up here. And there's a paper written quite a while ago where the surgeon said, yeah, the pain's here, but the problem's really here. They all need a second dorsal wrist release. The few times I'll do a release for intersection, I actually kind of do both. And I have seen, I have one patient, his tendons were worn down, were frayed. And they looked like someone took sandpaper or a rock and had rubbed them raw. So that's a real problem, just not as common. We didn't talk about the wrist flexors and extensors really. You can check those by palpation. Certainly the wrist flexors. People can do okay. We use the wrist flexors for donors. And so wrist flexors are, I wouldn't say they're expendable, but if you have a patient with an isolated FCR, tendon laceration, you don't have to fix it. You can see spontaneous ruptures in people who are a bit older. You don't see a lot of inflammatory arthritis here, but there is a condition where someone comes in with this, well, 2 conditions. One, spontaneous rupture, loss of flexion of the thumb, all right? And that's usually from a spur off the scaphoid. It's called a Mannerfeld lesion. That's more common in like rheumatoid patients, but it could be could be from someone who's arthritic. What about patient comes in, and maybe you've been treating them too, distal radius fracture, not necessarily a bad one, you've splinted it for a while, they were doing okay, they come in, I don't know, 8 weeks later, maybe some pain, and they say, I can't put my thumb up. What happened? What? EPL rupture. Is it because somebody did something wrong?
No, it's wrong.
No, it just happens, right? It's probably maybe it could be a rough edge of the bone, could be attritional from blood and scarring in the third dorsal wrist compartment, and there's usually a little bit of a prodrome where they have some pain, but just pop, it's gone. And in the States, people are really mad when that happens. You said I had a wrist break and it was going to be okay. It's often, it's typically the non-operative ones. So what do you do for an EPL rupture? You have the patient, should we fix it or pin it or fuse it or do a tendon transfer? Any thoughts? It's an attritional rupture, so getting it to fit is not going to be good. And the EIP is an awesome donor because it's synchronous, it's long, and this is a great Willant case. You make a small incision here, find the donor, pull it out here, and weave it into the EPL while they're awake. They make sure it's good tension, split them. They do really well. Let's see. Okay. Any other questions?
Basal thumb arthritis.
Oh, basal thumb arthritis. Do you see that here? Yeah. So very, common in the States for sure. Women more than men here as well. Is it? Yeah. So probably because of morphology and ligamentous laxity, women more than men. Basal joint arthritis, so double saddle joint. It's got a curvature this way and a curvature this way, so it can go side to side and up and down. And as things kind of break down, you have pain, subluxation. A lot of times adduction, and it gets stuck, and then when people get adducted, what do? They hyperextend at the MP, and then as they hyperextend the MP, it drives that force kind of down and back, and this will actually start to stick out even further here. They get that kind of collapsed, real difficult thumb. When it's mild, they're painful. They'll be painful here. They'll often point here. It hurts here, but if you palpate right at the base here, you'll feel it. Like I said, that's basal joint. That's STT. So they should be distinct enough you can palpate. Somebody can hurt at both of them, but you should kind of check both. When someone's just started, activity modification is helpful, anti-inflammatories. Cortisone's fine, but cortisone and lidocaine, it is countertoxic. So if someone's got a decent looking joint on their X-ray, I tend to not start that, because I think once you start injecting, you're probably accelerating the condition a little bit. And then as far as treatment goes, bracing can help. If you're thinking about surgery, I've started to do more denervations of this joint. And that's, I've actually talked to Sean about that, because he's got bad basal joint. But, so that's a pretty simple operation with pretty decent results. Otherwise, reconstructions are good, but not great, in the sense that if it's somebody young, somebody like take me for example, at 56, if I were to get a basal joint reconstruction by probably anybody anywhere, perfect, it's gonna be a long time before I'm in the OR gripping again, heavy, probably 5 months, and I'm probably gonna not feel like my strength is what I want for using a Ranger or twisting wire or something like that. So it's a good operation, reconstructions, but we have to describe to the patients that we have to be realistic in our expectation for them. And then if there's real bad collapse, we fuse the MP joint at the same time when we reconstruct here. Those patients are happy because their thumb's out of their palm and it's functional. We didn't talk about carpal tunnel syndrome, compression of the median nerve, compression of the ulnar nerve. Hopefully that's pretty straightforward for you guys. Yeah, I think that's good. Thanks.
So we can get home to our families. This is my mentor of the shoulder. I think if he wasn't as good a mentor as he was, I would not have a clue as to how to handle chronic shoulder dislocation. So I owe a lot to this guy. If you look at the history of this, 1911, they describe a procedure that takes the subscap down, and pathology was described but not treatment. In 1935, there were 15 cases where they just casted the person up here and had poor results. In 48, Advisor, very famous surgeon for lots of reasons, put a screw across the joint, kept it reduced, of course, got stiff. Rowe treated in 82, neglect, head resection, open reduction, hemiarthroplasty, with variable results. And over the last 20 years, many methods have been described with varied results, total shoulders, hemiarthroplasties, etc. One thing I do want to emphasize is that a Chinese guy put a paper together using the ladder J, and it did 50% redislocation rate. So ladder J for chronic shoulder dislocation doesn't work. Okay, so this is your first chronic shoulder dislocation. Unfortunately, he's been out not for 5 weeks, 15 months. You never faced this before. Up till this point in your career, you've read little about it. How do you plan for this? Where's the anatomy? You know there's important nerves around the shoulder, especially the axillary nerve. Where is it? Basically, where is everything? Okay? So, this is the plastic model we have in our clinic. Basically, that's where the shoulder sits. And you know the anatomy is screwed up, but how do you know where things are? What's your approach? How extensive? Do you take the subscap down either with just the soft tissue, or do you osteotomize it? It seems intuitive that you do an osteotomy because it'd be a stronger repair, but maybe that's wrong. Where is the axillary nerve, and how can I avoid injuring it? Okay, so here's the normal insight to anatomy. You can see, here's the coracoid, and everything, all the important structures are just medial to that. Okay? When you dislocate it, all the stuff is right here. Everything that's important is right next to your head. Okay, so that makes me really nervous. I hope it makes you nervous as well. Okay, so let's look at the anterior anatomy and the things that we're going to do.
we'll show later that we go right down through the white. Again, if you're going through red, you're in the wrong area. You either got to go up or down. You want to go through white down to bone. Okay? These little, why doesn't this work? Okay, what's here? Yeah, you remember the Navy goes under the bridge and the Army goes over? Army goes across the bridge, the Navy goes under the bridge. It's pretty cool, isn't it? God has a sense of humor, I think. And here's your all-important subscap. Huge insertion, okay? So your head's sitting down here. You know your subscap insertion is here, and it's like everything's cramped together, okay? You know, again, your supraspinatus is here, but now it's wrapped down here. Everything is just totally out of whack. And you know that your head's sitting down here close to the axillary nerve. It's like, how can I do this safely? How can I do this operation, get it where it's back and not cause permanent, really terrible damage? It's difficult. Everything's close, everything's important. Okay, so here's the steps that we put together. Take down the anterior deltoid, just open the door wide, okay? Osteotomize the coracoid so you can pull the musculocutaneous nerve along with the muscles, etc. Get it out of the way, open the inner door, so to speak. Take down the subscap off of bone, don't take it with the bone. Mobilize the soft tissues around the base of the coracoid. The base of the coracoid is home. Okay, if you're at the base of the coracoid, you can then determine where everything should be and where you want it to be. Okay, so the base of the coracoid separates the subscap from the supraspinatus. Okay, that's where you need to start. That's where you need to be thinking. This is here, this is there. And so you want to basically make the base of the coracoid naked. You want to just release everything from the base of the coracoid. And so you're mobilizing both the superior subscap and the anterior part of the supraspinatus. You mobilize the head away from adjacent scar tissue, and then you do a circumferential release of the glenoid. And mobilize the cuff at least a centimeter back carefully without injuring the suprascapular nerve. Mobilize the interval between the posterior cuff and the posterior deltoid. It's like everything is attached to everything. Okay, you can't just assume that head is, once you release it from the capsule, it's still adhered. The inner layers of muscle is attached to the outer layer of muscle. There's adhesions there as well. You need to release the undersurface of the acromion from the posterior part of the acromion so that the anterior translation of the deltoid that's now scarred into place anteriorly, it's preventing you from pushing the head back. You need to mobilize the subscap as far medially as you can. And then underneath the head, you're going to see this many times you're going to see this glenoid that's organized heterotopic ossification. You excise that because it's going to be just like a rubbing over the subscap once you reattach it. Then you stretch the posterior and superior cuff by pulling on the shaft laterally as hard as you can. It's short. Everything is short. And then you see where the head sits without reattaching the subscap. Pin the head anatomically if you have any question about whether it's going to stay where you put it. Repair the subscap, coracoid, and deltoid. So you go back, keep closing those doors sequentially on your way out. Okay? So I learned this early on when I tried to do this just through a standard deltopectoral interval. You're pulling that thing hard. and you're doing it for a couple of hours, and at the end of the operation, you look at it and say, that doesn't contract anymore. Okay? So basically, you take that anterior deltoid down, so it's just laying there off by itself, it's just comfortable, it's taking a nap while you work, okay? It's no longer a problem. Then the coracoid osteotomy gives you the second door to get down to where the business really is. It relaxes the musculocutaneous nerve. It gets the muscles that are attached to the coracoid. Can't think of them right now, but the short biceps and the coracobrachialis out of the way. It's calling me. Okay, the head is fixed immediately below the coracoid base. Again, the coracoid base is home. So basically, open the second door so you can really see what you need to see. Relax the important structures adjacent to it. Okay, pre-drill the coracoid and then osteotomize it and then pull immediately. Okay, take the subscap down. Okay, again, the anatomy is going to be distorted. You can feel the bicipital groove. Take it up, away, up towards the base of the coracoid. Take it all the way down. You don't have to take it all the way down to its inferior edge, but take most of it down. Peel it off. Early on, I did osteotomies, and I recognized it's softened the head. The head's already soft because it hasn't been articulating with the glenoid. So the softer it is, the more risk you have of the coracoid of your head crushing when you re-reduce it. So take it down. My advice is just to take it down with a soft tissue technique. The supraspinatus you can easily injure if you don't recognize it's wrapped around the base of the coracoid. It's coming down. Remember, the humeral head comes anterior and inferior, so it's like the supraspinatus is going like this, and then it goes right around the base of the coracoid. Okay, so your superior coracoid, you have the supraspinatus under all this tension. Be careful as you go around the superior surface of the base of the coracoid that you don't amputate it. You go up too hard and too vigorously, you're going to just amputate the supraspinatus muscle. The supraspinatus muscle is your friend. It's not your enemy, right? Know where it is and protect it. It's wrapped around. Okay, basically, it's a scar ball. Okay, so that's why you need to know where the base of the coracoid is. Stick to the base of the coracoid. You get confused, recognize everything is distorted and everything is one ball of twine. Okay, recognize that your glenoid, as Dr. Rick shared with us yesterday, it's diminished in size. Okay, so the next step is to release the labrum. It's difficult to separate the capsule and the labrum in a chronic dislocation. I just go basically around the edge of the articular surface here. Don't worry about the labrum. Just peel it off with the capsule, and you have to go all the way circumferentially. You have to go all the way down to the bottom. And of course, as you get closer to the bottom, the more you need to worry about the axillary nerve. The more you go over the top, your suprascapular nerve is up there. Suprascapular nerve is 1.5 centimeters maybe, and then it's really pinched as it goes around the base of the spine of the acromion. Okay, here's a cadaver and a real patient. Take the deltoid down, pre-drill, osteotomize, reflect it, take it down, cut the long head of the biceps, it just gets in the way, and tenodese it at the end of the operation. Frequently it's just tenodesed itself, you don't have to do anything. Do a circumferential capsulotomy, So the first step is to go in this area, go inferior along the neck, and as you get close to the bottom part, so that'd be the 6 o'clock position on a clock, then switch to the glenoid. If you go too much further, you got to be careful you don't cut the nerve. Cut the anterior capsule off the neck, and then as you get closer, start cutting off the glenoid. Cut the inferior capsule directly off the bone. Immediately beyond that capsule is the insertion of the triceps. Okay, you can take that down if you have to gain more traction on the arm and more mobility. Then you go posterior. Go between the deltoid and the posterior and the external rotators. Mobilize that interval. And then you get your cob in here behind the posterior glenoid. And again, be careful of the base of the spine of the scapula, that you don't amputate that. But you basically want to go around, circumferentially around, so you're mobilizing that periarticular scar tissue, mobilizing your rotator cuff. Okay, remember, the glenoid goes anterior. You can't go like straight in, you gotta go around the corner. All right, scapular nerve is right there. All right, that's the real operation. This is anterior, that's the deltoid. Here's your circumferential dissection. In this case, it looks like I left the labrum on. Make sure that your dissection is completely circumferential. You'll pull on it and you can feel, when you get to that point where you've gone circumferential, you can easily feel the axillary nerve. Okay? The axillary nerve is inferior. It's going to be anterior to the subscap. It's going to be following the anterior part of the body of the scapula. It's going to come around and then it's going to follow the neck, in between the neck of the glenoid and the neck of the humeral head. Mobilize the whole cuff. Okay, so you need to mobilize the subscap. So your head is sitting here, your HO is here. You have to worry about the suprascapular nerve here. Carefully come here, gently come up across here, mobilize this whole, try to get your cob all the way back to here, so that when you pull on that subscap, it actually moves. You don't want a tenodesis. You want a mobile muscle, right? So again, your nerve is coming across here. Axillary nerve is coming down through here. But if you stay on the bone, you're okay, unless you go around here and you just lever across, okay? The subscap needs to move. So here's your anterior surface, posterior surface. I'm going to go all the way around here, mobilizing your complete rotator cuff. Mobilize posteriorly again. Recognize you've got to go around the corner here. Here's where your suprascapular nerve comes around and then divides. Here's your suprascapular nerve underneath the bridge and then around the corner here. Create a space between posteriorly. Then the next important thing to do is actually manually stretch the posterior cuff. I put my one hand on the proximal part of the humerus, my other hand on the elbow, and pull the whole shaft laterally. Don't just go out like this. Put one hand here, and pull the whole humerus laterally with a sustained pull, so you're stretching the posterior soft tissues. Okay, if there's any tendency after you get the head in place for it to sublux, pin it. Ladder J, I tried it once, it just totally frustrated me.
It's impossible when you totally detach it to use it in a way a ladder J is supposed to be used. Again, repair it on the way out. Okay, this patient had a anterior dislocation for 12 months. Here he is 12 months after dislocation. Shoulder score of 100. Completely symmetric motion of this big scar. So I used to kind of make the decision on the table whether I pinned it. If I were to have one recommendation is, it's terrible on your post-operative x-ray to see a subluxation of the shoulder. Because you know it's probably going to stay that way. So my advice would be, if there's any doubt, pin it. Pin it anatomically before you repair the subscat, before you repair the coracoid. Pin it. Pin it anatomically. Leave the pin outside, but bend it so it doesn't go in the body and into the heart. And then pull it at a week. I think if it sits there for a week, it finally says, you know what, this isn't so bad after all. It's just getting over that initial soft tissue memory and contracture. Maybe you could do it less, but it's terrible to see a subluxation on a post-operative x-ray. It's equally discouraging or more when you see a collapsed head. Okay, because you've not really helped the patient if the head collapses. Any questions?
The way you do this, the intervals you go through, you're very protective of the nerves. So when you're deep on the subscat, you're fine. I've seen you all the medial, that's fine. But when I worked with you, I haven't really noticed I guess I didn't pay enough attention when you were releasing the subscat from the coracobrachialis and whatnot. That makes sense. But the nerves coming off the plexus on that side for the subscat. Do you have recommendations on how to avoid damaging the upper or lower subscat nerves to the subscat in that interval between the plexus, the coracoid, and the outer surface of the subscat? You just not go very medial, or what do you do there?
Not sure I understand the question again.
How do you not denervate the subscat when you release it on its outer surface?
Oh, I just gently mobilize it with my finger. It's the deep surface that needs
mobilization. The deep surface you can be as aggressive as you want.
Basically, there isn't a whole lot of scar past the brachial plexus and the artery.
Yeah.
You just gently finger dissect it, and I think it's the undersurface that's really scarred.
Do you pull the subscat? Do you pull the subscat and the strap musculature apart from each other and do any dissection intentionally between the two, or is that mostly finger dissection?
Finger. Yeah. Yeah, I've never been real excited about playing around with the brachial plexus. The thing is I've always been really careful about the axillary nerve, and I know if I stay underneath it and I don't go around the neck of the glenoid, and if I don't go too far down the neck and I've never injured the axillary nerve with this operation that I know of. Any questions?
How shall we release the subscat? So is there any specific way of detaching it from the insertion? From the insertion, yeah.
Yeah, you just take electrocautery. And basically, in chronic dislocations, I just go right down the bicipital groove. Look at the anatomy preoperatively of its footprint on the lesser tuberosity. Just peel it back. You know, this is another thing that Ed Craig taught me, and that is the rotator interval. The rotator interval is the coracoid, okay? It's just capsular tissue that separates the subscap from the supraspinatus. Now that's totally filled in with scar, but that's an internervous muscular interval. Basically, you want to follow that. You have to fix it in your mind that below the base of the coracoid is the subscap. Superior to it in the normal anatomy is the supraspinatus. Okay, in its anatomic position, if you draw a line from the base of the coracoid to the bicipital groove, that's your rotator interval, right? So when you translate the head down, you just have to kind of make an arc rather than a straight line, or you have to redraw it. So you know that your supraspinatus is down as well as your subscap. So it's not so much horizontal, it's almost a little bit more vertical. Your dissection.
So do we have to drill a hole during the when you secure it back?
I just put it through with a heavy needle. Or have a stronger resident do it.
So my question is, you said lethargy doesn't help in those chronic cases. So after releasing all the soft tissues and reducing the shoulder, you mean you are selective in doing the lethargy, or even if they have bone loss, you don't consider putting any bone support? I didn't understand, because if they have significant glenoid loss, even if we release all those scars circumferentially, I feel it will be unstable if we reduce it unless we support it with.
I think there's a couple ways to look at that. And if you do a glenoid graft, which I think is the really only thing other than using the distal clavicle, which you could. I mean, the distal clavicle would be in your dissection. And I think that that's probably something we should think about strongly.
Just don't release the CC ligaments when you go around the coracoid.
Yeah.
Make sure you don't release the CC ligaments, because then if you take the distal clavicle.
I think, you know what, that's a brilliant question. Because we've always been thinking, I don't want to use a tricortical graft because it's non-articular. And the evidence out there from my reading of the literature a few years ago is that it's clear that you get degenerative arthritis if you do that. Long term, is that right? If I remember correctly. That's my recollection, is that a glenoid autograft from the iliac crest will eventually lead to arthritis. So I think it makes sense, as long as you're doing this big approach. I mean, you can get by without your distal clavicle. We cut it out all the time, at least in the US we do. Is just take that, preserve the conoid and trapezoid ligaments, use that as your, I think that that's the next study for this. Use the distal clavicle. Because you got everything there. That is a really, really novel and intuitive idea. I think that's great.
But you don't do the lateral J because it's not articular, and it's going to be on top of the subscap and pull it
The subscap is unhappy. Don't split it. I mean, you're just tearing the subscap apart, and you know you're not going to start moving it. With the lateral J as it's described, you can start moving it right away. You can't do it with this operation. Or you're going to just totally make it, you're just going to rip it off, in my opinion. It does not work. Do not do a lateral J with this procedure. So I think that what you're suggesting is a really great idea, that I'd never ever thought of it until you suggested it. But it may preclude putting a pin in the joint. Just that added additional bone on the anterior inferior glenoid. I think that's a fantastic idea. What do you guys think? I think we should start doing it.
One more. So, did you select the patients when you are doing this open reduction for neglected shoulder? Example, the dental patients with this neglected dislocation, there are some range of motion, even in dislocated position. So, sometimes after reducing this neglected shoulder, the head will collapse, as you said before. So, you consider going for reduction for all patients, or you neglect?
Could you hear it?
You just say that since there is some motion with the chronic, and since there is some risk to reduction or collapse, do you ever just leave them where they are, right?
Yeah.
When do you decide to say, when do you ever say, your motion's pretty good, your function's okay, there's a risk of collapse, let's not do anything? I think that is a
Patient selection.
I think, I think that that's an option for patients. I think if you follow this protocol, you don't osteotomize the lesser tuberosity, you pull as much as you can. I don't think that your collapse rate is going to be that high. Now, we've had some recent collapses, but after I've talked to the people who've done it, it's like they've forgotten they got to release the posterior capsule. I mean, the posterior, the external rotators. All right? Yeah, so you have to, I think this is becoming a less frequent operation in our hospital. I think you have to review a PowerPoint, your PowerPoints with the file sharing group.
Oh, sure. Yeah.
And I will share this one as well. So I would just over-prepare. And remember, you've got to stretch the posterior cuff up. Because if you don't, my first one I did of these was in Cameroon, probably in the late 90s. And when I got it reduced, it was out here. And I said, no problem, no problem. Like Greg said, an orthopedic surgeon in the United States used to be as strong as an ox and half as smart, or something like that.
As smart as an ox, strong as an ox and half as smart.
Yeah. So I said, I can do that right in the head clasped. There's just too much inelasticity of that thing, and the weak point is the head. You know, the glenoid is more cortical bone, and the head is more cancellous bone. It's the weak point. I mean, that posterior cuff has been short for as long as it's been dislocated. It doesn't want to stretch out, and it goes, it would rather have the head collapse, and the head doesn't have much resistance, so that's what happens. So you can't shortcut this. Now the only, that being said, if you have a dislocation that's 2 weeks old, I think you can get it reduced closed. If it's 3 weeks out, I'm not even sure I would try. I think between 3 and 6, you can just do a standard deltopectoral incision. I think that you can avoid a coracoid osteotomy, just take your subscap down and just, has that been your experience, Samson? If it's 3 to 6 weeks, you don't need to go posterior. Yeah, they usually just manually stretch the posterior cuff out, and you should be able to reduce it without a problem.
Is there any cases that you stop not to do, like, for example, if patient comes after a year of dislocation? What is your time interval to do the surgery or not, especially in young patients?
I know I've done them out to 18 months. Samson, what's your longest?
6 months.
I think you look at the bone quality, you look at the person, you look at their level of function, and you just do the best you can. Make your best decision, do your best deep dissection, best mobilization. The other thing that I just briefly mentioned is, you know, after you think you're done, then just stick your hand around when you're pulling, and frequently you get this inferior band that is really restrictive. And of course you have to worry about the axillary nerve, but I think taking down, just staying right on the inferior part of the glenoid neck and resecting that scar that seems to be kind of with the triceps seems to be helpful. And you want as much laxity as you can. You kind of want a multi-directional instability shoulder.
Before we conclude, I just was looking at my phone, and so this is the WhatsApp group that I think I mentioned called Cubitus Mundi. It's pretty cool. It's got its benefits. It's got its, it's a lot of information. You have to take it sometimes in smaller pieces. But this is a group of now over 1,000 elbow surgeons across the world, and there's plenty of people in resource limited environments like Ethiopia. And you can share cases. Sometimes you'll get really good advice. Sometimes, honestly, I think the advice isn't maybe exactly what I would say, but that's fine. But there's some really good information. I've learned a lot from it. I just saw that the group's at 1,000 members, and apparently WhatsApp limits the group to 1,025. So if you're all interested, let's just take it over the limit right now. Just log in and become a member. And yeah, so then that way. But if you can always reach out to me or Dwayne. Sean is usually quite accessible.
Do it right away.
Yeah, if you're gonna do this now, because this will put us over probably. But you're welcome to reach out to me, and I try to be.
Come up with your phone.
You should be able to get it off that. Yeah.
Oh, you can do it off
I think so. Yeah, I think so, unless it's not high enough resolution. But just finalizing. So I want to say thank you to the faculty, Dr. Rick. He's a long way from home. He's been here 2 weeks now, and he's been here. This is your 5th time. So he's a surgeon with immense organization and detailed and knowledgeable, but humble heart. And his big quality is he has a big heart for Ethiopia, and we're gonna use what he offers to the maximum, and we'll establish an upper extremity department in Ethiopia where everybody gets excellent service and good teaching for the residents. And then I also to thank Dr. Dr. Tim Dunn. He's always there where the training is. He gives everything he can, provides everything he can for a training for residents and for faculties in Ethiopia. So please give round of applause for him. And I want to also thank you for coming and giving your time for education. Please give yourself a round of applause. So let me go over some of, I want to thank ESOT for helping us. You know, it's not easy to put out this thing together and being there for us. So ESOT is the way forward, and we also want to thank ESOT for helping us organizing this course. And it's also, we were also thinking where to do it, but Alert made it so easy. We just had a 5 or 10 minutes discussion with our admin assistant of Alert, and they just provided us the space and everything. So I want to thank Alert Hospital for doing this. Dr. Khalid has played a big role in organizing this. He was behind the scene, but did a very excellent job organizing this. Please thank Dr. Khalid. Binyam, the chief resident from Blackline, has done a lot organizing and putting the course on a webcam. It's not easy, so please thank Binyam for us. Last but not the least, Pioneer sponsoring us a tea break, and not only sponsoring us, but Pioneer is known for their quality imaging, and now they have brought a new product, photo emission CT scan for a whole body scan. So we also want to thank Pioneer for being there for Ethiopian Orthopedics. So I want to say a few words about future. You know, the future in orthopedics is, you know, just it's getting better every year. So the way forward is education and taking small steps in the right direction. And the other thing I want to say is it needs a team effort. We cannot do it alone. So let's come together under ESOT and do it together the right way to improve our orthopedic care in Ethiopia. And finally, I will invite ESOT President Dr. Galatao to provide a certificate and do a closing remarks.
This is the way like how the leaders are coming. Sami, like he's not only a surgeon, he becomes. And the other thing, like I will appreciate your dedication, Dr. Anderson, Dr. Rick, and team. Like it's very hard job. Like imagine how coming from US all the way Sodo and here to teach you guys like from your day-to-day activity. And from his family, like it's very tough. Like for example, today, like my boy was like asking 3-4 times, "Are you today also going home, going work, something like that?" You know, like it's very tough. But this one is like he's doing like a great job for us. You know, like in the name of our patients, like you are giving something for this young generation. Definitely, they will implement on their day-to-day activity. So I will thank you, like, in the name of our patients. Thank you. So as Sami say, like, our orthopedic training care is increasing time and time. Like, we are like almost shooting up like rockets. That's very nice. So we have to work together. We have to, you know, when you have this type of chance, we have to grip. You know, we shouldn't like refrain back. Like every resident or every surgeon expected to have a chance to take part in this type of meetings. So unless we learn, unless we see something, we will not change our practice. This is the way we change our practice. And this is the way how we help our patients. So thank you very much for coming, everyone. And thank you again for our faculty, esteemed faculties, Dr. Anderson and Rick and the team. So hopefully we'll see a best care in Ethiopia in future. Definitely we'll have upper extremity surgeons soon. Thank you very much for coming again.
So we have a certificate for participants. Dr. Khalil has it. Please take it.